Good morning, folks. If you could all please just take your seats. And welcome to the Amphitheatre Vavo of the Université de Tours, and to the second Infectious Diseases and One Health Day. I'm Patrick Leonard, and I'll be taking you through our first session of the day. Now, a little bit about IDO for those unfamiliar at this far. So we come together here in Tours in September to bring together both the commencing and the graduating Infectious Diseases and One Health Masters classes. And along the way, we like to bring along a few professionals and masters of the One Health art and science to guide the way and to be exemplars for all of our students and inspiration. Just a little bit of housekeeping. I'm sure you've all become a little bit familiar, but we'll be hosting all of our talks here in the amphitheatre. If you could all please be seated before the start times. We've given a little bit of breathing room for most of the presentations. As academics, we tend to go on a little bit longer, particularly with questions. If you could all please enter through the door that you've come through today, but during the coffee breaks and lunch, we'll try to get you to go through the exit that way, just to minimize kerfuffle around the AV area. And also the bathrooms are, as you leave, if you leave that way, down the stairs and to your left as you re-enter the building. And yes, coffee will be served downstairs. Our ushers will guide you. You can recognize them with their white fairy caps, as exemplified there. And our lunch will also be arranged. We'll get you to follow the ushers along to the lunch run, to the arranged lunch. And in your tote bags, you should find all the necessary provisions to take your notes and see the program that we've laid out for you today, with a variety of speakers, some flash talks, and poster presentations from our students, past and present and future, and also a few other sponsored talks and prizes. So also, we'd like to extend thanks to our sponsors. So our principal supporting partner, the Fédération de Recherche Infectiologie in the Centre-Val de Loire, but also to our other principal sponsors, the European Federation of Immunological Societies, as well as Zoetis and Roche. And so, without further ado, I'll bring on our first speaker from the Ferry, Denny Brandt.
Thank you. So, good morning, everyone. As said, my name is Denis Brand, and I'm the co-director of the Fédération of Research in Infectious Diseases, call it FERI, and also professor of microbiology at Tours University. The other co-director of the FERI is Nathalie Winter, who is a research director at INRAE, and who will present this federation after my speech. Something very important is that this symposium has been organized by the alumni of the IDO Erasmus Mundus Master Program and the FERI management team, including our project manager Morgane de Laverne, with the support of the IDO Master Program coordinator Stéphanie Germont, and the administrative coordinator of the program, Frédéric Dersac. And the FERI also provided most of the funding. I thank, of course, all the people of the organizing committee for their commitment in this event, and many thanks also to the University of Tours for making this amphitheater called the Varvou Amphitheater available today, and also for the audiovisual coverage of the symposium under the supervision of Jean-Philippe Le Tourneur and his team. It's of course a great honor for us to welcome you all here for this second symposium on infectious diseases and One Health in Tours. And I hope that this event will provide the opportunity for all the attendees to meet with the representatives of renowned organizations or agencies working in the field of One Health, zoonosis, and infectious disease, even on snake venoms, We'll see that today. I thank, on behalf of the organizing committee, the chairwoman and chairman of the various sessions and the guest speakers for their help to build this ambitious scientific program. It's also the second time that we have such a meeting organized with the strong contribution of the IDO students or former students. And I would like to thank here Patrick Lénart, but also Dera Ortiz and Mariana Geoffroy Lopez, who were by far the most involved in the organization, and will be also chairing session. I want to thank also other students who were involved in this organization: René Coury, Babi Naznine, Shivangi Shukla, Juliette Offel, Denise Dubois, and Camélia Nani. Before starting, I would like also to say a few words about the IDO program. This program is funded by the European Education and Culture Executive Agency since 2017 and involves 3 core partners: the Universitat Autonoma of Barcelona. My German is not very good, so I'm going to do my best. The Medizinische Hochschule Hannover, MHH, and the University of Tours. And we kept also a very good relationship with our former core and now associate partner, the University of Edinburgh, with the Rosling Institute. It's obvious that the institutions of the European Union and other nations bear a special responsibility in developing educational curricula, particularly at the university level, curricula integrating human, veterinary, and ecosystem health. And these institutions have a duty to provide the academic organizations or research institutes of less developed nations with comprehensive support in the various disciplines relevant to One Health. Another important point is that the trend to institutionalize One Health in the EU is another important issue, and its implementation in member states must be considered carefully to prevent shortage of highly skilled staff in the field of infectious disease and One Health. And the IDO program has taken these needs carefully into account for several years now. Now about the curricula of the IDO program, for instance, during the time spent in partner institution as part of the mobility program, IDO students acquire multidisciplinary skills related to One Health in the context of strong scientific backbone and a unique knowledge of various sociocultural settings. They also receive detailed training in research with a focus on biorisk management, animal models and alternatives, innovative therapies with transactional medicine, and they are thus able to meet the growing need for highly skilled professionals worldwide. The IDO student of the 2021-23, so the just graduated, and 2023-2025 intakes are present with many alumni, and they will of course have the opportunity to tell you more about the program and their expectations. So thank you very much for your attention, and I let the floor to Nathalie Winter for a short presentation of our Federation of Research in Infectious Disease.
Ça marche ça? Comment ça marche ça? Il faut double-cliquer, qu'est-ce qu'il faut faire? Voilà. Okay. So it's a real pleasure to welcome you to this day. And as Denis just said, I will give a few words about the FERI, Fédération de Recherche en Infectiologie. which is sponsored mainly by our région, Centre Val de Loire. So we are actually a network, a scientific network, to bring together all the components of research on infectious diseases. And our really important point is that we foster the concept of the One Health. So all of you obviously are aware of this concept, but I will again give a few words about this. So as you know, we need this view of the One Health because of this global increase of infectious diseases. And as you know, 60% of new infections in humans originate from the animal world. And there is also a very strong role of the environment and all the changes that we bring to the environment in these emerging diseases. So we need to work together to cope with these new infections that are coming, as for example, the recent pandemics of the COVID-19 just showed us. So there is, to bring all this together, there is a concept which is called the One Health concept, une seule santé in French. And so we need to work together. And this is why we have here assembled this scientific network, which is called the FERI. And we foster this concept in research and education at higher level by helping labs and also universities to collaborate and develop projects together to tackle the issue of infectious disease of humans and animals and take also, of course, the role of the environment. And the FERI is also here to foster interaction between the academic world and the industrial world, private sector, to help developing new solutions to control infectious disease under this One Health concept. So why here in Région Centre? Well, it's because we have here in our region a very long history of academic research on infectious diseases. And when I talk about the région, it's mainly in terms of cities, big cities which are involved. It's Tours, Orléans, but also we have Angers, Limoges, and Poitiers, which are not in the real in the region, in the administrative region itself, but still are very involved in this FERI and very active. So in fact, altogether today, we have 16 research labs involved in this network, participating to the FERI, and helping to bring together people on basic research for new therapeutic solutions to help solving public health issues. And the asset of our region is because we have all these labs in very close environments, and also we have animal facilities and technological platforms to help these research activities. And for example, we have here the PFIE, which is one of the largest facility to have infection of animals in large animals. But we have also all kinds of different platforms here close to us. So this is why we decided to bring this FERI together. So we foster 4 research axes. One is to work on the virulence mechanisms. So we're here tackling the issues of epidemiology, emergence of new pathogens. We're also working on host pathogen interactions and actually trying to understand how hosts and pathogens co-evolve together. We work also on the physiopathology of infectious diseases, and this is also where the technological platform really help us to understand these issues. And we also have a 4th axis on therapies and resistance, because as you know, resistance to antibiotics, antivirals, antiemetics is also a very important issue under the One Health concept. So what kind of actions do we support with this FERI? Well, we have a workshop each year, a 2 days workshop, and this is where we bring all together the community, we present our data, and we give also a little bit of support to new research projects. Of course, we also support the intake of the internships, for the master students. And we also support incoming and outgoing mobility for scientists. And actually, we help people to travel all over the world to bring this concept of the One Health. So actually, I think the ferry was quite instrumental in the beginning of the IDO project because we gave the financial support for the first manager for the application to the EU. All the scientists who are gathered in the IDO, in the ferry, are involved in teaching in the IDO master. We also support internships. And we also give some support to this very important day, which is the IDO day. So this is why we are really happy again to welcome you. So not only the present attendees, but also all the attendees online, because thanks to Jean-Philippe Le Tourneur and his team, we are in direct line on YouTube, and we have a lot of attendees there. And so we wish you all a very, very fruitful day with a lot of discussions, because we need you, the young generations, to bring this One Health concept to the reality, because as you know, this is a beautiful concept on the paper, but it is a very challenging one to bring all these communities to work together, and so for a better world and for tackling this new infectious disease which are coming every day. So welcome everyone.
Thank you, Denny and Natalie. So, without any further ado, we'll begin session one. Now, session one is all about ecosystems under global changes, the influence of environment, on systems that infectious diseases and we ourselves find ourselves within. Now, our keynote speaker for this session is Dr. Osman Dar, who is both a Fellow of the Royal College of Physicians in Edinburgh and the Faculty of Public Health in London. He specialises in public health medicine and communicable disease control. Not only that, he's the director of the Global Health Programme's One Health project at Chatham House in London. And on top of that, he's also based at the UK's Health Security Agency, where he's a medical consultant in global public health, where he supports low and middle income countries to be able to develop their programs to the international health regulation standards and core capacities, I should say. And he's also been a co-chair to the One Health High-Level Expert Panel, the OHH-LEP, bit of a mouthful, which advises the quadripartite forces, which you might be quite familiar with, the WHO, the OIE, the FAO, and the UNEP, on their development of global One Health strategies. And so he's right at that nexus of being able to implement policy that directly influences how we control infectious diseases and zoonosis at that human, animal, and environmental interface. So without any further ado, please welcome Dr. Osman Dar.
So hopefully that comes up. Okay, thank you everyone. It's really great to be here. I'm gonna just get straight into this because I've got quite a few slides to go through, but I'm gonna rattle through them. We're gonna cover a little bit of the political interface between science and evidence-based policy or implementation. But we're also going to cover a little bit about the history of both One Health as well as what we call health security. So at the end, there may be time for a little bit of science, but this is mostly politics and that policy interface. So just as a little bit about of background to what I'm going to be talking about, I'm also going to be talking about this Lancet series that we did. So we did a Lancet series on One Health and global health security that was published earlier this year. It's 4 papers plus a special piece by OLEP, that One Health high-level expert panel on One Health, as well as their theory of change. So we'll talk a little bit about that. And just let me talk to you a little bit about what OLEP does. The OLEP, obviously there's a number of these challenges at the human-animal environmental interface, all of which I'm sure you're well aware of. And so it was convened and brought together in 2021, sort of in the middle of the pandemic. What happened was the FAO, OIE, and WHO collaboration was being assessed. They'd been working for 10 years together, sort of under the One Health concept, but there wasn't the kind of cooperation, collaboration, joint capacity building that would have been intended by that initial setup that had been organized by the different UN agencies. And at the Paris Peace Forum, a number of member states got together and said, we need something additional to get these agencies to work better together in this One Health sort of way. And so OLEP was introduced as an idea, a One Health high-level expert panel, an independent panel that will support the 4 agencies work better together on any issues at the human-animal environmental interface. But of course, the main focus at the time was the pandemic, and of course, so the primary mandate or the initial mandate for OLEP was around emerging infectious diseases and diseases with pandemic potential. Just moving on from that. So what was OLEP's mission? It was initially to provide policy-relevant scientific assessments and advice at that human-animal ecosystem interface. And as I was saying, the initial focus was meant to be emerging infections and diseases with pandemic potential. But this can expand and extend to other issues at that human-animal ecosystem interface. And we'll talk a little bit about those. So how was OLEP's work sort of divided? One was around One Health implementation, the principles, what the definition is, what do we mean by One Health? And that's the group that I was co-chairing and leading. And what are sort of operational examples of how you turn theory into practice? There's another group looking at creating a One Health inventory, all the kinds of collaborations and capacity building initiatives that are going on worldwide. They were mapping tools, what are all the One Health tools that are used by countries at the national level, assessment tools, capacity building tools. There was a third group working on surveillance, and then there's a fourth group working on the drivers for spillover. What are they? Proximal drivers, distal drivers of spillover events, and that's a very important group as well, because they were focused very much on what we mean by prevention. So if you look at the spectrum of issues across health security, they're usually divided into prevention, preparedness, detection and response, and then recovery. So that's the health emergency sort of spectrum. But what is it that we mean by prevention? Is it primary prevention just of disease in humans, or is it prevention of spillover? So all of these things definitionally have huge implications when you're then thinking about funding, asking member states to put investment into A, B, or C. So that again needed a lot of work around and building consensus. The other important element was that we wanted to make sure that the group of experts represents all the 3 sectors, animals, humans, environment, and that there's a balance between perspectives from high-income countries and low and middle-income countries. It's very important that there's good geographical spread, as well as, of course, having an appropriate gender balance. That's also sort of key, and so that reflects where the group is from. But I wanted to then just move on to what we mean by then health security. So what is health security, right? And where does this concept come from? When did health become securitized, and what are the implications of that? And this goes back to the sort of 19th century, really. We had a series of global epidemics which kickstarted about 13 of these international sanitary conferences. But this is in the colonial period where the great sort of colonial powers would come together and try to liaise and coordinate on how they manage their colonies. And it's very interesting that the first 4 diseases, for a long time, the focus was up until 1969, the first iteration of the international health regulations, the focus was cholera, plague, smallpox, and yellow fever. And so, you know, why you would think, why are these just these 4 diseases? Cholera, because they kept having repeated outbreaks in India in particular. Yellow fever, because the Americans were expanding into Central and Southern America. They were building the Panama Canal. Their officers kept getting yellow fever, so they were worried about that. So I think there was then this tension evolving between the reason why the whole movement around health security was being put together, the focus of the investments, and what is in the interests, and in whose interests are these decisions being made. And I think that has sort of carried through to the present day, and it's reflected in sort of, especially if you look at if you break down where the funding actually goes when you look at health security issues, why certain things get invested in, why there's a focus on particular issues, you start to see, you know, the pattern emerge. Like, who is it? The so-called recipients of all this aid and all this benefit that are whose priorities are being addressed, or is it you know, the donors? And that's a very interesting angle to explore. And I think it's so some of you might know Patrick Manson is the founder of the London School of Hygiene and Tropical Medicine, and this is at the launch of the London School of Hygiene. These are a few excerpts from his speech then. William Wilson Hunter is a Scottish historian who was writing about the cholera plagues in the 19th and 20th century, early 20th century. And I think, again, this sort of reflects what the attitudes were, the prevailing attitudes at the time. And, you know, some might argue that we still find that in some of our politics today. And I think that's, you know, one of the issues when it comes to generating consensus at the global level, why we see the tensions that we see, right? So many of you will have been aware of all the issues we were having around access to vaccines, access to medical countermeasures during the COVID-19 pandemic. Obviously, poorer countries were struggling to get any kind of access. If you look at what happened in Europe and North America, they were able to borrow. Can anyone guess how much money they were able to borrow to respond to the COVID-19 pandemic over the first year and a half? Just shout out a number. A lot. Just any number. $19 trillion. Just the US and North America. And how much of that do you think they thought, oh, let's put aside this much for low and middle income countries? So this is a thing that funded everyone's furlough, everyone's, you know, social security. And this is money that they're borrowing at 0%, 0 to, you know, 0.5% interest rate. Whereas if it's a low middle income country, they have to borrow at 5%, 7% interest rate, and, you know, they were getting 1 billion, 2 billion. So you can see the difference in the scale of what's possible, and you'd see the difference in the scale of the inequality. So I think it just, you know, I know we're a scientific community, but it's good to understand that wider context that you're sort of operating in. So anyways, this is the IHR, as I was sort of saying. It was based on the International Sanitary Conventions, first established the first version was published in 1969. It focused on those 4 diseases. And I think this is, again, you know, it's at that design state that you started to see the problems, because it was more about protecting trade, borders, and colonies rather than protecting health of the peoples in those settings. And so the focus and the investment and the impetus behind it was always around those elements, and that's really what's affected it throughout. And then we had revisions in 1995 after the Ebola outbreak in DRC. Then obviously the major revision was after the SARS-1 outbreak out of China in 2003, and that's the version we have now, the 2005 version of the International Health Regulations. That's being reviewed again now, and that's why I bring it up, because it's an important process that we're part of. that we're providing some input into how those revisions happen, so that we're thinking about things a little bit more equitably. We're thinking about, the greater good. I know in France, everywhere else, the people talk about solidarity, but there's the talk of solidarity, and then there's the actual implementation and what it means in practice, and they're often two very different things. So again, as I was saying, the IHR work along that spectrum of health security, so from prevention to detection to response, and then the recovery. And then every country has a IHR national focal point, and there's legal obligations around reporting diseases and building the capacities to then prevent, detect, and respond to them. Initially, it was just around reporting and what happens at the borders, but that was then expanded after 2005 to look at core capacities that need to be built across all those systems. But again, you see, if you look at the bit in blue, that's what the initial focus was, and has sort of remained. Unnecessary interference with international trade and traffic and commerce, which is of course important, but it moves away slightly from protection of public health. Of course, a big issue has been that we're getting increasingly globalized, so the world is getting more and more interconnected. So it's quite silly, really, to think of yourself just as an island, even though we in the UK love to do that. But we are interconnected, and we're increasingly so. And I just wanted to show you how we do some of the work with advocacy with our colleagues outside of the health sector as well. So this is, for example, the UK's National Risk Register, the latest one. And if you look at it, 17 out of the 38 risks on the National Risk Register. So risk is calculated by impact versus the likelihood of something occurring. So it's a function of both those elements, the likely impact, but also the likelihood of it occurring. And 17 of the 38 are One Health type issues, either across environment or animal health or human health. And of course, the biggest ones are things, number 25, pandemics is right up there. So right next to large-scale CBRN attacks. CBRN is chemical, biological, radiological, or nuclear attack. So it's a very useful frame, the One Health frame, to make that wider argument to your political leadership around why it's important that you have these integrated approaches across sectors to deal with these kinds of threats to health, economy, trade, and then it's calculated by environmental damage, essential services, the impact on international relations, public perception, fatalities and human deaths, and economic impact. So there's a number of factors that go into then grading and gauging those risks on the national register. And the reason I raise it is because that then becomes part and parcel of international relations. So every country is thinking about it from their own perspective, their own set of risks, and that's what they want prioritized at the global level. That's where they want the investment going. And that might not align with, what's happening, for example, in hundreds of low-income countries. They have completely different priorities and completely different things they would want the investment focused on. And these are the sorts of One Health priorities that people do tend to look at. But of course, the things that a lot of us spend our careers working in, things like neglected endemic diseases, where a lot of the One Health evidence base actually resides around effectiveness, impact, cost effectiveness. Those never get invested in, those get ignored, right? We're always looking at the next emerging infection with pandemic potential, viral hemorrhagic fevers, things that we feel will be threats if they come to Northern Europe or to North America. And whereas those are not issues that are, affecting Chad or Central African Republic or whatever. So yet those countries are being asked to prioritize those things and put all their investment into that. So even the limited human resource that they have, the limited expertise that they have, are directed or funded to do work in areas which are not really national or endemic issues in those countries, right? And so that's why there was a lot of debate and discussion when we were coming up with the definition for One Health. There were over 40 definitions at the time, some narrow, some broad. We wanted something that was holistic. And one of the most painful things you can do is try and draft by draft by consensus, because every word has to be looked at, and everyone agonizes over every detail. But we got there in the end, and this is the sort of definition we came up with that the OIE, WHO, the UN Environmental Programme, and FAO have all agreed to. The important thing is that it's underpinned by a set of principles. These are published in PLOS Pathogens paper, but it's these principles that I think are really important. So there's equity between the sectors and the disciplines, there's parity, socio-political parity, including everyone's voice in it. So it's not just the interconnectedness between humans, animals, and the environment, it's also that the approach applies at different levels of society, right? So the inclusion of marginalized voices, there's this socio-ecological equilibrium, and that's recognizing that it's not just human outcomes that are of value. Animals, ecosystems have their own intrinsic value independent of humans. And so animal health outcomes, ecosystem or environmental health outcomes have to be part of the conversation. It can't just be about, okay, human health is going to be affected like this, and so that's why we all need to come together as three sectors to do this. If you want sustainability built into it, you have to look at things that are of primary concern to the animal health sector or the environmental sector to bring them along and bring those communities along with it. There's obviously the stewardship role that humans play as the apex species on the planet, and then there's the principles of transdisciplinarity, and that includes traditional forms of knowledge, indigenous knowledge. Not everything, not all the captured knowledge is in sort of medical textbooks. So textbooks of pathology, there's a lot of oral tradition, there's a lot of knowledge in indigenous societies and communities that are much more used to living in harmony with their ecosystems and environments, and it's important to try to capture all of that. So what did our papers show, and how are they organized? So the first paper looked at the evidence base for the application of One Health approaches to try and establish, okay, this is where the One Health approach works vis-a-vis unisectoral approaches or other types of approaches. And these are the areas where these are the types of issues where they work, and across that spectrum as well of prevention, detection, response, and recovery. Then paper 2 looked at, okay, so if this is the evidence base, where is funding and where are collaborations actually being focused? What are the geographical areas that are being focused on? Is it a needs-based focus? Is it a politics-based focus? What are the networks focusing on? What are the types of issues that are being invested in? So that looked at that. Is it matching the evidence base? Presumably you invest based on an evidence base, but obviously there's a disconnect when you see what's presented in the papers. Then the third was, okay, we're doing all this investment, but how are we monitoring it and how are we evaluating whether or not our investments are achieving what they want? So our country's building capacities, what are the outcomes from all this, these millions and billions of dollars that go into building health security capacities? And then the fourth looked at the political and the governance architecture of One Health, but also health security globally and regionally. What is there in terms of the legal responsibilities of governments? What arrangements are there in place to enforce implementation? So that was a big issue around the pandemic recently. Is there some mechanism to enforce countries to report when there's an outbreak? What's the carrot? What's the stick? And is it by consensus? So what are the levers we have? So that's what that looked at. And just very briefly, paper 1, you're all scientists, so you can go away and read the papers in depth, but paper 1 found some very interesting results that as sort of I was suggesting in the beginning. A lot of the evidence base is around endemic and neglected diseases, but a lot of the investment is around emerging diseases or those of pandemic potential. And so there's some very good recommendations around what is the kind of science that's needed, what's further research that's needed, and where that what the current research and evidence shows, both in terms of cost effectiveness, but also strengthening that link or delineating the link between those animals, humans, and environmental, sort of the ecosystems side of it. Paper 2 looked at all those networks and mapping. Was a global network analysis. Where are all the One Health networks operating around the world? What countries, what regions, what issues do they focus on? So again, as you can see, they sort of, since 2015, since after the Ebola outbreak, a lot of the focus was emerging infections and novel pathogens and antimicrobial resistance. Because again, I was part of the process from the UK, but the UK was one of the big champions around AMR in particular. So our chief medical officer, Sally Davis, it was a legacy issue for her as well, so she's been a real champion for AMR. But in low-income countries, if you look at AMR, it's not so much resistance that's the issue for them. It's access to an effective antimicrobial, whether it's around quality issues, substandards, counterfeits. They're having huge issues with that. It's not the resistance. For us in Europe or in North America, what impedes our access is that we're starting to see resistant infections. Yes, you have resistant infections in low and middle income country settings, but actually millions of people don't even have access to an antibiotic or an antimicrobial in the first place. So if you go to somebody in a village and tell them, your issue should be AMR, they look at you like you're crazy. We don't have clean water and sanitation. You want us to wash our hands. We don't have the water to wash our hands. Well, most of the infections we're dying from are sensitive infections anyways. We never had access to an antimicrobial there. So why should our issue be, training staff up to be able to do resistance monitoring? Is that where we should be putting our limited resources? So it's not that AMR is not an issue, but how you frame it and what you then choose to invest in does become an issue. Paper 3 then looked at those, as I was saying, those assessment tools. And again, one of the big things it found was that the environmental sector wasn't being well represented in the assessments. The capacities relevant to those were not being assessed. The social and political and cultural dimensions of health security outbreak response weren't being adequately addressed by the assessment. So, that trust deficit that we saw, for example, in North America or in some parts of Western Europe, where people didn't trust their governments, didn't trust the advice, none of those elements were being properly assessed in these IHR health security capacity assessments. And so all of those are sort of starting to be addressed now in the new versions of the tools that are coming out. And then finally, the governance one was around hard and soft levers, and we found that things like the World Trade Organization, where you've got some economic levers and you can punish countries with sanctions and that kind of thing, tended to be stronger than what you find in health, which are usually by consensus, by trying to coax and cajole a country into doing the right thing. But there was also a lot of work done there around regional approaches and making sure that regional capacities are sufficiently robust and strong. So for example, if we're looking at Africa, having independent development, manufacturing capacity around diagnostics of vaccines and therapeutics, having the governance and the regulatory framework to be able to do that, in putting that in kind of investment in to be able to do that. That was seen as very important in that, and there's some very good recommendations around some of that. And of course, integrating the environmental sector more into what happens at the global level was seen as key, and that was one of the big changes that happened sort of last year. UNEP, the UN Environmental Program, joined the tripartite, so it's now a quadripartite, and together they launched a One Health Joint Plan of Action. So there's now a 5-year framework that all member states have sort of signed up to that will support One Health relevant capacity building across a range of different issues, which we'll just very briefly touch on. So the way we supported this whole process was to develop a theory of change. So first we looked at sort of the anthropogenic influences on health, and we'll just list some of those out. That was looked at through that One Health lens, looking at all those different principles. And then we looked at that ecosystem of different initiatives and issues and things that are happening at the global level, at the regional level, and then we developed these pathways of change. So pathways of change include sort of the policy advocacy and financing side of One Health. There's the organizational development, the implementation, and the sectoral integration across the different sectors and agencies. And then there's the stuff that we're all more familiar with as scientists, the data, the evidence, the educational element of it, and the knowledge exchange between the sectors as well. I mean, I'm amazed every time I come to something. I'm supposedly some sort of One Health expert, but I learn so much from the other sectors, and it's a humbling experience, because you come, like I have a human health medical background, but there's so much amazing, beautiful science in the environmental sector and the animal health sector that you just learn from every time. So it's a joy to come to these kinds of events because you learn so much. And those are then framed around high-level actions. You look at the risks and assumptions and barriers to implementing and achieving those consistently. So there's a risk management approach to it. And then you develop a set of outcomes that eventually lead to that sort of impact statement. These are all the sort of environmental challenges, societal challenges, animal health challenges that we sort of identified as OLEP as a group. And this includes things like, digital innovation, the advance of AI, for example. What does it mean for the One Health workforce if you've got everybody doing, and what does it mean in education? I'm sure you're doing all your assignments using ChatGPT now, so don't say you're not. So what does that do, and how does that impact how we create the next generation of the One Health workforce, right? And it was very important to be quite specific about some of the medium and long-term outcomes. So look at number 3 on medium-term outcomes: the improved stewardship and equitable access to diagnostics, humans, vaccines, therapeutics, and technologies for the control of human, animal, and plant diseases. So now when we're talking about things like the Pandemic Accord, the international treaty that's being negotiated, initially the discussion on countermeasures was simply restricted to human countermeasures, vaccines, diagnostics, therapeutics. And that's where the contention still is. So high-income countries in Europe and North America, they want to protect their patents and their IP, and they don't want to be forced to share technology, even in an emergency where there's millions of people dying. Doesn't matter, we still want to make a profit. So there are these kinds of tensions and issues. Low-income countries are saying, there's this other thing called TRIPS, the Trade-Related Intellectual Property System, which allows you to bypass these kinds of IP in an emergency, where you can declare an emergency and then create generic versions of whatever the product is. But there are huge issues with trying to invoke that, because you get hit by trade sanctions, you get hit by bilateral sanctions by wealthy countries. So there are those kinds of issues that are then at play, and we wanted to expand that conversation to animal health countermeasures, but also environmental countermeasures, and that's where the debate is now taking place, because we're sort of trying to adopt that One Health approach to it. Anyways, these are just some of those medium and long-term outcomes, but I just wanted to end by saying that, so this is that One Health Joint Plan of Action. It's focused on these 6 different pillars, integrating the environment into the One Health approach. There's obviously antimicrobial resistance, but antimicrobial resistance is being thought of more broadly. So that includes pesticide resistance, insecticide resistance, the other elements of resistance that are perhaps relevant to the animal and environmental sectors. There is the endemic disease bit, the emerging infections bit, and then food safety and food security, the nutrition security part of it as well, which is often ignored as one of the issues. Finally, all of this is then going to go into and feed into the discussions around the Pandemic Accord. And the other last thing I'll say is that there's also the World Bank Pandemic Fund now. So there's countries are able to access grant-based funding. It's not just loans, it's grant-based funding. And as a technical advisory panel for that, we made sure that One Health was embedded in the core criteria for countries getting the funding. So the first call was for $400 million. It's a $2 billion fund. It was focused on workforce surveillance and lab systems. But we made sure that the scoring for countries, you'd score higher if you were demonstrating a One Health approach. So not just saying that we're going to use a One Health approach, but actually showing that the funding is going to the animal health sector, the environmental sector. You're creating a coordination platform between the 3 sectors. So that's how we scored them, and that's how that funding has been allocated. But thank you. Sorry if I went over a little bit, but that's it. Thanks.
We do have time for a couple quick questions, if anyone has any. Yeah. Just raise your hand and we'll bring the microphone around. But maybe I can just poach one while we're here. So you've touched on sort of the systemic inequities really between the low and middle income countries and these like big powers and financial powers. And what do you see as like the biggest implementable change really that could stop like the big powers from being able to just come in and quash, particularly with like you touched on TRIPS and the like.
So I think it's not. It sometimes comes across as adversarial. It doesn't necessarily need to be. We've got a lot more in common than we have that separates us. So firstly, I think it's important to preface what I'm saying with that. There's a lot that we agree on and there's consensus around. And I think the wealthier, bigger powers know that it's in their own interests, long-term interests, to be for the world to be more equitable, to have less of these inequalities, because it leads to a more stable world and planet. But I think to address your point, the regionalization approach does help. So for example, the establishment of the Africa CDC, Centers for Disease Control under the African Union. Africa now has its own public health agency, sort of like the ECDC, it's a similar kind of model. And you get an economies of scale through that, creating your own internal market that will have a regulator for medical products, for example. Those kinds of things, I think, will help progress. Progress matters, and it allows you to have more of an equal seat at the table, because you don't want to go into a place where you're then your access to funding is like we were talking about, $1 or $2 billion, and they're talking in trillions of dollars. It's completely different, scale. And I think the other thing that's good in that space is that people are understanding the legal ramifications of these kinds of issues, and you've got lots of NGOs now which provide international legal aid and support to some of the lower income countries. Because what happens in these organizations is actually that a high income country will come with 50 lawyers, and you've got like one generic lawyer that's not even a specialist in that area coming and representing 3 or 4 countries. And so, forum shopping in the international legal system is also one way of addressing these things.
Yeah. You have a question down here, yeah.
Thank you for your speech. The establishment of the HOLEP is a very nice step to advise the quadripartite. Do you think that now we have to go further and to establish something like IPCC intergovernmental panel to have even more impact on the action developed by the different countries?
I think that would be a brilliant idea, and it would democratize and socialize and increase the inclusion of the scientific community in particular in some of the decision making, some of the advice, and make sure that whatever is being advised is really the best science, the best research out there. The trouble is funding that mechanism at the moment. So member states have to come forward, and WHO can't fund it itself, or OAE or IFIC can't fund it itself. It has to be a UN process. And funding that is, I think, the issue. But I think that is the intention of the desire of both OLEP as well as the quadripartite, that they go in that direction. But you have to have willing funders, and that's always been the issue.
Alrighty, we might wrap it up and move on to the next speaker. Please join me in thanking Dr. Dar. So our next speaker for the session is Dr. Aline van Utrecht. So she works at the European Environmental Agency as a climate and health expert. And she looks at the climate impacts on human health and well-being and the resilience of our sort of systems around that. She also coordinates the European Climate and Health Observatory. That they work by collecting and providing access to evidence and supporting resources that surround environmental influences on health. And prior to that, she's also worked as a researcher at KU Leuven and at Australia's CSIRO and the Flemish Institute of Technological Research, as well as the FAO, focusing on climate change impacts and resilience of these diverse systems and sectors. She'll be joining us virtually, so please join me in welcoming Aline van Utrecht.
Good morning from Copenhagen. Thank you for the introduction. I hope you can hear me well. Yes? Okay. I'm delighted to join you here, unfortunately not in person, but if technology is with us, it should be fine this way. And I will be talking indeed about the link between climate change and health, and specifically infectious diseases. And as the previous speaker, Osmar Dar, already highlighted in his explanation about One Health concept, environment, and for me specifically, climate change is important to look at. Just to give you a bit of context, I work for the European Environment Agency, which is an independent agency of the European Union. What we do is we analyze and assess existing information, and we provide additional information based on these analyses to the European member states for them to be able to implement, develop, monitor policies, environmental policies specifically. And we aim to be an interface between science and policy. Here on the screen, you can see the 32 member states that we have in Europe. The European Union member states are these, but also including Norway and Switzerland, for example, and 6 collaborating or cooperating countries in the Western Balkans. I coordinate European Climate and Health Observatory, which is a partnership between several organizations, and the aim is to support Europe to become more resilient and adapt to the impacts of climate change on human health. And we do that by providing resources, all kinds of information, data, tools, but also examples of how to respond to the impacts of climate change on human health. The European Environment Agency is managing the observatory on a day-to-day basis, but the management, we do that in collaboration with European Commission, and more specifically the Directorate General for Climate Action, DG Klima, and the Directorate General for Health, DG Sante. Apart from us, we work together with many organizations, among which ECDC, the European Center for Disease Control and Prevention, EFSA, the European Food Safety Authority, but also Copernicus, INFI, the Association of National Public Health Institutes, and ASFER, the Association of Schools for Public Health in the European region, which you may know. So it's not us only who's developing knowledge, it's collaborative effort of these different organizations. We do focus on infectious diseases. The observatory was launched in 2021, so about 2 years ago. It was part of the European climate law actually to erect the observatory because we have to protect human health against the impacts of climate change. And we work with biannual work plans. And our first work plan focused on heat, which is a well-recognized impact of climate change now, but also on infectious diseases, for which there is an emerging attention in the context of climate change. And this work plan resulted in a report that we published in November of last year. And that was focusing on heat and infectious diseases, and it describes different climatic hazards, what happens to temperature, precipitation in different regions of Europe, what are the impacts specifically for human health and well-being. We also looked at who are the vulnerable groups, children, people in poor households, but also workers that are more exposed to these climatic hazards and health risks. And apart from the impacts, we also focus very much on what are solutions in policy and in practice, because we really have to respond to what is happening. This year and next year's work plan focus on water, so everything that is related to flooding, but also droughts, water quantity, as well as water quality. That's the thematic focus of this work year and work plan. Also on capacity building, so making sure that health professionals are aware of climatic impacts and how they can respond to it or prevent impacts, health impacts. And we continue our focus on infectious diseases. And this should lead to a new report to be published in the spring of next year that looks at water. And again, here we look at the impacts, but also at the solutions. And flooding and droughts are also important factors that contribute to the emergence and spread of infectious diseases. So part of it will certainly focus also on infectious diseases. Why do we want to look at the link between climate change and infectious diseases? Several diseases are sensitive to climate, either to temperature or moisture in the air, or availability of water for certain vector-borne diseases, for example. So they are sensitive to climate. So that's known in science. Other diseases, like the ones listed below in this list, like giardiasis and leptospirosis, they're sensitive to floods. So there is also a clear link with climate change, because the climate is expected to lead to global warming. It's not only expected, it's already happening, but also precipitation events become more extreme, and flooding, as you all know, is also a consequence of climate change. So leading to distribution and spread of infectious diseases. In 2022, a study by Mora in Nature Climate Change analyzed what the impact of climate change and different factors of climate change, so both increases in temperature as well as changes in precipitation and air moisture, air humidity, as well as flooding, how this affected different pathogenic diseases. And the conclusion was that for the majority of them, climate change is aggravating the situation and the risk for human health. There's a limited amount of diseases for which climate change doesn't seem to have a big impact, and even a smaller amount where climate change would lead to decreases in the emergence of these diseases. So, but the majority is aggravated by climate change. And we summarized this information in our 2022 report, which you can consult on our website. And here is an example of how we summarize this information for a number of viral diseases like chikungunya and dengue that are affected by temperature increases. So when the temperature rises, these the vectors that transmit these diseases, they can become more active, they can establish better in the European region, but also the vectoral capacity and the virulence of the virus itself can increase. It's not only related to temperature, but also to precipitation. The mosquitoes that are transmitting these diseases, they thrive well in areas where there is, well, some flooding, where they have breeding sites. The numbers that you see here on the right side of the pictograms are the number of studies that found on the left side aggravating effect of climate change versus on the right side effects that climate change was decreasing the disease risk. So you see that the number of studies that found these aggravating effects are much higher. And then you still have on the far right the modes of transmissions. Here, this slide is focusing on the vector-borne diseases. So you see the mosquitoes and the ticks. Another reason for focusing on the link between climate change and infectious diseases is the fact that it's an emerging threat in Europe. So the number of local transmitted dengue cases in 2022 in France was very high. On the right side, you see the number of autochthonous cases between 2010 and 2022, and you see a large rise, a large peak in 2022. The blue color is for dengue cases. In gray, you see chikungunya, and in pink, Zika. And the map that you can also see there indicates where these local cases happen. So that's southern France. So this means there is a real problem, and part of it is due to the fact that the vector of dengue, Aedes albopictus, the tiger mosquito that you see on the left side, gets established in larger parts of Europe, among which France. And our partner ECDC has some information maps about that. Another reason for focusing on the link is that climate change impacts on human health, or thought by several hospital doctors and nurses to be a large problem. This survey was done among hospital doctors and nurses in France, Germany, and the UK, and the emergence of infectious diseases through the rise of disease vectors was one of the impacts that I saw as most important in the next 10 years. So what do we try to do with the observatory? As in our reports, we look at impact, so we collate information, knowledge, but also data and indicators that can be used to evaluate the trends in the past, but also assess the risks for the future. That's about impact. We also look at responses, so we do policy analysis and we support the exchange of solutions to combat these changes and these increased risks. So let's have a look at the impacts. So one source of information that we provide is fact sheets about infectious diseases that are affected by climatic changes. We provide information on the notification rate. This is the ECDC data for different countries in Europe. And we also focus very much on this climate sensitivity. So fact sheets about diseases, you can find it from several organizations, of course, but our focus on climate is what makes it different from other information that you maybe find. So we look at climatic suitability for both the pathogen as well as for the vector, if it's a vector-borne disease. So how does temperature and moisture conditions affect growth, reproduction, and the activity of the pathogens? We look also at, or we give information about seasonality. When do these diseases peak? Mostly in Europe, that's in summer, because then it's warmer, of course, and the pathogens are more active or virulent. And we also provide information about the expected impacts of climatic changes. So in 20 or in 10 to 20 and years' time, as well as towards the end of the century, what can we expect based on scientific literature? Apart from these knowledge pages, we also have a lot of data indicators. This one, for example, looks at changes in the basic reproduction rate for chikungunya transmitted by Aedes mosquitoes. So looking at the expected number of secondary infections from one infected person. And here you see the change between a period in the past, 51 to 85, to a period that is nearer to us. And the red colors indicate that there is a positive change, so meaning that the reproduction rate becomes higher. So this is tracking the evolution, what is happening in Europe. And we do this in collaboration with the Lancet Countdown in Europe. Another example is the percentage suitable coastline area for non-cholera Vibrio outbreaks. On the left side, you see the period 2003 to 2005. On the right side, you see the situation for more recent situation, 2018 to 2020. And the darker the red colors are, the more percentage of the coastline is suitable for Vibrio. And this indicator, also developed together with the Lancet Countdown Europe, looks at temperature and salinity and assesses the suitability of the coast for Vibrio. So this is also the risk factor that we assess, but we also look at the future. Here you see maps showing the climatic suitability index for Aedes albopictus, so the tiger mosquito that can transmit, among others, dengue and chikungunya. On the left side, you see the situation in the past until 2000, and on the right side, and the middle and the right side, you see the near and the far future. The red colors indicate a high climatic suitability. Climatic suitability here is based on temperature and precipitation factors, and the blue colors indicate a low climatic suitability. And you see that towards the future, that more and more countries within Europe become suitable for the a factor of these diseases for Aedes albopictus. What you also see is that Southern Europe, which is like the Portugal and parts of Italy, that they are red at the moment, but that they become more blue, and that is probably due to the fact that they will face more droughts, and in that case, the mosquito finds less breeding sites. So in this case, climate change can be beneficial, but you see the spread towards Western and Northern Europe, Central and Eastern Europe as well, actually. So that's not good news. So then let's focus on the responses as well. As I said, we do policy and responses in practice, or solutions in practice. In terms of policy analysis, we assessed national policies of all our member states and looked at national adaptation strategies here in blue, as well as national health strategies here in green, to look to assess whether they mention infectious diseases, and indeed it's one of the aspects that is mentioned the most. So there is awareness about the disease. We also developed for the different countries fact sheets on what is available in their policies. So if you're interested in that, certainly have a look at our website. Here is an overview map of the different countries, and the colors indicate, so if it's a pink color versus a gray color. If it's pink, it means that it's mentioned, infectious diseases are mentioned in the national adaptation policies. If it's gray, then in the national health policies. And then if it's hatched, then it's mentioned in both adaptation and health policies. We also look at the preparatory measures that are mentioned in these policies. So again, in blue, it's adaptation policies or strategies against climate change. In green, we look at the health strategies, and there we see that monitoring and surveillance or early warning systems are the measures that are mostly mentioned as responses to increased risk, but also awareness raising campaigns are important. A lot of it is about research, awareness, governance, so non-physical infrastructure, maybe also assessing what the risk is, but it would be good if there would be even more focus on really tackling the existence problem of emerging or increasing risk of infectious diseases due to climate change. And then next to the policy responses, there are, of course, also responses in practice. And what we aim to do with the observatory is to inspire different countries or authorities with examples of solutions elsewhere. So we have, for example, several examples of surveillance systems, for example, for tick-borne encephalitis in Czechia, where people are warned, among others, about the activity of ticks, and then tick activity is surveyed, as well as infections with encephalitis. We also have the surveillance system for local dengue transmission in France, which was unfortunately thoroughly tested last summer. We also have some examples of citizen science projects whereby citizens and the general population is involved in order to make them more aware of certain risks and how they can protect themselves against these infectious diseases. Maybe something that I forgot to say in the beginning, because my presentation was very much focused on climate change, and climate change is certainly a factor that is aggravating the spread of infectious diseases, but it's only one factor, of course, in that is leading to this evolution. Also trade, hygienic measures, travel are important factors, and they play together with climatic changes, leading to the increasing numbers of infections that we that we see in Europe. Okay, this was what I wanted to tell you. If possible, I'm happy to take some questions.
Please join me in thanking Dr. Van Utrecht. Do we have any questions from the audience? Please just raise your hand and we'll bring you around the microphone. If not, I'll lead with one. Dr. Van Utrecht, in sort of the wake of only really accelerating climate change and the changes to all of these diverse environments, what do you see as kind of the biggest obstacle in terms of implementing these knowledge bases, particularly to other countries and regions that might not that might be quite interrelated and yet maybe overlooked?
Yeah, thank you for that question. One thing that we see is that working in silos is still an obstacle for tackling this problem. So climate change adaptation is, for certain sectors, it's okay, it's accepted and people are working on it, but in the health sector, for example, the knowledge about climate change and what the risks are is not yet very widespread. And we had the Budapest conference in July this year and the Budapest Declaration, where the linkages between environment and climate and biodiversity and health are recognized by several member states. So something is changing for sure, but really the integration of tackling climate change and its consequences into health policies is certainly something that can be improved. When it comes to different regions, of course, there are differences in awareness and also the means to react to this, but this is a transboundary problem, so we cannot stop vectors nor diseases at the boundaries. So a transboundary collaboration and to strengthen all member states in Europe and outside of Europe, of course, is important. You cannot just limit yourself to working on measures within your country boundaries.
Thank you. Do we have any questions from the audience? If not, please join me in thanking Dr. Van Utrecht.
Thank you.
So our next speaker is Dr. Marie-Cécile Ploy, who is the Professor of Microbiology at the Faculty of Medicine at Limoges Teaching Hospital, as well as where she heads up the Bacteriology and Virology Hygiene Department. She's also the director of the INSERM ResinFit Research Unit on antimicrobials, and part of numerous committees on antimicrobial resistance at the national level. She's also been a coordinator of the European Joint Actions on Antimicrobial Resistance and Healthcare-Associated Infections, and part of the management board of the JPIAMR, as well as vice chair of their steering committee. And her research mostly addresses the mechanisms and dynamics on the spread of antimicrobial resistance, and looking at the role of SOS response in antibiotic resistance acquisition and risk assessment of its dissemination into the environment. Please join me in welcoming Dr. Ploy.
Thank you very much for the kind introduction, and thank you very much to the IDO Organization Committee for inviting me. So I will keep some slides because most of the, not most, but some very important key points have been already addressed in the previous talk. And as I have too many slides, it would be nice. So just to show you that, but it has already been said that antimicrobial resistance is a One Health paradigm. So as you know, antibiotic resistance has a huge impact. But first of all, I think it's very important to say that antimicrobials are wonderful drugs. They save every day millions of lives. But however, due to different causes, including the inappropriate or excessive use of antibiotics or antimicrobials. Now we are faced to the problem of antimicrobial resistance all around the world. And this antimicrobial resistance caused over 1.3 million deaths in the world every year. And if you have a look on this slide, you can see that, yes, can you see? No, anyway. Here, you can see here that some countries and the low and middle income countries paid a heavy price to the attributable or associated death, to the death associated or attributable to antimicrobial resistance. And there is a predicted increase of this rate death by 2025 in different parts of the world. So this is the burden in human health, but what about animal health? So we have data about the burden in human health, but what is so surprising is that even if 40% of the value of global agriculture is constituted by production animals, and that 1 in 5 people depend on production animals for their income and livelihood, we have only very scarce data on AMR burden in animals. And in companion animals, we have different studies, different publications showing the prevalence of multi-drug resistance in companion animals. But it's not exactly burden study about the burden. And about the livestock, we do not have data about livestock. Only data is that there is a World Bank report in 2017 estimated that by 2050, the global livestock production will fall by 3 to 8% each year due to antimicrobial resistance, and that the IAMR impact scenario estimates 11% loss in the livestock production, with the highest decline expected in low-income countries. And for global burden, antimicrobial resistance could increase animal mortality rates by 1%, which is an equivalent loss of $13 billion in livestock value, and also AMR results in a gross domestic product shortfall of $3 trillion annually, and push 24 million more people into extreme poverty. And it is very important because we know very well, and you and Osmar have introduced that there is a link between AMR and the condition of life. And AMR is closely related to poverty, lack of fast sanitation, access to safe water, poor hygiene, and pollution. And low and lower middle income countries are the worst affected by antimicrobial resistance. And also antimicrobial resistance exacerbates inequities within societies and groups, some groups including women, refugees, migrant children, people working in agriculture, in the health sector, and those living in poverty may be particularly vulnerable and more exposed in drug-resistant bacteria. So it was in the UNEP report, so the United Environment Programme, in their 2023 report. And it is also known that around 60% of domestic and industrial wastewater globally is released in the environment without or with only little treatment. And as you know, most of the drugs, and especially antibiotics, are mainly produced in China and India. And in these countries, there is no or very little legislation about the release of the drug into the environment. And so we have drugs, but we have also, when it is antibiotic, we have also resistant genes and resistant bacteria going and selected into the environment due to this very high proportion of pharmaceutical residues in the river, downstream the industries. But it's very, and you can show it in this figure, that's how complex are the environment relationships in transmission and spread of AMR. And the UNEP made a score, a pollution score based on the water discharge sources against the connection to available wastewater treatment infrastructure. And you can see that in some country, when it is more red, even near black, there is a very high pollution score. That means that there is poor treatment of wastewater. I won't go into climate change because it has been showed in the two previous talk, and there is a direct consequence of climate change on the release of antimicrobial resistance with increased runoff due to increase of precipitation, and also to the movement of population and overcrowded urban areas. The climate change has also an effect on the biodiversity loss and then increase of some pathogens and a risk to transmission to human. And we do not have to forget the role of wildlife. I was amazed when I saw this figure in this publication, this report. This is the pathway of the migration of wildlife birds, and it's quite impressive, and some publications have already shown the role of seagulls in the transmission of antimicrobial resistance. And how this condition, there is resistance in human, resistance in animal, resistance in wildlife, resistance in the environment. So that creates all the conditions for the transmission of resistant bacteria or transfer of resistant genes between bacteria, because bacteria, they do not know borders, not borders of ecosystem, not borders of countries, and so they can exchange very easily genes. And even if the bacteria from the environment or the animal ecosystem are not really fit to implement in the human gut, but however, you can have some hotspot, and some scientists call also hotspot, but also hot moments, where there can be an exchange between these bacteria from the environment or the animal ecosystem, and then you can have transfer from genetic elements, virulence or resistant genes, and you can have in human a very resistance, a very virulent pathogens. And this has already happened. For example, this is the successful CTXM story. CTXM is a mechanism of resistance, is an extended spectrum beta-lactamase that codes for resistance to many beta-lactams. So, and usually the bacteria are multi-resistant. And actually, the progenitor of these genes is in the chromosome of a bacteria which is absolutely not pathogenic, a bacteria living in the soil, Crivera scorbata. And during the evolution, this gene has been captured by different genetic elements to be present in a very broad host range plasmid in E. coli, which is a bacteria in the gut. And so you can imagine then the transmission. And now CTXM is a worldwide mechanism of resistance. We have it everywhere. So it happened, and it has been shown for other mechanisms of resistance. And probably, actually, in the environment, we have probably the future superbugs. So I'm sure I'm convinced you about the complexity of the network of the antibiotic resistance. And that means that to tackle antimicrobial resistance, we cannot work without a One Health approach. So because AMR is a significant threat to human, animal health, food security, economic development, and equity within society, we need a coordinated One Health approach to tackle antimicrobial resistance. So I will not go into detail about the One Health approach because it has been very well defined by Nathalie. And this figure has been shown also by Osmar about the key point to promote a sustainable and healthy future within the One Health approach. And to my opinion, there are 5 main pillars to tackle antimicrobial resistance: surveillance, behavior change, research, education and awareness, and the political agenda. So what about surveillance? For human health, we have different structure to monitor antimicrobial resistance at national level in some countries and also at global level. You see here the GLASS report, and you have here the country involved in the monitoring of either antimicrobial consumption or antimicrobial resistance, or both. And you have also some joint surveillance by ECDC and WHO about antimicrobial resistance in Europe. For animal health, once again, it's more complicated. We do not have really, we have data for the food-producing animals, but they are not diseased animals. And there is this recent paper showing also the trends for 2020 to 2030. And you see that they showed that whatever the region of the world, the trends will increase in all this region about the antimicrobial use in food-producing animals, depending also with a higher score in some part of the world. But we have no data in diseased animal. So in the previous joint action, the European Joint Action on Antimicrobial Resistance, which was launched from 2017 to 2021, we have launched the EARS VET network. Probably you know the EARS NET network is surveillance of AMR in human health. So we have launched the EARS VET network. It's surveillance of AMR in diseased animal. And we will continue in the next joint action to extend this network. And why it is so important to survey? I agree with you that in some part of the world, maybe it seems not relevant because there are so many difficulties about the sanitation, access to water. But I do believe that if you monitor, you can show evidence-based data to the policymaker and push them to take decision not only for specific bacterial transmission, but as AMR is a global problem, if you are able to show the high burden of antimicrobial resistance in a country, and also give all the causes, including the lack of sanitation, the lack of access to water, you can help the decision maker to take actions at the ground level. But it is not so easy, and I have a question for you. I take the French example because I know it very well. In your opinion, how many network initiatives are doing surveillance of antimicrobial resistance or antimicrobial use in France, including the 3 sectors? Do you have any idea? 7? 2 or 3? 48. 48, and it has been recently published in Neural Surveillance. 48, and most of them working in silo. How to work in a One Health approach with so many siloed initiatives? It's amazing. So that's why we absolutely need to stop working in silos and to organize a One Health community on antimicrobial resistance, both at national level and also at global level. And that's what you have shown this morning. And at national level, in the French National Action Plan, there is money for research, but so far there was no money, no fundings for structuring the actions. And now, during the French Priority Program for Antimicrobial Resistance, within it there is money for the structure, and we have launched the PROMISE network is a professional community network on antimicrobial resistance, gathering all the existing professional network from human health, animal health, and we are building what we call the AMR-ENV, the network of environment with national agency on the environment, but also with around 20 research team to coordinate the action and to try, for example, to give data on the monitoring of AMR in the environment, because so far there is no indicator for which people agree on which one we have to use to survey resistance in the environments. So we are trying to organize that. There is another structure on a platform for omics data to share the data, and a network on human and social sciences. But the problem is that it's only a 3-year program. We have money for only 3 years. So 3 years is just the time to have people together, know each other, speak the same language, etc. So now my challenge for the next year is to find money to continue this PROMISE program. And it is important to have this sort of integrated surveillance. For example, this JACRA report is from EFSA, ECDC, and the European Medicine Agency. And they published, don't remember, maybe every 3 years, data with AMR consumption and resistance in animals. And why it is important to have such an integrated surveillance? Because there is direct connection. Here in this recent paper, you can see that, and I will be very short, when you increase the animal usage, you have an impact on resistance in human, and vice versa. If you increase human usage, antimicrobial usage in human, you increase resistance in animals. And we do not have to forget also the resistance in the environment. So there are some initiatives. The quadripartite established recently the technical group on integrated surveillance on antimicrobial use and resistance. There is an initiative which is called Tricycle by WHO, looking at the multi-drug resistance E. coli in the 3 sectors. And in the next joint action, 2024-2028, we will also implement an integrated surveillance in human, in animal, with the EARS VET network, and we will launch the EARS ENV network for environment at the European level. So what about behavior change? About antimicrobial stewardship. Antimicrobial stewardship is very important, and we have to do that also at One Health level. So the WHO has established a critical list, a list of critical antimicrobials for human medicine that are not allowed to be used in animal, to avoid resistance in human. The World Organization for Animal Health also edited a list of antibiotics of veterinary importance. But it's a good thing to have stewardship recommendation, but as you mentioned earlier, we have to have access to antibiotic and antibiotic of good quality, and it's still a challenge in some part of the world. Well, I will skip that point. And another harm of the behavior change is about infection prevention and control. Infection prevention and control is a critical cornerstone for the response to AMR. And for animal health, the key means are animal husbandry, biosecurity, and vaccination. What about research? For research, there are different initiatives. I can't detail everything. It has been mentioned, the GPI AMR is a joint programming initiative which is moving towards what is called at European level a partnership, the One Health AMR partnership. And it's a global coordination with 29 countries putting fundings together to organize calls and in the partnership capacity building, training, etc. And also the quadripartite has recently produced the One Health Priority Research Agenda for AMR with 5 pillars: transmission, integrated surveillance, interventions, behavior change, and economics and policy. Oops. About awareness and education, what it is important. In this study, there was an interview, first interview of experts on infectious disease and antimicrobial resistance, and they were asked what is the role of these factors, so human antimicrobial overuse, animal overuse, travel, suboptimal vaccination, etc. For the experts, all these factors are important in the relative contribution towards AMR. For the general public, only the main factors are human miss or overuse of antibiotics and animal, and the other factors are not considered as important. So that's why it's so important to aware and educate. And we have, there are different tools that you can use, and they are in open access to organize in your country program for awareness and education on AMR. And last but not least, the political agenda. It is very important to keep AMR at high level on the political agenda. I won't go into details, but for example, at global and European level, there have been different from 2015 with the tripartite Global Action Plan on AMR than the Council recommendation at European level. There have been different initiatives to push AMR high on the political agenda, and not only political declaration, but how to bridge the gap between declaration and action. And we have now the actual EU for Health program. And holds this plan, one of the main direction is to design and implement national action plans with a One Health approach, to join forces and to avoid duplicating our efforts. Why it is so important to have national action plan? Because in this recent paper focused in Latin America, you have the same figure than before. I mean, the mortality rate associated or attributable to AMR. And you have the different countries of Latin America. And for the country where the color is green, green means that the national action plan are published, but some of them are only developed, some of them are government approved, and some of them are government financed. And when it is, when it is purple, it is when the national action plan are maybe developed or government approved, but unpublished. And you see, this is very evident, the correlation between the mortality rate and the fact that you have a national action plan which is published and financed. So it is also very, very important to raise the voice on AMR at global level, and this question is always mentioned at the G7 or the G20 meetings, and in 2024 there will be the next General Assembly of the United Nations, and there will be a specific meeting on AMR. So it is very important that every country raise the voice, and in 2024 the presidency of Brazil will hold the presidency of the United Nations, and it is of the G20. And so this is very important, and it's a very good opportunity for Latin America to raise her voice on the burden of AMR. So just to conclude, I hope I convinced you about the absolutely need to work together to tackle AMR, and I really like this African quote: if you want to go fast, go alone. If you want to go far, go together. Thank you very much.
Yeah, we just have some time for some questions. Yes, just over there. Do we have the microphone? One moment.
Yeah, thank you. It's quite interesting, your talk. I actually don't have necessarily a question, but what you're talking about, 48 silos, so to say, unfortunately, that's rather common. Also, for any kind of monitoring, and as you said, also you have a 3-year project. This is also something which, unfortunately, is hampering all of this development. That's why I was thinking if I can ask our colleague Van Utrecht from the EEA. What the European strategy is, because they always finance projects, but they don't develop monitoring poles, and I think that's something which is needed. So this is just something where maybe this community should think on how to progress with this and how to or whom to talk to, and that's bringing me to my second comment, because in your last slide, what is actually missing? You put the UN, but what you are missing is actually putting IPBES, the Intergovernmental Panel for Biodiversity and Ecosystem Services, because that's something they might be interested in but not fully aware of, because they are going more on ecosystem services, but the AMRs are pretty much impacting on the ecosystem services, and they are quite accessible. So this is something where I think could be one option for us to put that a little bit forward.
Thank you very much for your comments. I fully agree with you. And I used to coordinate the joint action on antimicrobial resistance, the first one, and we coordinate the second one. We convinced the Commission to go further, because the first program was 4 million euros and the second program is 50 million euros. So I hope we will be able to have other and more initiative, and but not only initiative, but really concrete action for people. But I totally agree with you that the Commission asks us to not working in silo, etc. But even within the Commission, it's sometimes difficult because there are different initiatives on AMR, but sometimes launched by other DGs, and we are not aware, and it's difficult. And I totally agree with you about this example. And also there is another example on economic incentives to develop a new strategy or alternatives to antimicrobials. And so now after the pandemic, this is the DG era, which is working on that. So we're trying to make connection, but it's really it's really a challenge still. I agree with you.
Marie-Cécile, I have a question on, so you mentioned the restrictions that are imposed on the use of antibiotics in animal health, but this is fine to restrict AMR emergence and to keep antibiotics efficient for human diseases. But isn't there a risk that this will also be taken as a limit by professional of animal health and limit the development of new antimicrobials for animals? Because
Really, I don't think so. I was last week in Ecuador, invited by the World Organization on Animal Health. And there was a workshop dedicated to alternative to antimicrobials. And so the objective of the workshop were to discuss what are the main challenges to develop these antimicrobials. And the challenges that have been raised are not research and development. The first one was, probably at academic level, we do not discuss sufficiently with the private sector, the industries. But the main challenge that has been raised by all the veterinarians from all Latin Americans who were there was the legislation. Because, and also there is a lack about cost effectiveness study, cost benefit. Because it's in animal health, this is the farmer who pay for the drugs. And okay, we can maybe introduce new alternatives as phages, as microbiota, as immunomodulators, and whatever you want. But we have to be sure that there is a cost benefit, because if they pay an expensive price, but at the end they don't have the return on investment, I'm not sure they will use it. And also the legislation at national level is not clear. There is not really legislation for these new alternatives, and it's difficult to have quite impossible to have a worldwide legislation. So I think the challenge are more there than development.
Oh, we have another question? Okay, okay. Yeah, please join me in thanking Dr. Ploy. Yeah.
Thank you.
Now, I know you're all looking at your programs. We did have factored in a little coffee break for time. We've run a little bit over. You are welcome to go downstairs and grab a quick coffee if you'd like, and a quick little croissant. But we will probably push ahead in a couple of minutes with the next talk. So pretty much just grab a little drink and come back if you can. Yeah. Yes, please follow our usher with the white hats if you can. Alrighty, welcome back everybody. Please just take your seats and we'll get started with our next speaker. So our next speaker is Dr. Dirk Schmeller, whose research focuses on elucidating the links between global health changes, ecosystem degradation, and the risks to human and animal health that's brought about in mountain ecosystems. He's currently the AXA Chair for Functional Mountain Ecology, and he investigates global change effects in mountain freshwater ecosystems and pathogens. One of his principal explorations was his research in the Biodiversa Project, RACE, and the Belmont Forum Project, P3, on people, pollution, and pathogens, which I'm sure he's going to tell us all about. So please join me in welcoming Dr. Dirk Schmeller.
Thank you, Patrick. Thank you to everyone also for having invited me. And thanks also to Patrick to pronunciate my family name well, because if you don't make the Schmeller, it's not so nice. So let me bring you a little bit of ecology. Because what we heard so far is very One Health, and I'm more or less in between the two concepts of eco-health and One Health. And I will talk to you about health, mountains, and climate change. Why? Well, first of all, what you can see here, these are all the different mountains you can see. I know that there are many different nationalities in the room. All of you have their proper mountains. Well, maybe not in the Netherlands. But it's quite interesting to see how many mountains there are. And why are they important? Well, they are the water towers of the world. Without mountains, most of you would not have water. All the big rivers, the Rhone River, the Po, the Rhine, they would not exist without the mountains. And there are millions of people depending on them. So this is something which you need to keep in mind. And I'm not here talking about the bigger Asian mountains where we are getting almost to 1 billion people depending. But in general, dependence on mountains and waters from mountains is extremely high. At least half of humanity is depending on them. So how does the water get to the mountains? I mean, there are no people with buckets and bringing them up in the mountains. No, it's just, it's pure, almost physics. It's evaporation in the lowlands, and clouds are then pushed up the mountains where they cool down. And by cooling down, they can't keep that much water, so it's raining. So that's how the water gets up there. With all the different precipitation and then the runoffs. That's why we have those wonderful lakes. And we need to keep in mind that one of the Sustainable Development Goals of the United Nations is clean water and sanitation. And there are still billions of people around the world which don't have access to that. So this is kind of the framework in which I place my own work. And then you need to understand that mountains are quite impacted by many different things. Well, all of you have heard about glacier melt, so there are climate change impacts. There are also then human impacts, because exploitation of mountains is quite widespread. In France, we have pastoralism, we have tourism, and others. But this causes issues, which I will explain a little bit more. But those impacts, in combination, climate change and human impacts, have biological consequences. And these biological consequences lead to disruption of ecosystem functioning. And by that, ecosystem services are lost, and some of them are linked to pathogens. And this can have an impact on our health, on health of livestock, and health of wild animals. So this is something where we need to look into. You can have a look at this work, which comes from one of my projects. The chemical pollution in the Pyrenean Mountains has reached levels where we have a toxicity, acute toxicity, mainly driven by two molecules, diacinone and permethrin. So you need to imagine that these are remote mountain lakes. And we find pollutant levels high enough to kill crustaceans. It's not the perfect evidence from these. There's a certain variation between where there's low toxic risks and high toxic risks. But you can see in those with a high toxic risk, we have much less crustaceans. And I will explain to you why that is important. But let me continue in telling you, this is not just in the Pyrenees. When you review data around the world in different mountains, you find a plethora of different pollutants, molecules. And if you add them up, which is meant with mixture, you can see that in many different lakes, we have acute toxicity from chemical pollution. And you need to keep in mind that this is likely an underestimation because we are not able to detect all the different molecules. So we only can detect at the moment around 500, and there are thousands. So chemical pollution is one problem. Introduction of non-native species is another problem. Whom of you is aware of what kind of fish naturally occur in mountain lakes? None, that's the right answer. All of the fish are introduced in mountain lakes, especially in alpine lakes. How could they get there? I mean, there's cascades, but they are too high to jump up, so there's no way for them to naturally get there. So what they do in those mountain lakes is shown here, because they are the best predators for an aquatic system. They are adapted to this. So when you put fish in such a native system, they pull in all of the energy which is available in that mountain lake. So what they do is actually destroying the plankton here, and that gives then rise to possibilities of microorganisms and pathogens, which then have an impact on the health of, in my case, amphibians, but also of humans. And this is something which is very similar to what the pollution does, because the two have an impact on plankton and on crustaceans, which are filtering water. So these are huge, huge impacts. What we also can see, and this is a very recently accepted article, is an eutrophication. When you have a look at the biofilms and the development of biofilms, you can see that they are becoming bigger, that they are becoming more important, but it's mainly driven by an increase of cyanobacteria and the degrees of diatomies. Both of them are indicators of the ecosystem health, so to say. The more cyanobacteria you have, the less good is the health. And the reverse for diatomies. So diatomere usually occur in a functional, healthy system. So what I would like to draw your attention to is also the increase of toxigenic cyanobacteria. We are talking about toxigenic because this is done with meta-barcoding or meta-taxonomy, so we are not having all the ASVs and not all the information. But many of the genera we find are able to produce toxins, the cyanotoxins. They also are not very good for our own health and for that of livestock, because they can
even lead to the death. And this is what happened recently in the Pyrenees with a dog. So there are reports that the dog died after having ingested water from a lake. So why am I telling you all of this? Because impacts on mountain ranges around the world are very diverse. But what I gave you here is examples from the Pyrenees can be applied to any mountain range around the world. So what we do when we impact on the mountains like this, I mean, humans are kind of good in constructing machines, but they're simple. A human-made machine has a few components. When we talk about ecosystems, we talk about hundreds of thousands to millions of components, meaning different species and different elements. This is meant when I show you these. So imagine that each of these dots would be one species, and they would interact with each other. So when we are killing, leading to local extinction of those species, then those biological barriers which we see here are slowly vanishing. So what happens when we don't have all those interactions? Well, we open the door. We open the door for pathogens to get into an ecosystem. And if they find the right conditions, they will proliferate. The incidence will increase. The probability that infections occur based on that will increase. And this is something which is extremely important, and this is one of the big dangers of biodiversity loss. Because this can happen not only in mountain lakes, this can happen anywhere. And that's why I consider we are kids at the moment, playing with the environment, but not really understanding what we are doing to it and how we are impacting ourselves and our life support system by destructing what biodiversity gives to us. So how does that look in the real world? This is a lake in the Carpathians, which I was able to visit very recently. So when you have a look, you see the stones, very clear water, hardly any algae, or not visible for you on that photo anyway. This is a photo from a Pyrenean lake where there are fish inside. So you pretty easily see, well, first of all, the color is not the same. The French would say vert fluo, which is really what it is, especially when the sun is shining on it. And you can see lots of deposits of cyanobacteria. And this is something which is spreading. I mean, I'm roaming the Pyrenees since 2008, and many of my lakes, the ones I'm studying, have changed in a dramatic fashion over time. And when you keep that in mind, and all of the pollution and introduction I've shown you, then this is one example of research where I worked on a fungal pathogen infecting amphibians, Batrachiochytrium dentopartitis, or BD, because it's a little bit easier to pronunciate. And we clearly show that zooplankton is a biological barrier. But a zooplankton like this, you will likely only find in a healthy ecosystem. In an unhealthy ecosystem, most of the crustaceans and most of the rotifers are gone, and there's only the most resistant ones which maybe still be around. Well, in that case, most of those zoospores, they get through to the host. While if you have that biological barrier, there is few or none which can infect the amphibian host. So we are working currently on showing this also for human pathogens. I can't show you data at the moment, but it looks pretty much the same. So in an unhealthy ecosystem, you will see way more pathogens in different species, but also in abundance and proportion than in a healthy ecosystem, which is more stable. So this is increasing the probability of infection, and this also led us to develop what we call the disease pyramid. It's actually the result of a visit of Adeline Loyot, my colleague, and myself to a seminar where people kept on maltreating the disease triangle by putting in different axes and different names to the different axes, not seeing that actually what they are missing on is also all the microbiome components. It's microbiome within and on animals, so within our intestines, but also on the skin, but also in the environment. So this is something which is extremely important, because the disease, which is more or less here in the center, is the result of expression of those interactions between the host microbiome, the pathogen, and maybe the biofilm as a new entity, being a micro-ecosystem in an ecosystem. And this disease pyramid is something which we are only starting to comprehend because methodologies are not so good. And then the antimicrobial resistances, they will have a huge impact on it. This is something which then is part of the environment, which we need to keep in mind and need to elaborate and understand better. And the moment we have an disbalance in this system, well, we will have that disease expression. And this is not only for amphibians, this is for livestock, this is for humans, this is applicable to anyone. I've used it also to explain the COVID-19 pandemic. But with the COVID-19 pandemic, a lot of medical scientists, they don't talk about a pandemic, they call it a syndemic. Is that a new term for most of you? You know it or you don't know it? You don't know it. Okay. So well, we have what I was talking about, the ecosystem health with all the different components. This is something you had to look at during your studies or during your work. But what you need also to keep in mind is that the human environment is a little bit particular. What was shown with the COVID-19, particularly in the US, is that poor population which is already under more or less environmental stress, if that's due to a bad location of their apartments or houses, or if that's because they're using drugs or because they have bad food. All of this has an impact on us and on our metabolism and on our susceptibility for pathogens. So this is something which we need to keep in mind as well, that the human population has its own functioning, and this is why it's so important what Marie-Cécile also said. We need to understand that we work together in many different ways to really comprehend all of the different elements of our global life support system and the impacts on us in regard to disease outbreaks and in regard to risks or future risks. And this work I'm doing is really looking into the differences of climate change, because climate change can also have an impact on the pollution patterns, because we have more extreme events. By that we might have higher concentrations of pollutants raining down in mountain lakes at a certain moment, which might lead to higher toxicities and therefore a higher impact on the biodiversity. It will then impact on the microorganisms, on plankton, on other key species. It will reduce the species interactions, which are the center of all ecosystem functioning and the ecosystem services those ecosystems provide to us. And all of this will have an impact on water quality and on ecosystem health. So we are very close by looking into quite a range of the Sustainable Development Goals with this work because human health depends on it. Livestock, there's much livestock in the mountains. It will have an impact on our drinking water, food production. So these are things which we really need to keep in mind because biodiversity is central. But mountains are rather simple ecosystems because they are extreme environments. So they are much less biodiversity rich than what we have in lowlands. So losing one species in mountains might translate in losing 50 or 100 species in lowlands. So this is something where mountain ecosystems, even so they are vast, they are also very fragile. So the ecosystem services need to be taken into account. The global changes will have quite a range of different impacts on this system, and this will lead to an alteration of ecosystem functioning. This is something which I would like you to keep in mind when you look at mountains from now on, that whatever water you drink, most of it comes from a mountain, and if the source is not good, then what you drink will not be good neither. Just a little anecdote around this, because with this pollution work we have done, we were kind of convocated by the Agence de l'eau. How can that be? We don't find anything. And we said, well, but how do you sample? Well, we take a liter of water and we look what's in there. And I said, yeah, so what is your detection level of your machines? Oh, well, it's milligram per liter, microgram per liter, sorry. And I said, yeah, well, but we are on the nanogram scale. So you need to enrich. And if you don't enrich, you don't find it. And this is something where it's also an arms race between science and chemical industry to see who can detect what, but keep that in mind that it's always an underestimation. I'm talking quite a bit about things on my YouTube channel. You had also a little flyer in your pockets. There are French, mainly French, but also quite a few German and English movies, which you might like. And then particularly for the students, if you would want to understand a little bit more what a researcher's work is, my colleague has written a book on our endeavors and adventures, and it's quite interesting to look into this and understand that what the work looks like of a researcher, and also, yeah, how to not be blocked by a forest fire or reviving a newt, these kind of things. So with that, I thank you for your attention, and I'm open for your questions.
Do we have any questions? Just raise your hand.
Hello, Dr. Dirk. Thank you very much for your talk about, it was more focused on eco-health. And I'm linking it back to the comment you made to Marie-Cécile about like the ecosystem services linked to antimicrobial resistance. So I wonder, you talked about like climate change, but has your research team, or do you know like any research done on the detection of antimicrobial resistance in the microbiota of mountains? And if you have done that, like how do you have like any comments on how it's shaping like the microbiota and then like linked to the disruption of ecosystem services?
So, well, to put it out first, no, we haven't had a look on antimicrobial resistance.
Okay.
My research is already very vast.
Yeah, I know.
I do a lot of different things, and I'm not able to do yet more without collaboration.
Yeah.
But of course, if Marie-Cécile would want to have a look at certain samples,
yeah.
That's of course possible. So yeah, I mean, there are many different ways to look into. We also started recently a new collaboration looking on snails, because snails are also very good vectors for many different pathogens.
Yeah.
This is also something which we are looking into. So I'm looking for collaborators. I'm happy to give them samples, but I can't answer your question.
No, thank you. It was out of curiosity, just in case it had.
But that said, because antimicrobial resistance is often also linked to resistance to lead.
Yeah.
If I'm not wrong, so we are having ideas about the lead contents in our different lakes. So this could already be a first indication.
Okay, thank you very much.
Yeah, I believe Dr. Dar has a question. Yeah.
Thank you. That was a very insightful, illuminating presentation. I was interested by what you were saying about crustaceans, and then you just mentioned snails as well at the end, because we've been doing some work on schistosomiasis control, of course, and one of the things we find is that the prawn species that consume the snails, you see their levels fall, especially around dams and irrigation systems where they're using these pyrethroid type pesticides. And there's a real, it's a really interesting thing that we switched to pyrethroids because of organophosphate poisoning and the effects in humans. But now we're seeing schistosomiasis then increase in these areas where the prawn species die down. And one of the interesting things we're exploring is then the reintroduction of indigenous prawn species as a means of controlling the snail populations, because it helps you then address other outcomes, not just the human health outcomes from schisto, but also nutrition outcomes, livelihoods, gender inequalities if you get women to farm the prawn species. So it's very interesting to hear you talk about the crustaceans.
Yeah, no, this is exactly the idea behind. And what I didn't say is that the snails are very likely introduced together with fish. So if we would stop fish stocking, we might also stop the introduction of snails. But yeah, this is something where I will try to look into with a colleague from Perpignan to see how high the risks are in that regard in the mountain lakes. And yeah, I guess there will be some interesting results.
Yep. Oh, yeah, we have another one.
Darren Shaw, University of Edinburgh. A question about your disease pyramid.
Yeah.
You've pulled out host biome.
Yes.
I don't understand microbiome. I don't understand how the host microbiome impacts on the environment out with going via the host. So I don't understand how that's pulled out, because that's implying the host microbiome is acting directly on the environment, but it must go via the host because it's in the host or on the host.
So this is exactly a question I would have expected, and this is something where people have forget. I mean, most of us, we go on the loo, but animals don't do that. Yeah, so the host microbiome can have an impact, particularly, for example, amphibians. They have a very developed skin microbiome. So they are in direct interaction, and there are exchanges, and we can show that between the biofilm and the water. So there are interactions, and it's not an impact which we are showing. We are showing interactions in this pyramid. So it's not unidirectional. It's something which goes in both directions. And those exchanges and those interactions are definitely happening. Also, by simply pooing in the water, you're releasing your internal microbiome, and this will have an impact on the water microbiome and on biofilms. Go ahead. If you're not happy with the answer, then ask what you're not, or tell us what you're not happy about.
There's still an impact of the host, because the host is still impacting that microbiome if it's on the skin or it's the biofilm or if it's going through the digestive tract. It's that line from the host microbiome to the environment that you haven't quite convinced me about. I would expect to see a bit of host in between.
No, well, this is why it's a pyramid. You have, it's not, you can't look at only microbiome and the environment. You need to look at all of the different axes. And it's all of those different axes which are determining the disease result. It's not that you look, what's happening between the microbiome on the host and the environment. No, you need to have a look what's happening host, microbiome, pathogen, and environment. This is what's determining the outcome. And it's those interactions which we are capturing with the disease pyramid. I think your perception is very influenced by the disease triangle, but you need to get a little bit away from it.
With that, we might just move
There was
on.
one
So,
more question there.
we'll just invite you to take up with Dirk at lunch if we can. Okay? Yeah. Please join me in thanking Dr. Schmeller. Yeah. And with that, we move on to a bit more of a studenty element of our IDO day. We have our flash talks now, where our students will be presenting roughly 5-minute talks on their different disciplines that they've either working on during IDO or after. So first up, we have Emily Watts with in silico analysis of VI-positive Salmonella Dublin genomes.
Thank you. Good morning, everybody. So, yes, I'm going to speak about a small part of my PhD, which has been the in silico analysis of VI-positive Salmonella Dublin genomes. So, to go to the first obvious question, what is VI? So, it's a capsular polysaccharide which is found in Salmonella typhi, but is also occasionally found in Salmonella Dublin. It's encoded by these 10 genes at the top here. So, there's a regulator. There are 4 biosynthesis genes and 5 genes which are associated with export. And it's been studied and it's been found in literature to have various different virulence associated factors, which I've listed there. But historically, this has been researched using typhimurium, which does not naturally harbour the VI capsule. And then has also been researched in mouse models which don't naturally form a typhoid-like disease. So the Salmonella Dublin offers a natural microbe host model to study this further. So my PhD revolves around these 3 strains of Salmonella Dublin, which all harbour the VI capsule. So one of the things I did when I got into the lab was just to check that the VI was there. And as you can see on this agglutination, in 931 and 937, agglutination is lovely in there. And 934, it seems to have disappeared. So what I wanted to do was to study the genome and see if these has been excised or whether it was still there. So I did some long read and short read sequencing and formed hybrid assemblies. So this is just an example of the 937, came back in 3 nice contigs, the chromosome and these 2 different plasmids, and found that the VI genes are there in the one that is no longer expressing. So I thought I'd look a little bit further at the genome structures to see if there was a genomic explanation for this. And so I've just put an example over there. So we have 2 different genome structures seen within these 3 strains. So 931 shows a genome structure of a 1, which has these 7 elements all nicely in a line, with the VI locus just within segment 7. And 934 and 937 both show identical genome structures of an 8.66, again with the VI locus in segment 7. But as 934 and 937 are identical, that's not going to explain this lack of expression. So what is next? I've made some mutants of the 937 to look further into this, to see what's happening with each of the genes, and then also to look further into the expression. Considering the genes are there, the expression is not. We're going to start looking at whether RNA is being made. There is also a deletion in the first of the biosynthesis genes, so we're going to have a look into whether that might be responsible for this loss of expression. Whether genome structure affects expression level is something else that I'm going to start looking into, and then also to see about phenotypic analysis of the wild type strains versus these mutants that I've made. I do have a poster downstairs, so if you would like to speak any more about salmonella sequencing or anything else, please feel free to find me down there. So thank you very much.
Alrighty. I missed out on this before, but I should just remind you, we will be having a vote for the best flash talk and also the best poster presentation. The posters are set up downstairs in the coffee area, so please have a little look at them. We'll show you a QR code at the end that you can use to vote. Our next talk is Paulina Morales Ruiz on mapping interactions, a systems thinking perspective on One Health.
Hello, everyone. I am certain that many in today's audience are experts at observing and analyzing complex structures under a microscope. Today, however, I would like us to zoom out and look at a big picture. What do you see? Microplastics in the placenta is not a standalone event, but it is the consequence of a network of elements and interactions. Like infectious diseases, environmental problems grow, spread, evolve, and have very unintended consequences all over the world. In order to understand these problems and to tackle them, we need a holistic perspective. This is when systems thinking comes into play. And what is systems thinking? At its core, it's simple. A system is an ensemble of elements that are interconnected and they work together for a purpose. And what is thinking is the understanding of these interconnections. Systems thinking allows us to see the full iceberg and not just the tip. It allows us to see the forest and the trees. The concept of One Health is rooted in this. It is an affirmation that human, animal, and environmental health are interconnected in multiple ways. And a small twitch in one of the elements will certainly have a repercussion, sometimes not very early visible, in another one. With this interconnected mindset, let's dive deeper into a One Health problem. We use systems thinking to analyze the role of microplastics in One Health. We use secondary data and created a causal loop diagram, or CLD. This is a tool essential in systems mapping. Let's go through it. In brief, polystyrene and polyethylene microplastics became the miracle product in the 20th century. Versatile, durable, cheap, and hygienic, they were fast adopted by consumers from different sectors. And the plastic market grew, and the yearly use of plastic soared. However, with time, plastics ended up in the environment. This mostly due because of the single-use nature of them. And plastics did not degrade, but they broke down into minuscule particles, the microplastics. These tiny, insidious fragments became a sign of unintended consequences. They infiltrate our ecosystems. They reached water, soil, air, our plants and animals, and even our wombs. From a feedback perspective, one might think that given the possible bad health repercussions in humans, we're on the brink of discovering a new miracle product. However, public awareness, this led by scientific discovery, is now calling out with safer solutions. Diving deeper into this intricate narrative, we found that the interplay of microplastics with One Health is complex because plastics are part of the culture, social forms, and also in many economic ways. This is an example of plastics as part of the culture. Plastics also represent the livelihood for many people. And unfortunately, the shadow of plastic pollution disproportionately affects the lowest social classes, further intensifying human health inequities. To address multifaceted challenges like this one, we need a unified way of understanding and communicating these challenges. One of the most potent tools in any interdisciplinary endeavor is to have a common language, and systems thinking provides just that. Systems thinking brings together the expertise from different fields and shed light over unlinked patterns, long-term effects, and this can help to avoid unintended consequences. And we can reach way higher. At my team, Access to Medicine Research Center, we use a 5-step methodology to join systems thinking with policymaking. And how do we actually make sure that all the complexities of the world are put in our ideas? Well, we work together with stakeholders during the full process. First, we design the system. We encompass what's going to be part of our system. Then we choose, after a lot of studying, which aspects would be the most meaningful to change. We map, we model, and we validate, always hand-to-hand with stakeholders. Well, I've spoken about the challenges, the tools, and the methodologies, but what about the solutions? Currently, as we have seen, it's not enough to have isolated solutions. We need solutions that are sensitive, are informed, and that they are sustainable. And joining systems thinking with One Health paves the way for harmonized strategies that aim for human, animal, and environmental equity. We are in the time of innovations. We're in the business of solutions. But in order to actually be sustainable, we need to think broader, think differently, think in systems. Sometimes our challenges might look microscopic, but what solutions can we all create together? Thank you. Thank you very much.
Thank you, Paulina. Our next talk will be by Fernando Morales Calvo on the analysis of the role of coevolution between fungi of the Trichophyton genus and their various hosts by co-phylogenetic methods. Please welcome Fernando.
Good day, everyone. Well, I'll be talking to you about the analysis of the role of coevolution between fungi of the Trichophyton genus and their various hosts by co-phylogenetic methods that we are developing at the University of Costa Rica. Well, first of all, the fungal species, for everyone who have been here working with fungi, know the taxonomy could be a mess completely. And the taxonomy is based on the criteria of morphology, host, and recently the genetics. But the genetics come to the mycology world to say that we are giving different names to the same thing, to the same sequence of DNA. We are giving different names depending on which host we are getting the fungus of. Recent findings reveal that the presence of cryptic speciation is very important also. So we have the two opposite sides, where we are giving different names to the same and same name to different things. So we use the five-host rule that implies that the parasite phylogeny should reflect the host one. As long as we know, this is the first attempt to do coevolution analysis in fungi affecting human health. Right now, it's usually used on parasites, on bacteria, on viruses, and on fungal affecting mainly the vegetation. But this is the first one attempt to recreate on fungal affecting humans and other animals. And we also have that hairless skin has shown more prone to stronger clinical signs. So first of all, that gives us a sign that humans should play a very important stand on the infection of Trichophyton genus. So our results have that the phylogenetic congruence by the PACO, the Percusis analysis of phylogenetic congruence, shows exactly that humans have a very major role in the evolution of the Trichophyton genus, getting the main results of phylogenetic congruence. Even here in this little site where the phylogenetic congruence results so little, is the complex of the Trichophyton rubrum, that it's known to be a highly anthropophilic complex of the fungi. While on the other hand, the most probable reconstruction of the phylogenetic history of the genus gives us the idea that co-speciation was given on the early stages of evolution, while now what we are seeing most is the transfer of the dichotomies of the same fungi from animals to humans. And here is shown the duplication on the trichophyton rubrum complex that, as I said, is highly anthropophilic. So we are now having different species on this complex given to the duplication of these species, giving new species, and actually that's what we find as one of the main challenges on the mycology right now. So we stand that more molecular epidemiology surveillance is needed in mycology, as right now it's only limited mostly from human isolated fungi and to taxonomy markers like the ITS, but more molecular research on the proteins that are related to the interaction between the host and the fungi is really needed, as they will give us the exact and more precise information about the relationship between both of them. Also, the spillover by duplication and transfer could lead to more adverse phenotypes as the terbinafine-resistant trichophyton species that we are facing mainly in Europe and in India. And well, the public health policy needs to take into consideration the epidemiological surveillance of dermatophyte in humans and animals, as right now the most common way to diagnose these kind of diseases is mainly the isolation of the pathogen as itself and the identification by morphological structures. Thank you very much. That was the presentation, and I have the poster downstairs, so any comments, I will be, please be happy to reach me. Thank you.
Thank you, Fernando. Our next talk will be from Onskarat on glycosylceramide targeting ETD-151 defensin as an attractive antibotrytis scenario candidate. Please.
Hello. Fungal infections have been greatly neglected relative to other classes of infectious disease, despite their dramatic effects on human and plant health. In fact, they cause a high global rate or high global mortality rate and destroy yearly between 15 to 20% of the world's crops, threatening then the food security. These impacts are worsened by the resistance that fungal pathogens have developed to all the licensed antifungals in the worldwide. To overcome this situation, we need to promote the discovery of new antifungals. However, proposing a new drug is so challenging, since the drug should satisfy three main criteria. First, the drug should kill fungi without having toxic effects on human and plant cells, despite the classification of fungi as eukaryotes. Second, the drug should have a target that is highly conserved in fungi, to inhibit all fungi despite the diversity of fungi. And third, the drug should have a target that is with relevant biological roles in fungi. Thus, the probability of developing resistance will be unlikely. One of the promising targets of new antifungals is glycosylceramide, a glycolipid that is found in plasma membrane of eukaryotes. Interestingly, fungal glycosylceramides seem to answer and to satisfy to all the criteria that I have already mentioned. Why? Fungal glycosylceramide is a highly conserved target with a specific structure compared to mammals and plant cells, and is required for pathogenicity. One way to target fungal glycosylceramide are defensins. They are small cationic and disulfide-rich peptides. We can find them in some plants and insects, and their antifungal activity seems to be strongly dependent to their interaction with fungal glycosylceramide. My PhD thesis is about a 44 amino acid called ETD151, optimized from butterfly defensins. This peptide has a potential activity against yeasts and filamentous fungi, and without being cytotoxic, which make this peptide a potential candidate for crop protection and or therapeutic application. Particularly, we are interested in the activity of this peptide against Botrytis cinerea, one of the most problematic phytopathogenic fungi, and to understand the essential step of the mechanism at the molecular level. To do so, we first showed that the green labeled peptide here is preferentially localized in the plasma membrane, cell wall, and intracellular vesicles, cellular zones that are known to be rich in glycosylceramide. And also we showed that the peptide loses its activity against yeast mutant lacking glycosylceramide in their membrane compared to their wild-type species. So it means that not only glycosylceramide is the target membrane of our peptide, but also its presence in the membrane is crucial for its activity. So we believe that understanding the molecular interaction between the two partners is essential if we want to explore glycosylceramide targeting defensins as a new class of antifungals. So to do so, we isolated and chemical characterized the glycosylceramide from our fungi, Botrytis, and then incorporated into membrane model liposomes to mimic fungal membrane. And using different biophysical techniques such as thermophoresis, calorimetry, and NMR, we started to dissect the interaction between two partners by answering three main questions. What is the binding affinity of the peptide to its target? How this interaction happens, and which part of the peptide is implicated in the interaction. Finally, these key elements will help to a rational design of a new antifungals that specifically and effectively target fungal glycosylceramide either for human or agricultural use. Thank you.
Thank you, Hans. And we have just one final talk for you from this section, which was sent in as a virtual recording. This is from Amir Osman on Ehrlichia species in cattle from Somalia. Slight delay there.
My presentation will cover the introduction of the Ehrlichia, the objective of our study, material and method we used, and the result we uncovered so far. Ehrlichia are small, gram-negative, obligate intracellular tick-borne bacteria cause disease a wide range of animals, including human. These diseases caused by different Ehrlichia species, Ehrlichia ruminantium and Ehrlichia ministensis, have been identified as significant threat to the cattle industry. Somalia is a country located in the East Africa. a population around 16 million people. Is a livestock-dependent country. 60% of Somali community are nomadic. Livestock contributes about 40% of national gross domestic product. The current status of Ehrlichia infection in Somalia remains unknown. The aim of this study is to perform a comprehensive molecular survey for the detection of Ehrlichia species. A non-probabilistic convenience sampling was performed. A total of 131 EBTA blood samples were collected. Animals were submitted a visual inspection for the presence of ticks. Collected ticks were identified according to a morphological taxonomy case by Walker and Abanskovic using a stereo microscope. DNA were extracted from cattle blood and the ticks using commercial kits. DNA were submitted mammals indigenous gene for cattle and mitochondrial cysteine sRNA gene of ticks. Thereafter, cattle DNA samples were screened for Ehrlichia BSP gene. PCR positive samples were further submitted to serious PCR assays, GROL, 16 sRNA, and SOD-B genes. In the study, a total of 66 ticks were collected, resulting in a mean tick infestation rate of 2.2 ticks per animal. The predominant tick species identified among the collected specimens was Ribalacephalus procalis, which was 65%, followed by Amblyomma gema and Amblyomma dibibium. The species of Hyaloma was the lowest prevalence within the collected ticks, around 1.5%. We also collect nymphs. Here is some of the ticks we identified. 131 extracted DNA were successfully amplified indigenous gene. A selected DNA from ticks were successfully amplified 16 sRNA gene. Our preliminary data showed a total of 39 DNA were found positive for Ehrlichia species BSP gene. Subsequently, all positive samples were further tested for other genes. All 39 samples were positive for GROL gene, and 32 out of 39 positive samples were positive for 16 sRNA. Among the positive samples with strong bands for 16 sRNA and GROL gene were further tested SOD-B gene. 17 out of 19 were also positive for SOD-B gene. These findings indicate a significant prevalence of Ehrlichia species infection in cattle population study, with multiple genes confirming the presence of the pathogen. For further analysis, selected samples were sent for sequence. Partial nucleotide sequence of Ehrlichia BSB were submitted in a gene bank database. Sequence detect showed 81 to 97 percentage of identity of different Ehrlichia species previously detected in cattle, ticks, and bats from Brazil, USA. Surprisingly, sequence detected from SOD-B gene showed less than 90% identity of different Ehrlichia species previously detected in horse, human from Brazil, USA, Nicaragua, and Senegal. Surprisingly, Ehrlichia ruminantium, a pathogen known to be endemic in African cattle, was not detected among the sequences in our study. Currently, we are working a species-specific PCR assay for Ehrlichia ruminantium based on the PCS20 and MAPA1 genes. Furthermore, we are expanding our gene sequence effort to cover additional genes with the aim of establishing more comprehensive understanding of true prevalence of Ehrlichia ruminantium. To the best of our knowledge, this is the first study on molecular characterization of Ehrlichia species in cattle from Somalia. These findings will serve as a valuable baseline data, improving the overall health and productivity of livestock in the region. I would like to express my gratitude to FAPESC for their support in funding the project, as well as to CAPES for sponsoring my PhD study. Thank you all. Hello, good morning, and good afternoon all. I am Amir.
Over again there. All good. So that brings to the close our Flash Talk segment, and I'm just going to pull up another slide for you that has the voting system for both the Flash Talks and the posters. If you've already had a chance to check out the posters, then you can make up your mind and cast your votes as you like now. However, we do have time for that in the following coffee break after lunch, or as lunch is in a different building after you've finished, you can feel free to come back and admire the posters in the coffee room. There we go. If we can. Yes, so it's run through Menti, so you can scan that for the QR code, or go to the website and type in that code. We'll leave it up for a little bit there. Yeah, so you can feel free to cast your votes there for both your preferred Flash Talk and poster. We'll also put it up later as well, so you can have time to go through that in the next coffee break. And now we come to the last talk of session 1 from one of our primary sponsors, Zoetis. Dr. Sandra Ganis is the representative from there, and she will be talking to you today about the development of veterinary vaccines and insights for One Health approach. Please welcome Dr. Ganis.
Okay, well, first, thank you for having me here. And as it's been mentioned, I will be talking about the development of veterinary vaccines and insights of One Health approach. Vaccines, either human or animal, have been made a significant, sorry, I'm a little bit nervous, impact on public health in the last 250 years at least, by reducing the impact of infectious diseases and by herd immunity, by reducing the likelihood of microorganisms to be spread, as there are fewer animals or people susceptible, and also because vaccinated and diseased individuals are less infectious. Also, another important thing is that vaccines can help fight antibiotic resistance, as well, there are less needs of antibiotics because vaccinated animals are less prone to have secondary infections. Okay. What we consider that there are the 5 pillars of or elements for a successful program to develop a vaccines are to have worldwide surveillance programs, to have traditional and rational vaccine development, so to have the know-how of how to develop a vaccine, to have global research and development capabilities, to have regulatory affairs that can react quickly and accept new approaches, and to have flexible manufacturing capability. That's very important because you can develop a vaccine as fast as you can, but if you don't have a place where you can actually manufacture this vaccine, nothing is going to change. You have the vaccine, but no place to manufacture it. Well, I'm sure you are all aware of it, but just a little reminder, there are different types of vaccines. The first group is what is called conventional vaccines that are divided into inactivated and live attenuated vaccines. The inactivated vaccines are, well, they isolate the pathogen causing the disease or the toxin that is causing the disease, that are inactivated by traditional methods, and then they are actually mixed with the adjuvants. And they are usually injected through intramuscular or subcutaneous routes. They are widely used because they are quite safe, they're safe, and they are well accepted, and the regulatory pathways are very well known. On the other hand, live attenuated vaccines are the microorganisms that have been attenuated through passaging or chemical methods or other conventional approaches. And in this case, as these are live virus that it's inoculated to animals as vaccines, it's very, very important to make sure that there is no reversion to virulence, as the virus will replicate inside the animals. There are several types of administration routes, like injectable to spray or intranasal, drinking water or oral delivery. They are also widely used because first they are easy to administer and they have the advantage that sometimes they can be used for mass application through oral routes, for example. And the regulatory pathways are well known. Then there is a third type that is specific for veterinary vaccines, that there are the autogenous vaccines. In this case, they can only be prescribed by veterinarians, and only in the case that there are any other vaccine available or the one that is available has been proven to not be efficacious. The other group is the gene-modified vaccines, also inactivated or live, different types. It can be subunit vaccines, chimeric vaccines, like the ones used for porcine circovirus, for example, reverse genetics used for avian influenza, etc. The regulatory pathways are better known than the live gene-modified vaccines, but there is mixed acceptance. And in the case of live gene-modified vaccines, we have gene-deleted vector vaccines, like, for example, for MEREC in poultry, DNA or RNA vaccines. The regulation pathways are more complex, and again, there is mixed acceptance. I would like to explain the case of a new vaccine for Lyme disease. Lyme disease, it's found in dogs, but it's zoonotic. It can be also found in humans. And Lyme disease is caused by the bacteria called Borrelia burgdorferi. And this type of bacteria have many proteins, but we will focus on two. The outer surface proteins. There are two that are very important, the OSPA, that has only one type of serotype, and the OSPC, that is genetically diverse. It has more than 30 types of phenotypes. And Borrelia, it's capable of expressing or producing only one type of OSPC. How dogs get infected? Well, they get infected when a tick has a blood meal on them. And what is very important to know is that ticks can get infected at the same time by several different strains of Borrelia, meaning that they can have multiple OSPC types. Therefore, dogs can have multiple OSPC types too. The antibody response to OSPC is very specific. So we need antigens for all of them. So in order to develop a vaccine against Lyme disease, it's required to have antigens against OSPA and OSPC for optimal protection. And the vaccines that were on the market were only containing OSPA or OSPA with a single OSPC phenotype. But as I mentioned on my previous slide, both ticks and dogs can express several types of OSPC. So an effective vaccine must contain a wide variety of OSPC antigens for a broad protection. But a polyvalent vaccine against these multiple phenotypes is not feasible due to several reasons that are manufacturability, the cost of goods, too expensive, the antigen interference, and also safety issues due to an overload of proteins. Dogs would likely have an anaphylactic reaction to it. So it was decided to try a different approach at using chimerotypes as vaccines. So like the seven most typical OSPC found in dogs were selected, and then a chimerotype was produced. Basically, a chimerotype is a recombinant protein that in that case had the epitopes of these 7 types of OSPCs. And well, thanks to that, the chimerotype provided this solution, and it was able to produce a vaccine with OSPA, that it was not a problem, that was already fixed, and then the several OSPC antigens. So if we look at the future challenges in vaccine production, they are, well, vaccine coverage, as many of you have already mentioned. It's very important to be able to reach animals and, of course, children everywhere, not just in the primary countries. There are still no satisfactory vaccines against severe infectious diseases, like HIV on humans or African swine fever in pigs. There are emerging diseases that require a fast reaction. One example is avian influenza that's been happening this year. And there are still no vaccines for chronic diseases like cancer. So to face these objectives require an innovative approach in research and development, national regulations, new approaches into manufacturing facilities, and also in intellectual property systems that are more new approaches, basically. So in this graph, we basically have a representation on when a pathogen was linked to a disease. That will be the red point. And the blue point represents when a vaccine was licensed against this disease, in the US in this case. If we look at the typhoid fever, to have a vaccine, it took more than 200 years. But nowadays, we know that can be much faster if everybody works towards it. Like we have the example of the COVID vaccine that we all know that several vaccines were able to be developed in less than a year. So if we look into what it's needed, which are the efforts that should be done on research and development, we consider there are three main areas. So we have to continue to have investment in basic science and a multidisciplinary way across initiatives, especially on antigen selection and vaccine design. We need to understand pathogens. Someone already mentioned, I don't remember who, sorry, pathogen-host interactions, use neutralizing antibodies to discover protective antigens, use cross-protective antigens, and the use of chimerotypes. If we think about novel technologies and routes of administration, we should improve the adjuvant use, have alternative routes of immunization, like different routes like mucosal immunization, maybe direct vaginal immunization for, I don't know, metritis, for example, intradermal vaccination to target dendritic cells, and needle-free vaccination. Also, vaccine combinations will be good to reduce the use of needles. Finally, if we think of clinical studies and data interpretation, research in biomarkers for safety and efficacy prediction are needed, and the optimal use of animal models for human diseases. Okay, so there are certain animal diseases that fit human diseases very well. For example, the ferret model, it's considered the most suitable for clinical disease and pathology for human influenza viruses, and this is very well known. Camelids for MERS coronavirus. Here is a list of pig models for human diseases and sheep and cattle models, again, for human diseases. For example, if you want to study Helicobacter pylori, the best animal model that's there is neonatal piglets. Or if you want to study, I don't know, papillomavirus, adult cattle are the way to go. I'm not gonna explain you what is the One Health concept. You are all aware of it. But again, there are many organizations that work towards it. Some of them are very well known, like the World Health Organization, but there are others, like the IABS, that basically is an organization that tries to have standards towards how biological products needs to be produced, or others like the Jenner Institute or the Flanders vaccine that grant researchers in order to develop vaccines and to create different networks between them, so easier collaborations. And when the One Health comes into practice, again, COVID, in this case, many animal models were used in order to study the disease. They were used for pathogenesis studies, anti-infective studies, or preclinical vaccine studies. The World Health Organization was holding weekly meetings with experts committees to share information. Another example is the remdesivir. Remdesivir is a biopharmaceutical drug that it was originally used to treat cats with feline infectious peritonitis that it's caused by a coronavirus. Well, it was repurposed for SARS-CoV-2. And also vaccine development from an animal health perspective. There were some vaccines that were conceived as booster for COVID RNA vaccines. And just to finalize, some points to remember. The strategy for a rational vaccine development program is based in the 5 main pillars that I mentioned at the beginning of the talk. Vaccine innovation will face challenges that will need to be, they will need a creative approach in research and development, regulations, manufacturing, and intellectual property. And very, very important, that One Health cannot be a pandemic concept only. Thank you very much.
Thank you, Dr. Ganes. Yeah, if anyone has any questions, I'm sure you can take it up with her during the lunch break, which we've eaten a little bit into now. But with that, we'll call session 1 to a close. And the lunch today will be served at the Bio3 Institute, which is pretty much across the road, but it's a little bit difficult. So we do have a representative who'll be able to guide you if you just descend into the parking lot just behind us. Yeah. Yeah, and yeah, feel free to come back and check out the posters if you wrap up before 1:30 when we'll resume.
welcome back, everyone. Hope you had like a good lunch and that you did not eat that much because probably you would get sleepy. We still have a very interesting program. This year is like very complex, so we hope that you enjoyed like this second section of the whole event. So now we're moving on to the second session of the day, which is including some of the social aspects of infectious diseases. So usually like STEM is, tends to be in its own and doing some research, but some essential part that sometimes it's ignored or missing is the social sciences. So we can have a better design and implementation of strategies in the population. So we understand our population, the population that we're working with, and then how to implement more effectively these strategies. So without further ado, we will have our second actually keynote lecture, which is like the first lecture for this second session. And I would like to welcome Dr. Thierry Lefrançois. So Dr. Thierry is a General Inspector of Veterinary Public Health and has worked for over 20 years at CIRAD on the diagnosis, epidemiology, and control of tropical animal diseases, mainly with vector-borne diseases in Burkina Faso, Kenya, and Guadeloupe. His focus on research is on disease emergence and the development of interactions between research and surveillance in the framework or regional health networks in the South. He's currently the head of the Biological Systems Department, BIOS, at CIRAD, bringing together several research units. And he's currently member of the Committee for Monitoring and Anticipating Health Risk, COVARS, in support of the French government. So please welcome Dr. Thierry.
Hello. So thank you for the invitation, first of all. I'm very happy to be here. First time for me in tour, professionally at least, but for the wine, I came already several times. So yeah, I wanted to talk about the interaction between science and decision. And we had already a very nice talk this morning, and some of the things I want to develop will be a follow-up of the first talk, the first keynote. So first of all, One Health is not new in research, and you all know that One Health, even if the word was not used, the concept and the principle of One Health were already used at large during research study, especially when we were talking about animal reservoir of zoonotic diseases. Obviously, when you are working on vector-borne disease and the driver for emergence of vector-borne disease, obviously also when you are talking about zoonotic viral infection like rabies, and again when you are talking about antimicrobial resistance. So it's not new for research, but it's not always seen as a way to work. It's just in practical that it was already used, and it's not, and it has to be developed further than on the research. So the COVID-19 pandemic was initially, at least for the public, considered to be human diseases. And after a few months, some people and more people understood that coronavirus are not only viruses present in humans, but also in animals, and that COVID-19 was a zoonotic disease, one out of many and many, with more and more emergence during the last 10 years, 20 years, etc. So the consideration of this zoonotic origin led to some people working on how the pandemic was managed by the government and by the scientists. And we could consider that, in fact, the health system in France, in the world, in Europe or in the world, was not organized to have a One Health approach. Definitely not, because it was not able to make any prevention of the pandemic before emergence. It was not able to detect the circulation of the virus in animals. It was not able to detect the first cases in human. And it was not involved the One Health approach was not involved in the animal health sector, and the environmental health sector was not involved in the early stage of the pandemic. Even in terms of surveillance of animal reservoir and possible reverse zoonosis. So, still, we have seen for the last 2 years several scientific or political initiatives that decided to tackle emerging diseases and pandemic prevention through a One Health approach, or at least an integrated approach of health, taking into account human health, animal health, and environment. I have put on this slide several initiatives, and one of the last one was cited this morning, the Pandemic Fund, which is a fund managed by the World Bank, but obtained from different countries in the world, is now here to help the country all over the world to be better prepared to the next pandemic. And within the activities which should be, and I hope it will be developed, you have a lot of One Health approaches. I will come back to that. I want to detail another one, which is PREZOD, which is for preventing zoonotic disease emergence, because I want to show how a scientific initiative or a scientific-driven initiative could also incorporate some interaction between science and decision. So this initiative was launched during the One Planet Summit 2 years ago, and it was launched to change the paradigm of pandemic prevention, and especially to focus on prevention, and not only preparedness or management of the crisis, but to focus on the prevention part. So it's not preparedness, it's quite different. And on this graph, you can see the focus of the PREZOD initiative. It includes the understanding of the interaction that we have between the environment, animal health, wildlife and domestic animals, and human, up to the spillover part of an emerging diseases, but not incorporating the work which still is necessary to understand the mechanism of interhuman transmission and the development of drugs or vaccine for that. But the PREZOD concentrated on the first part of the pandemic crisis. As I said, it's a science-driven initiative with scientific questions, which was launched by scientists all over the world. What is interesting is that it's a co-design worldwide process, and the first definition of the initiative was done by 1,500 scientists over the world, by regional meeting, online regional meeting, obviously, during the pandemic crisis. But it was not new. It was just based on existing collaboration at a national level and at a regional level. And it was based on work done in every region of the world, and especially in the less advanced countries, where you could have hotspot of emerging diseases. What is interesting is that it's also aiming at developing a common framework to implement and therefore share the research project, which should not be just research fundamental project, but in tight link with surveillance activities. So incorporating the work done by the different stakeholders and especially the decision makers. And at the end of the day, the idea is provide also a platform, technical platform, scientific platform to be used by the decision makers to improve their surveillance strategy. And the interaction between the science and policy within this initiative can be demonstrated by the member of the initiative. So currently we have about 200 member organizations coming from more than 60 countries, mainly scientific organizations, but we have also 24 now, 25, I think that Zambia has joined the initiative, 25 member countries at the level of a country, so signed by a ministry, either Ministry of Health, Ministry of Agriculture, or Ministry of Environment. And the governance of the initiative has been set up to reflect this interaction with a group of governance, with a civil society college, a donor committee, a regional college, which is a political level, and One Health International Organization College. So we do have science-driven interaction between science and decision, and still co-construction process and engagement of all the stakeholders. So during the last 2 years, and I will go fast on these 2 slides because you had already a lot of information this morning on that, but it's important to say that during the last 2 years, we have seen international initiative to create a One Health expertise recognized by all. And it's very interesting to have this expert, One Health high-level expert panel now working under the quadripartite. And the first work was really essential, which was the definition, the new definition of One Health, which is to my mind very inclusive, which also relies on specific characteristics that are essential for One Health, which is multi-sectorial activity, multidisciplinary expertise, and multi-stakeholders work and implementation. More than that, it's still, I would say, institutional initiative, but in tight link with research and with science. And we need more than that. We know to have funding, to have a real organization and operation in the field. And we have seen again, for the last 2 years, political declaration by, I would say, economic or political group like G7 and also the G20 of Health Minister in 2021, pushing for One Health adoption. And we have seen very recently, during July, also the European Parliament, which has adopted a new strategy to use the lessons learned from the pandemic, and several of the recommendations involve an improvement of the One Health approach. We have seen also adoption of this One Health approach in European Union at different level, either by the creation of a new direction as a European Commission, or through a specific work by WHO Europe region, or through implementation of initiative by the civil society, like the One Europe for Global Health. And in US, you have also several initiatives, a very recent one, with One Health Bill, which was presented to detect, respond to biological threats. And very recently, the White House announced the creation of an Office of Pandemic Preparedness and Response Policy, which inside incorporate a lot of work on One Health. I change from international level to the national one. In France, One Health was also more and more adopted for the last 2 years. We had seen declaration for the scientific academy, either agriculture, medicine, pharmacy, and the vet academy and agriculture academy. We have seen also a national plan from the Ministry of Environment to develop the interaction between environment and health, and to incorporate more One Health in this plan with specific funding for research to be developed within the plan. And we have seen also the development of new initiative within the training and education field, with the creation of new master degrees, and also the creation of institute of a One Health Institute to be able to train the decision maker on One Health. Moreover, during the COVID-19 pandemic, France decided to create a scientific council to advise the government in relation to the management of the crisis. The Scientific Council for COVID-19 worked every day to propose a technical recommendation to the government regarding pharmaceutical or non-pharmaceutical measures to be implemented. However, it took time to develop one full report regarding One Health, and it was the only retrospective and prospective report from the Scientific Council. And this report proposed to implement several recommendations at different scale, and especially at the national scale, because that was toward the French government. I have put some of them, like implement intersectorial surveillance and intervention in the field, prevent gap in disease surveillance related to the silos between the Ministry of Agriculture and Ministry of Health, search for zoonotic disease emergence from the first case at the hospital, and, for example, remove administrative barriers which exist between animal health and human health, for example. And this work was later on in September published in The Lancet, and it described the different steps to be developed at the prevention level, preparedness level, and response level. The French Scientific Council resumed in July 2022, and the government decided to create a new council, which is not now devoted to COVID-19, but which is a committee for monitoring and anticipating health crisis. And the idea behind this creation was to have a scientific council which expands the scope of its activity, including the link between emerging diseases and environment and climate change, and including anticipation and not only mitigation of the risk. And from the beginning, because of the composition of the expert panel, which is definitely multi-sectorial with people from experience from different fields, human, animal, environmental health, multidisciplinary, and with a representation of the civil society within the council, it demonstrates the main characteristic of a One Health expert panel at a national level. And what is also interesting is that this council is in tight interaction with the government, with reports provided directly to the government at the level of the ministry, and which permanent interaction between the committee itself and the ministry, not only the direction of the different ministers, but the cabinet and the ministries, the minister themselves. And there is only 1 year of operation, so it's a bit short to say if it's a success or not, but actually we can see that through the different reports which were provided by the committee, the One Health perspective was definitely incorporated in the work of the committee. For COVID-19, it's obvious there were some recommendations regarding the surveillance of variant emergence in animals and the risk of reverse zoonosis. And another example is the report on vector-borne disease, which definitely made recommendations about the vector control, the impact of climate change on the vector distribution and the emerging diseases, the ecological impact of vector control, the transmission studies between animal and human which should be developed, and obviously the human and animal health surveillance to be developed. And the last one is, for example, having a global view on city revegetation and not just thinking about decreasing the health in the city, but thinking about the consequences about biodiversity and emerging diseases. On highly pathogenic avian influenza, another example, the very recent report released in June, tried to have definitely a One Health approach to develop a joint surveillance and diagnostic and take into account both animal welfare and human well-being when we are talking about culling the animals in the farms, for example, and establish a joint emergency platform. And the most emblematic One Health recommendation was to use the vets which come to a farm when there is a suspicion of avian influenza, highly pathogenic avian influenza, use them to either supervise or make the sampling on the farmer itself, and to provide the samples to the vet lab, which are well equipped to do the diagnostic on human health and animal health. And it will gain at least 2 weeks to be able to detect an infection in human than the normal process. So the more we worked within this group, the more we understood if it was necessary, but it was necessary for some of us, which were very specialized scientists. The more we understood that that was not enough, just having one health, I would say, approach. We need more and more global view, and especially the link between climate, biodiversity loss, and health crisis. And I want to finish with that, that we are facing global risk. And this is a report from a World Economic Forum from 2017, which showed the interconnection between the different risks. And we can see that, as reported by the countries themselves and experts from different countries, we can see that the spread of infectious disease are obviously linked to natural events, for example, and biodiversity loss and etc., climate change, but they are also linked to food crisis, and at the end of the day, also linked to migration of human and to global risk. What is interesting is that the same report in 2017 tried to make a hierarchy of the different risks in terms of likelihood and impact, like it was done in UK and presented this morning. And in 2017, emerging diseases were not at all in the top of the risk. So that graph in 2021, I don't know if you see it. No, you don't see it. But the two on the top are infectious disease and climate change failure. So that's interesting, but it was just after the pandemic start. What is a bit worrying is that in 2003, so it's another type of representation because they didn't want to make the same, but there is a top list of the 20 major risks for the world, either for the short term, 2 years, or for the long term. And for the short term, infectious disease now are at the 20th position. And for the long term, they are even not there. So why not? However, I think that it's better not to say that it's bullshit, but to think that it's very unpredictable and it's very complex. So how to work on this complexity? So we had a nice presentation about system thinking this morning. So that is a way, and at least having a global view and of the risk in general is very important, but to be sure that it's developed at different scale, it is really implemented, you have to do it at the different scale. And implementing at the different scale, it's working at the level of the territories, for example, and trying to put together all the stakeholders of a territory to define what is an healthy socio-ecosystem and trying to promote and to maintain it. And also, at the global level, being able to think about what is One Health, and not only One Health in principle, but One Health in practice, and especially in relation to equity with the different countries of the world. And I thank you for your attention. I finish with this some take-home messages, and the first one will be, do not wait for the next pandemic. Thank you.
Thank you, Dr. Thierry. Do we have any question for Dr. Thierry? The microphone, yeah, it's there.
So the prepared one.
Yes. In terms of sort of implementing this thinking, we've already sort of expand our thoughts with One Health from outside of our own disciplines to even more so with trying to widening concepts constantly. At what point do we stop this specialization and just sort of veer towards just generalism?
Yeah, no, it's a good question because when I say that you need to make the link between emerging diseases, or at least I would say health crisis, climate crisis, and biodiversity loss, the risk is that you work at the very high level with only principle, and you do not do day-to-day work. So it's why I finished with the territorial level, which I think is very important. But most of my talk was also at the national level. The national level, so the territorial level is for day-to-day work, and it's also to be able to have the voice of all the stakeholders and the public at large. Because if you see at a global level, you will not have the society involved. So if you work at a territorial level in a city, in a countryside, in a national park, for example, and you gather together people, the vets, the physicians, the pharmacists, the leader of the park, the agriculture, the farmer and whatever, but also the public at large, the tourist, etc. You will be able to try to work on a specific, you have to work on specific risk, specific disease. For example, let's say talk about tick-transmitted disease in one area, for example. What is the problem? It's a problem of policy problem, it's a scientific problem, it's a problem of just sociology of the people going more in the field. So you have to develop that kind of expertise. And it's not so obvious. It has to bring together policymakers and scientists to work on that type of consensus, I would say. And then at national level, it's very important because you need to provide the framework to develop this kind of initiative and the regulation to allow, for example, the sampling by a vet on a human, and that is very practical one. So you need very practical decision at all scale, and all together you need a general framework to go in the good direction with a science-based recommendation to help the quadripartite to go on the good side.
Sorry, just building on that. I am just curious. Do you think that the modification of regulation is coming as quick as like the research is coming, like for these initiatives? Because I'm thinking about my country and what you're suggesting about like vets sampling farmers because it's easy, they are right there. But then you think about like the regulation, the law is like they're not allowed. So then like thinking about changing those laws and the responsibilities and who will have the consequences of the actions, it's a little bit, yeah, there's a big lag there.
No, it's not easy, but it's perhaps, it could be sometimes easier than the way the people think, because you know that for this possibility of having the vet sampling the human, some people in the human health sector are really against that. So it's not only a matter of regulation. And we had a lot of discussion with the Ministry of Health on that. And we had some also discussion within the committee with the people representing the general practitioner or the general medicine. Mm-hmm. And they are convinced that it's a matter of, again, of training, education, and having the people, both the professional and the decision maker, having the broad view to say it's just an administrative issue, you know? So it can be, we can work on it. Yeah. It could take some time, but we can work on it. So just to give you an example, next, I don't know what will be because this recommendation was made in June, for the moment is not implemented, obviously. But on Monday, the COVAS has a meeting with the cabinet of the 5 ministers I have cited. And the Prime Minister cabinet asked all the cabinet of the minister to provide to us the list of recommendations that they have already implemented from the report that we have made in March and June. So I don't know, but this is a key point. Will the recommendation be adopted or not? We'll see.
Thank you very much, Dr. Thierry. So let's have an applause for Dr. Thierry. Okay, so next up we have a virtual speaker. We have Dr. Séverin Thies with the talk, The Added Value of Anthropology for Infectious Diseases Control in One Health Movement, the Case of Neglected Zoonotic Diseases. And let me tell you a little bit about Dr. Severin Thies. Dr. Severin is a Belgian One Health anthropologist who is currently based in Montpellier, working at CIRAD also. She has been actively involved in the One Health movement since 2009, when she started her research at the Institute of Tropical Medicine of Antwerp to foster intersectoral collaboration and to promote social sciences research of the nexus of animal-human ecosystem in the field of neglected zoonotic diseases control among livestock owners from the south. Her motivation also for her research is to continue building bridges between disciplines and stakeholders, and she is also co-chairing the One Health Social Sciences Initiative from the One Health Commission in Washington, USA, and is a member of the French Scientific Committee of CESAV, Center for the Synthesis and Analysis of Biodiversity, a key program of the Foundation for Research on Biodiversity. So please welcome Dr. Severin. Dr. Severin, you can start, please.
Thank you. Thank you very much for this kind introduction. Are you all listening? Yeah. Okay. So thank you also for this invitation. I'm really sorry to not be there physically, but the beginning of the academic year is quite hectic already. But it's very motivating to be invited at events where social science were previously not really expected. So I will try during, and I hope to stick to these 20 minutes, to demonstrate or at least convince you of the added value of anthropology for infectious disease in this oneness movement. And I will use the case of neglected zoonotic disease. So as introduction, I would like to come back to this term, neglected zoonotic disease, often called as disease of neglected populations. And I would like to highlight the neglected components again by saying that they are neglected because they are, in fact, affecting mainly poor and marginalized communities. Also, their official notification is still often inadequate and in existence, which is explaining why there is a low prioritization by national and international agencies. Then the component of zoonotic is also important to be again highlighted because these diseases are transmitted between animals and humans. We are really situated, localized at the nexus of animal-human ecosystems. And because the health, the human and the animals are affected, there is a dual burden on communities, not only the health, but because it's compromising livestock health, which is often the main income for those marginalized communities. They are also, it's adding a burden on when they are sick themselves, also because they are in places where appropriate healthcare is not often adapted. So all these aspects are creating a unique control challenges. And that's why it became more and more obvious that we needed to look for a holistic approach, a more collaborative approach, also action-based approaches, which is what, in fact, the One Health concept can offer. The One Health concept is based, in fact, on this paradigm that animals and humans and their environment is interrelated. They are not existing in isolation, and the activities of each member affect the other. So all is connected. And in that One Health movement, what is in fact the place and the role of anthropology? So for sure, it's incontestable that the importance of understanding social and cultural factors are essential, both in disease transmission dynamics, but also in planning and evaluation of control interventions. But if we dig a bit more, how well integrated is anthropology, is this One Health movement? Unfortunately, but it's of course changing and improving, but a lot of energy is put in this paradigm debate between qualitative and quantitative approach, which is in fact hindering a broader use of social science. Also, the One Health movements have a very high focus on global pandemic threats, where we can, in fact, also target more the well-being of animals, also the more structural drivers of disease vulnerability. Sorry. And because of all that, social science, obtain or were involved or had the possibility to a few opportunities for very serious scientific contributions and engagement in that movement. And if and when they are included, it's often to easing, in fact, the delivery and the dissemination of pre-established knowledge, which I means like exogenous solutions, so solutions that are out context and not adapted, so following more a top-down approach. So to come back to this debate between quantitative or qualitative approach, if we gather all these unique specific challenges to improve the control of neglected zoonotic disease, so which approach is best if we want to understand the complex and dynamic interaction of diverse factors, so coming from diverse sectors, but also from diverse species in very diverse socio-ecological contexts. And the answer is that there are no a better approach than another. They are very much complementary, and they have their pros and their cons, but we need to continue to have this holistic approach because biology and culture are very much in close and interconnected. Indeed, there are not only one way to look at health plural, because health of animals, of humans, and or of environment, and because social science are following a constructivist approach, meaning that they are not considering that there is one objective reality. All realities are, in fact, socially constructed. So that's where social science, and anthropology in particular, is key to be added in this One Health movement to offer a discipline of observation and interpretation of the causes and consequences of human activities in their sociocultural context. So anthropology, which is the systematic study of human societies and cultures and also their development, it's offer this key concept of culture, which is an englobing phenomenon and a dynamic one. Culture is very flexible. And because they are expressing a particular view of the world, it's through culture that we can understand the practices, the knowledge, and the attitudes, and in regard of health in that matter. And health is also a fundamental category in all cultures. All cultures has their medical systems. And that's how it came, the idea of my thesis is that we should apply this concept of culture to livestock owners and also to this interaction between human and animal. So my thesis was hybrid in the fact that it was a set of different socio-anthropological studies defended in the Faculty of Veterinary Medicine, veterinary science, in order to explore the contribution of socio-anthropological discipline to the One Health perspective regarding the integrated control of endemic. So we are speaking about endemic neglected zoonotic disease and not epidemics one. So the three case studies, so there has been one about cystic echinocosis in Morocco, which has been published. Then one in about Teniasolium teniasis cysticercosis in Zambia, also with two papers about why latrine are not used and why pigs are free roaming. And the last one, which I want to explore with you really briefly, is the last one on canine rabies conducted in South Africa at the border of the National Kruger Park in Mpumalanga province, which is close from Mozambique. and it has been also published. So the context of rabies or canine rabies in South Africa is that it's a notifiable disease, and free mass vaccination are often organized, and vaccination is free, and there are mobile campaigns organized. But still, they have to really face the reintroduction of the disease, and specifically in areas where the dog vaccination coverage is very low. But the question was why, when this vaccination is free and also almost done door by door. So we needed to understand people's perception of the dog ownership, and also the determinants of behaviors towards rabies control, such as vaccination. So this study, we did like focus group discussions. We focused on 3 different groups: men, women, and children. And for each of these groups, we had a discussion with only dogs owners and then only non-dogs owners, in order to compare their perception and their point of view of the problem. This area, the population is poor, rural, and they belong to the Shangaan ethno-linguistic group. They are mainly livestock breeders and doing some agriculture. And the question guide, so we focus on themes like the perception of dogs, how dogs were managed when you are owner, the risk behavior perception, but also their knowledge and perception of the disease itself, and then their perception on the control option. So the results, some results about dogs vaccination, it just illustrates how anthropology can contribute. So we had really gathered information about how vaccination of dog in general was perceived, but we also focus on the vaccination regarding rabies. And there we observed that there were like 4 different barriers, like 4 different narratives around this dog vaccination. So the first one is that injection for them is to cure dogs after having bitten somebody. So if the dog is dying after the vaccination, it's because of the injection, because it's supposed to heal the dogs who beat someone. And even if it's a car who killed the dog, it's always the vaccine which is going to be blamed. The second barrier is that vaccination was considered as a plan from the game lodge owners in order to kill hunting dogs. So dogs that were in fact going into the park for what was considered as poaching, but in fact what is for them hunting. Then the third narrative was about the fact that for them, vaccination makes dogs weaker, very much less aggressive, with less appetite, when in that area, it's a really remote one, but very poor and insecure. And the people who were owning dogs was because of protection. So they needed aggressive and dogs. And then the last narrative or barrier was that for them, dogs were trained to not bite. So therefore, there were less risk to spread rabies and no need for vaccination, because for them, rabies was linked to bites. And so if the dog is not biting, then why I should vaccinate my dog? But what is interesting and where anthropology is needed is to understand the barriers. What is the social cultural driver behind that? Those narratives. And in that case, it's very basic, but it can be a misunderstanding from a health promoting poster. So in every clinics, a poster was put in place to explain what was rabies. And there was this picture of a dog, which was said that if you have a dog, for them, if you had a dog salivating and aggressive like this, then you should vaccinate. But again, like I said, for them, they needed an aggressive dog. So that's how it hindered their willingness to vaccinate their dogs. And then we are at the interface with wildlife, and specifically with a national park. And you can, for sure, historically also find human-wildlife conflicts, because the park was fenced. Therefore, the people which in fact owned the land couldn't anymore go inside. Hunting small game was considered as poaching, when in fact for them it's ancestral practices and often also the only source of proteins. And then also they couldn't anymore go into this place where in fact they were fetching wood, getting water, and also going to the ancestor grave. So that created a lot of conflicts and mistrust. And so with the vaccination, which was not often explained why they should vaccinate their dogs and how, and also not involved in the campaign, that amplified in fact the how do I say, the barriers to vaccinate their dogs. So as general discussion, I would like to just mention that anthropology can contribute to the One Health movement, basically by, in fact, enabling novel ways of addressing zoonotic diseases, which have closer integration with people's own cultural norms. Because, yeah, if I want to go back there, also the perception and the interaction between animal human, it's not the same everywhere. And also what is considered as animal and what is considered as human. It's also the big debate between nature and culture. Then another important contribution is in the field of interdisciplinarity. In fact, anthropology or social science can also highlight different conception of risk. So you are a livestock owner, so you don't perceive the same risk if you are a decision maker, for instance. And that's why it's important, and I come back to what Thierry said, we need this space forum to collaborate in order to understand that there are different representation of risk, and that therefore we should come to a common perception in order to find common solutions. And then another contribution in the field of interdisciplinarity is that we need to go beyond the role of cultural mediators, specifically for behavior change. Although livelihood, farming practices, also gender roles are not only a matter of choice or open to change just with a public promotion or health promoting campaign. It's more complex, and I give the example of medical doctors who knows pretty well that smoking is not good for health, but still a lot of medical doctors are smoking. So it's not because you have the knowledge that you are going to change your practices. But of course, working in interdisciplinarity is very challenging, especially that you have this continuum between multidisciplinarity, interdisciplinarity, and then transdisciplinarity. And all of three has their own process, their own methodologies, and their own way of creating this collaboration. There are also, therefore, many barriers, also because we don't have the same language. We are coming from different background of, I mean, from a disciplinary point of view. And also, we are not often at the same place working together, which makes different difficulties. And that comes to the point of technical issues, delaying the process of working together. For instance, there are up to now no One Health ethical committee that can review and evaluate protocols which are under the One Health umbrella. So we have to find committees from the veterinary disciplines which are not trained to evaluate the qualitative part of the protocol, etc. And also at the peer-reviewed journal, there are journals that welcome interdisciplinary paper, but finding reviewers is quite complicated. And so we need to move from who can act and how to how should we act. That's really something that we have to go forward. And interdisciplinarity implies compromise and flexibility also from a methodological point of view. And I will end the presentation with this quotation coming from Professor Emeritus van der Kies, who is a medical anthropologist from Amsterdam. And he said, interdisciplinarity only has a chance if those who belong to the cultures of social science and those of the cultural of medicine give up their ethnocentric fear of dissenting beliefs and accept the practical consequences of the conviction that reality itself is multidisciplinary. And I end here. Thank you. And if you have questions, welcome.
So do we have questions for Dr. Severin? One question? No hands? Okay, we have one there.
Hey, Dr. Thies. So I'm quite interested in sort of the reconfiguring of sort of how we approach science communication through like these considerations for the anthropological. We already have a hard enough time trying to communicate like a science that is a consilience of evidence, and that all tends to come from like particular sectors. And so what is the most practicable way to also convince the public that also this consilience might not necessarily be the right way to approach things?
You mean the consilience of, I did not get what you mean by consilience.
Just like as an example, we already have a hard enough time trying to convince people of the ravages of climate change. And we have a consilience of scientific evidence behind that. But then when we have to consider also, a lot of these anthropological influences in other science, we're also approaching that through a certain lens. And it's like, how we convince ourselves also to approach it through that lens, and also like communicate to the public that maybe sometimes we're wrong and we need to approach things through other means. Sorry, it's a bit long-winded.
But just by, for sure, being honest, I think as researchers, it's difficult to also separate, us from being a scientific and being also a citizen facing all these, for instance, climate changes. I think we are, it's very utopical, but we don't need to work on everything, everyone, all the time together, because it's very taking a lot of energy, and it's often taking a lot of time. But I think if we just acknowledge that there are not one way to do it, and for that I would like to also mention that, for instance, in some related to climate change, we said we are going to integrate indigenous knowledge, but in fact it's still again not really integrated. It's mentioned, but there are no involvement. We are not going to practically use this knowledge, and it's not put at the same level. It's always like there is a difference of hierarchy about knowledge, and that's, I think, where we should, that's the base. If we don't agree on that, and I know it's very difficult, I'm working with vets and epidemiologists for so many years, and for statisticians, for instance, they don't see how we can overcome issues without statistics. When in fact, why, I don't know, sorcery or traditional medicine or religion cannot be something that we can invest in. That's a bit broad and very philosophical, but the basic is to rely on the fact that there is no one truth, and science is not neutral. And as soon as we acknowledge all that, I think it's going to be easier to consent and work together. That's my point of view.
Thank you, Dr. Severin. It was a great pleasure to have you here today. We don't have any more questions, so we will be moving on to our next speaker.
Thank you.
Thank you very much. A big applause for Dr. Severin, please. Okay, so next up we have Dr. Nicholas Ray, who is here today with us, and he will give the talk a geospatial, socioeconomic, and One Health approach for reducing snakebite burden in Nepal and Cameroon. And just a short summary of Dr. Nicolas Rey. He's associate professor at the Institute of Global Health of the University of Geneva, head of the GeoHealth Group, director of the doctoral program in Global Health, director of the Hub Digital Science for Environment Health and at the Institute of Environmental Sciences. He has a long-standing interdisciplinary research experience in spatial ecology, population genetics, spatial data, infrastructure, GIS, and global health, with a focus on developing and applying models of physical accessibility to health services. He is currently lead of several projects directed towards geospatial modeling at the interface of global health and environmental sciences, and with an emphasis on low and middle income countries, such as the SNF project, Snakebite, and the Access Mode also project. So please welcome Dr. Nicolas Rey.
Thank you. Good afternoon, colleagues. Good afternoon, dear students. Thanks a lot for the invitation, the very efficient logistics for all this, and for letting me talk today about snake bite, and most of all, snake bite and venoming. And snake bite and venoming actually has been coined by MSF as a public health emergency gone under the radar. And indeed, if you look at this slide that showed the world's deadliest animals, so after mosquitoes, of course, that are actually carrying many pathogens, and humans that are killing other humans, snakes is very efficient also in killing people, about around 140,000 people yearly. And then you have a suite of other beasts on the slide, and you can see that sharks actually at the end of it. Indeed, a few facts about snake bite and venoming, so envenoming through the venoms of snakes. WHO states that there are around 1.8 to 2.17 million envenom people yearly, with 400,000 disabilities, and we tend to forget that, but there are huge disabilities following snake bite, often, as you can see with this young lady here at the bottom and harm. And again, this is the official numbers, 81 to 138,000 deaths per year. This is certainly underestimated. And forgot to say that, yeah, the total number of snake bites, envenom plus non-envenom, are around 5 million yearly. It's a neglected tropical disease, an NTD. It's been put on the NTD list, back on the NTD list in 2019 only. And again, it has substantial public health impact, affecting mostly impoverished populations of the warmer tropics. There are only actually 300 snake species that are coined by WHO as medically relevant to people, so that have venoms that can affect humans, out of the 4,000 snake species worldwide. And also there's substantial financial consequences associated with snake bite management, because we are still making snake antivenom the old way, by injecting small amount of venom to large animals like horses, and then taking out antibodies and making some antivenom. So it's very expensive to do. There is not at all enough antivenom worldwide. Only about a third of the needed antivenom is produced by pharmaceutical companies. Some of them have stopped because it was not, good for them to continue. So it's a big issue, and we have very limited available data at national level on snakebite epidemiology. Just a geography a bit of the envenomings in a quite a recent paper, just to give you the sense that actually the big hotspots for snakebite envenomings are Central Africa and also Asia, especially India, Nepal, and around that area are hotspots of envenomings, and you can see the numbers here on the map. Snakebite also affect animals, and we've shown, our team have produced a review a few years ago that really show that it can cause mortality and morbidity in many domestic animals with very high fatality rate, of course, depending on the species. And so we're really talking, taking into account animals, human, and the environment in which this occurs, really in agrosystems with human, domestic animals, and snake together. And it's a nice framework to then call the One Health kind of framework to try to tackle the issue. We've worked about this One Health framework. We've published it in another paper, where we really try to put these various components together. On the left side in blue, you have kind of a human case track, where of course you have premature death, sequelae, disabilities, but also a loss of productivity, especially from farmers or that are bitten, that then of course triggers loss of household livelihood, of course in addition to human health burden. And on the right side you have the animal case that very similarly, through death we have an animal health burden, but also an animal production losses that affect household livelihood of people. And so that's the framework that we've used in a recent project and that had never actually used with snakebite, this kind of One Health framework. And so we got a project 4 years ago funded by a Swiss National Foundation for Research, an equivalent to CNRS in France, and we call it the Snakebite Project, with a Y because there are a lot of different type of digital approaches to it. And we focus in 2 countries, Nepal and Cameroon. I will mainly show you results from Nepal today because the one from Cameroon are still on the finalizations and soon to be published. I'll give you a few very preliminary results on that at the end. Nepal, small country at the foothill of the Himalayas, but with a very large plain here, agricultural plain called the Terai. And of course it has a kind of similar environment than northeastern India. And this Terai region that you can see here, very agricultural, is kind of perfect combinations of snake habitat and on the type of human environment that you can see here with a lot of farms, with animals, a lot of rodents that is the main food for many snake species. And so perfect conditions to increase encountering of snakes and humans, right? And so the likelihood of having incident and bite is very much increased in that type of environment. And so what we did, we call it at national scale, but of course there was only in the Terai region. There is not really many snakes in the Himalayas, no snake bite in the Himalayas, so we can consider this as a kind of a national survey. We set up a multi-cluster random household survey. So we first randomize administrative area in the Terai region. And then we had to randomize households to be surveyed. So that was really tricky because, of course, we didn't have a map of a vector map of all the house of the Terai as we have in many places in France, in Geneva. So we have even the small swimming pool we have everything, but it was really difficult. So we had to use high resolution satellite imagery, have some random points on top of it, and then select the household that we wanted to visit. And so our colleagues, surveyors from Nepal, then roams the Terai for about 3-4 months, surveying a total of more than 60,000 participants and around 14,000 households. So there was a very a great large database of primary data with the questionnaires that of course had many questions on whether the people in the household were bitten by a snake. We were looking at the last 12 months for this recall, what they were doing when we were bitten, were they trying to reach care or traditional healers, what sort of impact they had on the likelihood, many questions, socioeconomic questions on that, and also on the animals that they hold. So each animal we had a specific questionnaire asking also what happened when there was a snake bite, was there death, what was there incurring any cost, and etc. And so with this very large database, we were able to do several things. First, of course, look at the epidemiology, so on the snakebite incidence and risk. And basically found out that, of course, that was actually much higher than previously thought at this level in Nepal. So you have the numbers here. This is the projected number for the whole terrain, for the country, if you want, between 26 and 30,000 yearly beaten people, with around between, those are confidence interval, 2,300 and 3,200 deaths at national level yearly, which is a snakebite incidence of around 250 per 100,000 people, which is quite high. We have, of course, many numbers on animals as well. Just put some here. You have the number of animal cases per 100,000, and the number of extrapolated animal death case per year. Of course, a lot of poultry. The death rate was 100% with poultry, but then cattle, more than 4,000, goat and sheep, 2,000. And that was really the first time that we had such good data on the impact of snakebite on animals. What we could do also is, and this is for human bite only, is that we could use a Bayesian approach, geospatial Bayesian approach, to model the risk of snakebite at very high spatial resolution. That's what we did. So based on of course, all the covariates from our surveys, also other type of covariates of environmental covariates, distance to rivers, and other socioeconomic covariates. And we could really model, geographically model that risk. Not very surprisingly, the strongest predictor in our model was still the poverty probability index. So the higher poverty, the higher the risk of snakebite. And so this map that you see here, it's already quite useful also for the programs, for the Ministry of Health to know where are the higher risk. And of course, you can combine this with the number of population. And this map shows actually the population at risk in the terrain. So the darker, the higher this risk. So very interesting, important, and useful map for programs. I just make a digression quickly in another country. This is Côte d'Ivoire, just to show you that the next step was actually to look at access to antivenom. And just to show you on this map, because you will see and understand it better. We are doing this type of map we have done this for 20 countries. This is a map that shows the travel time to the facilities that can treat severe malaria in Côte d'Ivoire. And you have the legend, so the colors represent the motorized travel time. So 1 hour, 2 hours, up to 4 hours. So the area in reds are locations where the population needs more than 4 hours to travel to the nearest such facility. And so we have developed for 15 years now in my group with WHO an open source free tool called AccessMod that can do that. And so just to say that we have used the same approach in Nepal for access to antivenom. This type of model requires quite a lot of geospatial data as input. First, of course, we need the healthcare centers, the geographic coordinates and where they are, those that can treat snakebite. That was actually very difficult to get. We had to use all our resources with the ministry and many others to find, where they were. Population distribution at high resolution, we have this freely available for almost all countries, thanks to the World Pop group at University of Southampton. Transport and mobility, the road network, of course. We had a special data set of hanging bridges in Nepal that links the valley where people walk and that can really, improve the access of people. And so we took that into account in our model. And also different barriers to movement, of course, still the topography, the slopes, a land cover that indicates what's happening outside of the road network when people walk, because many people have to walk to healthcare. And finally, the river networks that, of course, are barriers to movement when there is no bridges. So we bring that all together. We construct a model of travel time to centers. This is the map of the travel time to the centers that can treat neurotoxic venom. So neurotoxic venom from the cobras, for example, attack during the neural systems. That's the most dangerous. Usually we say that you need to have healthcare within 60 minutes of such a bite. And so we have only here the facility that can treat those snakebite with the appropriate antivenom, plus ventilatory system, because patients need to be ventilated with these neurotoxic syndromes. Another very useful map, because then you can see where in the country are the areas that are far away from healthcare, and then try to mitigate that, and as I'm going to show you in the next slide. So we have the physical access, the modeled physical access to antivenom for this type of snakes. We had the snake bite risk, so we can combine the two of them and have a map of vulnerability to snake bite and venoming that we characterize in 3 categories: low, medium, high vulnerability. So high vulnerability would really mean that those are areas where people are both far away from antivenom, from healthcare, but are in area of high risk of snake bite. And so these populations are highly vulnerable. And we've done that for only the neurotoxic facilities or for all facilities that can treat also hematotoxic syndrome, some venoms also attack bloods, and so, but you have a bit more time to reach healthcare. So again, very useful map to kind of pinpoint, to prioritize area where populations are most vulnerable. But we can go also, because what is nice when you have a model in a geographic information system, you can start modeling and proposing scenario. That's what we did here. We asked the question, okay, what if we could upgrade facilities that currently do not treat neurotoxic bite, but could treat neurotoxic bite? Wouldn't be very costly. Of course, you need the right equipment, but let's try to model that. And we model the upgrade of those facilities and rerun the model. And what you can see in this in this area where we have additional facility that could treat those snake bites, as you start increasing the number of such facilities, even with the first 3 facilities, you add up around 1.4 million additional people that can have timely access to this healthcare within 60 minutes. And if you continue, well, you continue adding people, but only with 3 well-chosen facility upgrade, you can have this. If you upgrade all facility currently treating only hematotoxic to neurotoxic syndromes, we've done the modeling, this add more than 3.8 million people that could have timely access. And it's an improvement, about 30% of population coverage. So very interesting and again, very interesting type of map of modeling because it quantifies the effect of an intervention, of an improvement. For the Ministry of Health, this is key also for donors to have this quantification and based on really good primary data as well, and ensure that they can allocate resources at the good places. In parallel to that, we had our kind of health and socioeconomic impact assessment of the bite. So we looked at, we measured, of course, the well-known disability adjusted life years, the DALYs, of the snake bite burden on humans. We had livelihood loss that we estimated that were actually encompassing out-of-pocket healthcare expenditures from the beaten person, that we had this information from a survey, losses of productivity due to days off work, and losses due to domestic animal mortality and the treatment of the domestic animal. We had this information also through the survey, and we also use external information for that. We also estimate the so-called animal loss equivalent, so that's really the monetary loss due to domestic animal mortality, so-called ALI. And so if you add the DALYs to the ALIs, you get this relatively new Z DALYs. So these are modified DALYs for zoonotic disease that are encompassing both these DALY for animals and for humans. And a few numbers from our study that have been published last year. So we had an overall annual snakebite burden of more than 200,000 DALYs, and mostly due to a large number of bitten children and women. Those estimates were actually 14 times higher than recent estimates from the Health Metrics, Institute of Health Metrics and Evaluation in Nepal in 2019 in the Global Burden of Disease project. And so hence you can see the importance of basing your estimates on good primary data. 2.8 million in yearly livelihood loss associated with both humans and domestic animals, with the kind of median cost for a bite on animals and humans. $91, it's actually quite high when you think that the average salary in Nepal is about $250 US. So such event in a poor livelihood can really have a household can really have a really impact on livelihood. Equivalent animal loss equivalent, 1,800, and so the yearly impact of more than 202,000 DALIs. So it was the first estimation really of DALIs for a link to snake bites anywhere. We've done the same in Cameroon, but again, we are really now in finalizing phase. So Cameroon, a larger country, Central Africa, of course, larger snake bite incidents. I give you a few numbers here about the number of animals that, so cases of snake bite envenoming and deaths in animals that you see here. So much larger number, of course, than in Nepal. The annual incidence is close to 460 per 100,000, again, much higher than previously thought. And the extrapolated burden across Cameroon on national scale is more than 68,000 victims, close to 5,000 deaths per year. And of course, we also did the Z-DALIs estimation, and you have the numbers here. Just to mention also that the ALI component was 9 times higher in Cameroon than in Nepal. So we should be able to send all this to publication and to have this published by the end of the year, hopefully. Conclusions. Yes, we have now a kind of novel methodology and new evidence to raise awareness of snakebite, of course, in Nepal, but really, I think globally, WHO have been following closely our result. They want now to replicate them elsewhere. And potentially to other zoonoses. We applied for a project that would link snakebite and rabies, because rabies with a bite, we think that, and we know there might be joint approaches for prevention, at least, on these two entities. Very high burden of disease, mostly associated with this yearly life loss, again, due to very high, unfortunate mortality in children that are playing around and got bitten in the grass, usually. And so we really have this dual economic impact of snakebite in affected communities, both on humans and animals. And so really that's a call for strengthening all the preventive measures and also all the access to life-saving treatments, all the geospatial approaches that that's what we're really doing in my team, in the GeoHealth team. And we can apply that to snakebite, and we try to also apply it to many other diseases. So with that, thanks a lot for your attention.
Any questions? Thank you, Pat. Do we have any questions for Dr. Nicholas Bray?
So, thank you for putting lights on snakebite in Nepal and Cameroon. So I'm from Nepal. I'm Pratik Kizu. So yeah, snake bites are fairly common in my part of hometown. So recently also, back in 6 months, that I have 2 people who were bitten by snake. And so I have a question to ask, during your visit to Nepal and during the research, so you must have faced the people who were bitten by snake. So what were their perception towards a snake after getting bitten? Were they positive about the snake conservation, or had they very bad perception towards snake? Thank you.
Yeah, so, well, of course, I was not doing myself the interview, so there was many of your colleagues in Nepal that helped. Yeah, actually, that's a very good question. We didn't have specific question, and that's a clear, nice kind of anthropological research to do around this, and of course the use also of local traditional healers and all this. I just know because, of course, we discussed about that with the expert of snakebite in Nepal, and it seems that yeah, in Nepal it's really well, they really try to, of course, like many people, to avoid snake. They really see it as yeah, really bad, bad animals. Of course, they kill people. So I don't know if I have more information to give you. I just no. There are differences with other countries. I know in many African countries, of course, they're always seen as bad animal, and they have the tendency to always try to kill the snake, also to bring it with them to the healthcare facility, because they know that if they do that, medical staff will be maybe more prone to recognize the snake and then give the right antivenom, or to not give the antivenom because it's a non-venomous snake. And so, yeah, you're right, there are different perceptions of that. We've actually another paper by my colleagues that have been looking exactly at those questions and traditional healers for snakes and perception. So I can send you the link.
Yeah, thank you very much.
Thank you so much. Okay, thank you so much for a great presentation. I wanted to ask as well, I'm from Zimbabwe in Africa. So snake bites are also common in our region as well. I wanted to ask if by any chance you're working with any organization, since you've shown this data, it shows that it's a great burden to the society and the community. So are you working with any other agent or any other organization to maybe help in any way, since it's a really a neglected, as you said, tropical disease? Yeah, thank you.
Yes. So of course we heavily involved in collaborating with first the WHO, and they have a snakebite initiative. They launched a snakebite roadmap, I think it was last year or 18 months ago. They target to decrease snakebite deaths by 50% by 2030. And so what WHO is doing now is really assembling a lot of information, data, epidemiological data, availability of snake antivenom, which it's really a mess, for all affected countries worldwide. And so really, and they have 10 prioritized countries for that. And I can't remember if Zimbabwe you said? No. Yeah, Zimbabwe is part of the 10 priority countries, and I can check that. But definitely, and there have been quite some investment, notably from Wellcome Trust, for snakebite prevention and for this roadmap. So it's definitely coming. The other actor is MSF, Médecins Sans Frontières, that really have also strong programs in many countries, many African countries, on prevention, but also, of course, on treating patients. And I can also check whether that's the case in your country.
Hello. I have a question. Do you see any correlation between like what kind of crops they grow and related to the snake bite rate? Because what I've heard is like the different social status, they probably own different land, and those kind of different land, they are suitable for different kind of crops. And that might be, agree with you said, like probably like more poor people and they got bitten more. Do you have those data like showing that?
No, we don't have this data. The challenge in Nepal is that, of course, well, there are snakes mostly everywhere. First we wanted to do a snake habitat map, but we quickly understand that the main big species are everywhere. It's not possible to state where they are not. But what we found in the survey was a correlation with, it was more the type of food that were around the houses that were attracting rodents, that in turn were attracting snakes, that had an impact also on the snake bite. So whether people store some grains or stacks, of course, close to the house, and what they're doing also with the animals, and if they have all the poultry eggs very close to the habitat, and all this had I think a larger impact on the likelihood of snake bite rather than what they were exactly, what were in the field close by. All right.
We have a question over there.
Thank you, Dr. Ray, for a wonderful presentation. I really connect to your presentation because I'm from Bangladesh, and as a medical doctor, I have to treat hundreds of cases of snake bite and venoming. My questions, two questions, small ones. In the first several slides, you have mentioned from the One Health framework that snake bite and venoming cost us a substantial amount of out-of-pocket expenditure. And when you explained your research, you were talking about access to healthcare facilities that can treat snake bite and venoming. So did you experience in Nepal that out-of-pocket expenditure of the patients somehow is a barrier of accessing the treatment? This is one question. The second question is, as you were an expert on this snakebite and venoming, what we have seen so far is that the mainstay of managing is the curative treatment, right? Do you propose anything preventive? I mean, it's difficult, but do you propose anything preventive so that we can lower the count of this envenoming? Thank you.
Yes, thank you. Great questions. Maybe I'll start with the second one. Prevention, of course, prevention, and especially for snakebite, is really the basis to lower that number. And it's actually quite easy. You just need to wear boots when you work outside. I mean, it should be easy. And then your likelihood of being bitten is down to zero. But of course, wearing boots for people that are not used to that and that don't want to do it might be very challenging. But and another easy prevention measure that, and there's been research published on that, is that sleeping under, because you have country in Cameroon, big issue is that you have small snakes called crates that have really small fangs. They enter the house at night to feed on rodents or small mammals, and then if people sleep on the floor in many places, and so just by moving, they encounter the snake, and the snake reacts by the patient, but with no pain. So the people woke up in the morning and they already have paralyzed, and it's too late. So they found out that, yeah, again, sleeping under mosquito nets completely avoid snake bites. So an easy prevention measure. And of course, the other prevention measure is to, make people aware, recognizing where are the area. Don't have your kids play in some places. It's easy to say for many people, but in some area it's really difficult to tackle that. So yeah, there are definitely prevention measures, and this is always the key. This is also the key for WHO to decrease that number. Your first question was on remember. Out-of-pocket expenditure, yes. So of course we had this in the survey. Yes, we have many data that shows that it can really prevent people, and it's not necessarily on the cost of the antivenom, because in Nepal, in most places it's free, but it's really on the cost of the travel to healthcare, and so definitely that is a barrier. And for example, in Nepal, my colleagues, and I will finish with that, put up a very nice activities where if you're bitten by snakebite, you can call some volunteers on motorbikes. I had a picture in my presentation. They come with two people on a motorbike. They put the patients in between, and they rush him or her to the healthcare facilities, and that for free. And that really decreased the snakebite mortality in that area where this project was being done. Thank you.
An applause for Dr. Ray. Thank you very much. It was very interesting. So moving on, we're a little over the time, as always. Anyway, so our next talk is actually a sponsored talk, because probably we didn't mention before, we also have another sponsor, which is the European Federation of Immunological Societies. We were lucky to get EFIS on board with us, and EFIS was sponsoring the travel grants for some of our student presenters. So to talk about what is EFIS, we have our colleague Pat, which will give a small introduction about EFIS and all the programs that it has. So please welcome Pat.
Alrighty. Hey, folks. So yeah, as Dara has said, we've been sponsored by EFIS this year. But what is EFIS? We're a little bit lateral to it, being sort of infectious diseases is our focus. But The IFES is the European Federation of Immunological Societies. They are effectively a group of, if it'll load, there we are, a group of all the different societies for immunology across Europe. A little bit slower than I thought. And that sort of comprises Europe, but also parts of Eurasia and the Middle East now as well. So sort of constantly expanding. On top of that, they also have their young IFES chapters, particularly aimed at younger researchers who aren't really quite at that early career stage, depending upon your definitions. And they've recently just organised a symposium out of Berlin, and they are planning another one in Ireland for, I believe, next year. And these are all the different societies that have a youth chapter, and that's only expanding. They have... That was an old version. It's all an old version, which is a bit weird. But effectively, they have been sponsoring us with a small meetings grant that has allowed us to bring a lot of our students to present their research together. On top of that, they do a variety of different outreach programs, a lot of them coordinated through the British Society for Immunology, including things like bite-sized bio and weapons of microscopic destruction, which are really to sort of teach immunology to younger generations. As well as coordinating efforts around the International Day of Immunology to spread the message about immunology and sort of teach the next generation all about the immunological concepts. They also are tied with the journal Immunology Letters, which offers a lot of different fellowships. This is all an early draft that didn't get corrected when I copied the file. And they also arrange a bunch of different awards that are particularly aimed at early career researchers, women in research, women in immunology specifically, and also providing a lot of grants. Also, if you're submitting a PhD thesis, they have prizes for that every second year of up to €50,000, as well as potentially providing you project support as well for the next 3 years. And working together with Acteria. Yeah. And so the grant that we've received is also joint with the European Journal of Immunology, which promises effectively a first round peer review for any submission from a journal partner, which you become by being part of this event in the first place. Okay, and they have a series of upcoming events, or at least the different societies do. So the soonest one is a coordination between the French and the German chapters, and that will be at the end of September there in Strasbourg. They also have the wider global chapter, the International Union of Immunological Societies, that is having a conference in South Africa this year, in Cape Town. And shortly after that, we have the British Society for Immunology Congress, which will be held in Belfast. That is also tied up with the Society of Immunology, the clinical immunology, sort of a short summer school kind of thing, coordinated. And then also we have the wider IFES Congress that is going to be held next year in Dublin. And just a big shout out to all of our other sponsors who've together been able to actually provide us support for this event and getting it started in the first place. So that being our joint universities, as well as the European Commission, who gives funding to the overall projects. Our biggest supporting partner, the FERI and INRA, and the Region Centre-Val de Loire, Zoetis, and Roche. Thank you.
Okay, so for the last part of this second session, we have a special event that you must know that this IDO Day was created by former students for current and other former students of the IDO program. It's a way for us to facilitate the connectedness between students, former students and current students, and for the a welcome event also for the new generation of the IDO students. So last year we had this little space that is mainly for giving information about the program because we would like to promote this program. It's a great program. And so we're continuing on that tradition. We're changing a little bit about the dynamic that we had last year. It was more of a talk show. But for this year, we're having again my colleague Mariana as anchor, and we're having a couple of, well, a few former students like joining us here at the podium, and we will have a couple of the new students asking some questions about like the about what they want to know about the program, what the experience of the former students was. So please join. I don't know exactly the names.
I can take over. Hi everyone. So as Adair was explaining, like this is the more humane part of the program because it's the people that actually confirm the program. So I mean, I already talked to you. You know which students are coming. So please, Vima, Tanaka, Emily, Paulina, and Jackson, can you please come over? Yes, give them a round of applause. So this year's dynamic is a little bit different. Last year it was me just interviewing everyone. Here you go. But the thing is that I already passed in this program. I was also part of it, of the second cohort. So I already kind of know the ropes and know how it works. So who are the most interested right now to know what the program is like and what happens? So we picked two new students from the new intake, and they are going to make the questions. So I mean, just briefly, please, all of you introduce yourselves. I mean, the new intakes are like on the corners. It's Bima and Tanaka, so they can begin, and then the older students, well, not old, but from the last intakes, sorry.
Thank you, Marina, for that. Hi, everyone. Myself, Bima. I'm from Nepal, and I'm in the new cohort, 2023 to 2025. Yeah.
Hi, everyone. My name is Tanaka. I'm from Zimbabwe. I'm in the new cohort, 2023 to 2025.
Hello, spoke to you all before. I'm Emily. I was from the second cohort, so 2018. I think I'm the old one that Mariana was talking about. Yeah, I'm from Great Britain, and yeah, was on the course 5 years ago.
Okay, hello everyone. I'm Paulina. I'm from the cohort of 2019-2021, and I'm originally from Mexico.
Hi, my name is Jackson, and I'm from Taiwan, and I am the one who's going to graduate in about 1 hour.
Very good.
Okay, great. Maybe we can ask our questions now. So I wanted to ask you guys, what happened after IDO, like after your program? Yeah.
Okay, so mine was a little bit different because I finished in the middle of COVID. So I did my thesis at the University of Edinburgh and was lucky enough to get onto the PhD program there. Thankfully, managed to get on just before COVID hit, so I kind of started my PhD in the middle of lockdown, and I'm still on the PhD there. So I'm doing a One Health Models of Disease PhD. That's 4 years, and yeah, finishing my studies next year.
I finished right when COVID was finishing, one of the hardest waves, the third one. After we finished, I wasn't sure if I wanted to pursue a PhD, but I liked academia, so I stayed as a research associate. I started working with Bocconi University. My field at the time, I was very focused on vaccines, so I was in an association working at vaccine delivery and vaccine equity. I did it 1 year, and then I moved to KU Leuven as well, working as a research associate. And during the last year, I discovered that I really like academia, so I'm going to start a PhD this year.
Well, I'm not graduating yet, but right now I have a couple interviews in United States. So some belongs to the pharmaceutical company, some's like contract with national defense. I don't know what I'm gonna do over there. Yeah, and yeah, I think that's it.
Okay, so thank you for that. It's interesting to know that a lot of people move into PhD and other different programs. So another question that we have from our cohort is that apart from building professional skills, what do you appreciate the most about the IDO program? So what was the most interesting part apart from building professional skills? Jackson, you can start from there. No, okay.
For me, one of the best learnings from IDO was the multidisciplinary backgrounds that we had. This is something you absolutely encounter, I think, in every work field. So nowadays, although it happens, you have someone, at least one member of your team that is from a discipline completely remote to yours. So to learn how to dialogue with these people and to learn that there's no right and wrong, sometimes there is, but sometimes it's just different perspectives is really important. So during 2 years, we had the medical doctors, we had the vets, but also people coming from a completely different background, like engineering, that had another perspective. So we trained to listen to their points of view, to have an added value without thinking like, no, that's just wrong. Like it's human medicine, what needs to be on top. So to learn how to interact and to process that and so that you can enrich your perspective, I think for me was the greatest value aside from the academic one.
Yeah, I think I would build on that, on obviously in the group work and actually what you're doing within the course, but also you're going to live in 3 different countries, totally different culturally. You are working and living with people from all over the world, and so it's a real good experience to expand your horizons, learn about each other, learn about different places, and you can really take that forward as well. So obviously the course is wonderful and you learn all these different disciplines, but the people you're surrounded with and the countries that you're in, it's a really great opportunity.
I would say this program you're going to learn from the professor that best in this field, and you will learn something that really relevant for in the future you want to apply for a PhD for a job. Take myself for example, because of those flow cytometry, the CRISPR-Cas9, and the experience in the BSL-3 got those interview opportunities. Yeah.
Wow, you guys really took a lot from the program, right? Being IDO being a great program it is, I know it was really hard sometimes. Do you remember any hardest part of the program that you had to experience? Like, this was really hard.
I'm going to discount COVID straight away as not being program specific. I think for me it was, I was working at the same time, so I did the program but was also funding myself, so I was tutoring at the same time. And then also you're in all these new places, which as I was saying, is one of the greatest things about the program, but you really, you have all these opportunities, so you have all of these different universities, different countries, different places you can visit, and you don't want to waste those opportunities. But I was also working and then also doing the program, and so I think the balancing act of it was probably the hardest part, but then also when you get it right, the most rewarding. So, yeah.
For me, one of the hardest part was the 3rd semester. It was in Edinburgh, and it was studying veterinary sciences. That for me was the very first time. So to learn about chickens and fish and the reproductive system and all of these things, it was so new, but at the same time, very enriching because you become very flexible. Like you need to assimilate something that is completely outside your field of expertise, like for a presentation when you're supposed to know a lot, right? So it was very challenging for me, but also very enriching. It was like a point that I thought like, oh, okay, I can do this. I will try my best. So that was hard, but I really liked it.
For me, probably the hardest part was, you come from the different education system or structure. You have to adjust to different kind of teaching style and different kind of exam type. Yeah, so that was that's pretty difficult for me. And another really difficult part is actually the 2nd month of my internship, because that's the time you feel like you're losing all your friends. Yeah.
Actually, you did just mention about the internship, right? So we do have a question related to that. So that we have asked questions like, do you find the first semester to be more difficult, or was it the internship that was more, difficult in terms of the workload?
Okay. So, so mine was slightly different because COVID hit 2 months into my internship. So mine was probably a very different experience to you guys. But for me, I actually didn't find the internship harder particularly. As you were saying, going to different countries with different expectations and different ways of teaching and assessing was probably more difficult for me. When you're doing the internship, you have a single focus, which is the internship and then the thesis. And so I actually found it a little bit easier. But it is true that you've been together with the same people for 18 months and then you all separate and you're all over the world. So we had people in every time zone. So kind of trying to keep those relationships was definitely more difficult. But the workload, I wouldn't have said was particularly more difficult.
I'm still unsure.
Push it down. The difficulty of internship?
Yeah.
I think it's very a lot. It really depends on what kind of program and how you manage your time. So for me, it was, just speak out from my experience, it was really difficult from the beginning because I have like almost zero like coding experience, but I chose something that just do only the coding. So the first 3 months was almost like 10 hours just stay in a computer and try to figure out how to do things. But after 3 months and you start like get a hand of it and it become an adventure. Like every time you do something, you find something new. And it's not just a work anymore, it's like a exploration and it becomes like fun at the end. So I would say it could be difficult, but it depends on your perspective, how you see your internship and how it can lead you to your next steps.
Okay, yeah, now I know. I think it was the same level of difficulty for me. The classes and the internship. It was tough. The social part was tough during the internship because it was COVID and it was lockdown with very strict regulations. So I couldn't see anyone, but at the same time, that was also positive for me because I could focus a lot on my research. Yeah, I don't think I needed a lot of supervision. Like I'm good at planning, so that helped me. I could divide my day into tasks, so that was good. It was nice. It was tough because, of course, when you work with data, it's not easy to find all the data. But I enjoyed it. I mean, it was not easy. It's not easy to just focus on one thing and building data sets and then just testing. But I think it was the same level of difficulty as the courses, I would say.
Okay, great. We have another question. So speaking of being in different universities, like 3 different universities and probably 4 with the internship, did you still remember all of your professors? Did you have a relationship with them? And how did you navigate through that? Because knowing very well that there are many professors at each institution, yeah.
Yeah, that's very true. You meet a lot of people, a lot of wonderful lecturers. I do remember most of them, although I'm not really good with faces, I have to say. If I hear the name, I think I can position most of them on which lectures they taught me. I hope I didn't forget a lot. Maybe I did forget some, but I would say that the lectures are really good. So there's going to be a message, there's going to be a face that will pop up when you hear a title.
Yeah, there are a lot of different professors and you get taught by lots and lots of different people, but you are also taught a lot of different topics, not all of which you are going to particularly be very passionate about. So I would say the professors that I built relationships with were the ones that I really resonated with their lectures. It's on you. You can email them, you can talk to them, you can start that conversation. So that's how I worked it. Like I said, it was really interesting learning everything, and there are lots of different disciplines, but you will always be more passionate about something over something else, and that's when you start really building those relationships with those professors.
Well, opposite to Paulina, I am better at face, but really bad at names. Yeah, so I can probably remember the face, but yeah. I will say definitely you will definitely build out some like closer relationship with some professors, because if some of the professors, they probably taking more lectures, and some are actually require more like interaction. For example, if you do the coding thing, like if you're gonna learn R or epidemiology, you're gonna have a lot of questions. And so, or some like a practical labs, you're gonna spend a lot of time together discussing like why we do this, when we do that. So yeah, so just don't be shy. Any question, ask your professor, and they're all really helpful to answer your questions.
Okay, so let's move to like Barcelona. So do you have any tips for moving to other countries?
Yeah, it is tricky, especially because you're moving for such a short amount of time. I'd say for moving to Barcelona, we, over the first couple of months in France, kind of, as you build relationships and friendships with the people on your course, we kind of grouped up. So we went for apartments in Barcelona, and that worked quite well. I can't speak about Germany because I didn't get to go, so I'll let you talk about that. But I would say talk to people who have been on the previous cohorts about where they lived in relation to the universities, whether they have any tips. That was helpful for us.
Regarding moving to Barcelona?
Moving to other places in general.
Okay. Well, big tips, don't buy too much souvenirs. And then you end up like 50 kilos on your back and 50 kilos on your hands. So, yeah. And if you just talk about Barcelona, I mean, me and my colleagues, we did a road trip. That's probably the most memorable moment in this 2 years. And what we did was we went there because we heard there's a lot of spam or something going on, so we decided to go there first, like get a B&B for a month and then start like looking. Yeah. So for Germany, at least for our cohort, they already arranged the student dorm for us, so it's not a big problem. Yeah.
I think I would suggest the same, to talk to people from the previous generations and get some tips. That's what I did, and I think some other people from my cohort did. And we got some nice tips and suggestions on where to live, transportation, some practicalities. I think every country comes with some administrative challenges, but it's easier when you already know more or less what to do. So feel free to contact.
On like a less practical level though, like moving to another country is hard. So do work out what it is that you want to take to make that easier. And this is going to be super stereotypical, but for me that was tea. So I took my own tea bags for every country. But that was just for me, my home comfort that I needed. Everybody had their own little thing that they'd brought. I would also say think of different places you want to see in the nearby area that you can have for the weekends and stuff like that, to make yourself feel a little bit more like at one with the country you've just moved to. You don't have a lot of time in each place. So just on a less like practical how to find a house level.
Okay, great. So this is our last question. Probably we will talk to you after this. I want to know, IDO being an integrative research intensive program with lab and classes, how much time did you spend in the labs and the classes, and what did you enjoy the most?
I'm not sure of in a proportion how much we spend in classes and lab, but I would say most of the time it was classes, from my perception, but we can verify that afterwards. What did I enjoy the most? Well, I think I've been oriented, pursuing a career in policy making. So I enjoyed those classes that were policy making oriented. I really like the lab, but everything is so tiny. I don't see the cells. I don't see the microgram. So, yeah. So it was, of course, it was nice and meticulous, and it's a nice experience. But for me, it was those lectures.
Yeah, I think I'm the total opposite. I found the policy quite difficult and really enjoyed the lab. So yeah, there's different labs in each university does it slightly differently. So either you have like days in the lab, or there's like there was a chance to do a week in a Cat 3 lab kind of thing in Barcelona. So there was different experiences like that I quite enjoyed, getting used to different ways of working actually in the lab rather than the policy. But that's why the course is so good, to get us to experience everything.
For me, I think I enjoyed the most is like the mobile lab in Hanover. That was they have like scenario, and you have to assume there's like really highly infectious sampling coming in. You have to like dress up, and the professor will be being like a crazy person, come in and say, "Oh, my friends got sick." Yeah, so it's like intense, but at the same time, you're gonna learn a lot. Like for example, even how to design like the mobile lab, how the human and waste how they should flow. So I think that's the one I like the most. And I think the question is also about like the time about lab in a lecture. So I think it varies a lot. For example, in Hanover, sometimes there's a couple weeks we're going around maybe like 8 and then get up by 6. So you're going before the sun comes out, and you left after the sun goes down. Yeah, but yeah, that's it.
Good. Okay, perfect. Thanks a lot. So, I mean, I just have a question actually for Vima and for Tanaka, because they were doing the questions. Are you excited to start?
Yeah, for me, well, yeah, it's a privilege and an honor, to be honest. I'm so excited. I've been taking pictures like since the day I came here. So I'm really excited. Yeah, perfect. And I take it as a learning curve. Yeah.
Okay.
Yeah, same here. I'm very excited. I would rather put it like you know, a lifetime opportunity to be here, to have this diverse background of people sitting in the same panel and listening to all the researchers today as well. So it's a very great opportunity for me, and I think I can make it most of it. So thank you so much for answering all our questions from the cohort. It was really helpful, and I think we are connected. So maybe with WhatsApp and other things, we'll sure hit some other more questions, especially to the
So thanks a lot, everyone. So, I mean, they are from the 7th cohort. So we have cohorts from 1 to 7, 7th generations of IDO students, all with different experiences. But as you can see, I think all of them are good, right? So, I mean, this is it right now for this part of what IDO is. And that is actually like the people that confirm it. Teachers, students, the coordinators, everyone. So, I mean, right now we will have a coffee break. I mean, Data will get the announcement. Yes.
How much did the IDO studies help you grow up and prepare you for the world afterwards?
It's for me. It's for them.
Yeah, absolutely. I would say yes, absolutely. There are things, of course, that I had to learn once I graduated, but I think because, I never encountered them before. But, like moving from country to country and adapting to different places, that's something that I really keep. After IDO, I moved to 2 other countries, and I think the facility to adapt, it came from the 2 years of practice. And the multidisciplinary environment, that also helped. The different nationalities, I think that all countries in Europe are quite international at this point, and just to know, like, you know someone from that country, and at least you have something to talk about. Yeah. So as an icebreaker, for instance, that works great. And so I would say it prepared me in different aspects, but the international part is something I really embrace.
Yeah, I started the course a little bit older than most other students, so I'd already had kind of a teaching career, and then came back into science via this program. So I think from like a professional kind of that standpoint, maybe it was just a continuation, but definitely from learning the ways of academia from different countries, different people, different ways of thinking, definitely I grew as a person.
Yeah, definitely. I think there's no question about like professional aspect, but I think the most important growth will be like the interpersonal skill. As they mentioned, like you have to deal, well, not deal, but like make friends with people from all the backgrounds and different beliefs and different habits. And and also, well, deal as well. You have to learn how to deal with conflicts, and that's really important. Don't you have any drama? Please don't have that. Yeah. Just remember, like these people next to you, they will be your family for the next 2 years. All the good thing, bad thing, you're gonna go through together. So yeah.
Yeah. I mean, I'm not sure.
Do you realize that all the old people in this room are jealous? Because it didn't exist when we did our studies.
Yeah. I mean, now it exists, and we're actually very lucky to be a part of the program and also to be part of like this really big family that formed in each cohort, but it's also like a bigger thing actually. So thank you everyone for listening. Thank you to my wonderful interviewers and interviewees. I will probably, I'm not sure, I mean, I already have my replacements for next year. So, thanks a lot, and I will give the floor to Leila.
Yeah, just to add to what they were mentioning, I think that for the new ones, you're embarking in a great journey, a long one, but you're not going to, you will see those years go by in the blink of an eye, and I'm not kidding, you will see. And this program gives you professional growth, it opens your mind, it gives you a different perspective that if you had stayed at your country, you would not have. So you have something else to offer to whatever, if you go to the research community or public policy, you have something else to offer. And interpersonal skills, as Jackson mentioned, but also like it's a lot of personal growth. So make the best of it and really, like live it to the fullest, because it would be like great. It would be like the greatest journey of your life, I am sure. So just to close on this, we're going now for the coffee break. We have around 20 minutes, so please have a coffee and then come back for the last part of our event. Oh, and don't forget to, while you're having a coffee, to look at the posters and also read the QR code with your phone and vote for the one you enjoy the most. See you in 20 minutes.
So everyone is here, back here, yes? Okay, so we have reached the third and last session of our program, which is called Optimizing the Future Health of People and Animals. Our next speaker is Steph Brunsweier. He is a former lead of the scientific cooperation with the member states and current research coordinator at the European Food Safety Authority. Dr. Brunsweier worked as a medical doctor, shortly at the Social Medical Center Budkas Balad in the Philippines as project manager of a European Union project on communicable diseases, as well in Instituto Superior de Sanidad in Rome. He was project leader for the establishment of the European Antimicrobial Resistance Surveillance System while working at the Dutch National Institute for Public Health and Environment, and has been responsible for the several European surveillance networks on communicable diseases and leads the implementation of the community strategy against antimicrobial resistance while working at the European Commission. His talk is titled Transdisciplinary Cooperation in Europe, so we look forward to listening to Steph about his experience. Thank you.
Thanks, Marianne, for the introduction. Must be old when you have so much to be introduced about. I made the joke too. And I'm saying this also because it was very nice to hear before the break the new generation, the upcoming generation. Actually, I think today we traveled not only across sectors and across tiers, but also across generations. Let me warn you, though, that the border between young and old, and maybe the other old people in the room will confirm, it's actually a sliding border, always in front of you. But one day we'll get there. So my pleasure to speak from the perspective of the European Food Safety Authority, and I take a bit of a larger framework that we operate in to tell you about how we try to operationalize One Health in practice, which is a big endeavor. Nobody has the golden answer to that, but I'll share with you how we're trying to do it. This one is easier to move. Actually, it's an easy one for EFSA, and you can argue, because EFSA actually is a One Health organization, I argue, because if you look at the mission statement when it was established, it has all the components in there. Obviously, at the time, in 2002, it wasn't called One Health, but actually you see the animal health, the plant health, the human health, and the environment all in the mission statement. Now, that's not a surprise, actually, because as you will know, actually, EFSA, the European Food Safety Authority, was established in the wake of the mad cow's disease, which is a One Health issue, a feed issue, making animals sick, on turn making humans sick through food. So not by surprise, it is actually in our mission statement. There's still a challenge, obviously, also to EFSA, because where it's rather well developed and established over time in the area of biological hazards, it's less so in other areas like chemical hazards, nutrition, which are also in our mandate as a European Food Safety Authority. So we certainly have a way to go on operationalizing One Health through EFSA. EFSA obviously does not work in isolation. You can't do that for One Health. And we work since many, many years actually in a very consolidated manner with the ECDC, the Center for Disease Prevention and Control in Stockholm, as well also now more recently with the Medicines Agency in what was earlier referred to as the JACRA report, so the antimicrobial resistance monitoring that comes out and is delivered by us. Actually, currently we're also working with the Environment Agency, because also they will get a new mandate soon to monitor also in the water, possibly also the genetic components of resistance transfer. So we have a well-established cooperation, not only on antimicrobial resistance, also on foodborne outbreaks through the Zoonosis Directive, where we have a deep, long-standing cooperation with ECDC and other agencies, European agencies. If you're interested to find these One Health outputs that we produce on a regular basis, I've provided here the web link where you can find the ones that you see in small script on this screen. I said, I think it's important also at this point to tell a bit more about the European perspective. We've heard a lot about global perspective, national perspective. We had the European Environment Agency. So I will try to broaden that perspective a bit to the Green Deal. Green Deal, if you look with very careful eyes, in some of the Green Deal documents, you will find One Health mentioned. Not so many though, actually surprisingly few still, which is changing, and I'll come to that. But obviously to deal with issues that the Green Deal deals with, like biodiversity strategy, the chemical strategy, the farm to fork strategy, obviously you need a One Health approach. That's very obvious. I want to mention on this occasion also that actually the European Commission, apart from legislation, also runs, as you know, the large research framework programs, RTD, Horizon Europe, which also now increasingly invests in research activities that support policy, that feed into policy. And again, not surprisingly, in these years, actually, there is a number of large European partnerships, which are very large research actions, bringing together many different actors from all over Europe to work on priority areas identified, which again are very close to the Green Deal, and also we can argue to One Health. There's the Animal Health and Welfare Partnership, for example. There's the One Health AMR. There's the Sustainable Food Systems Partnership. And there's also the Chemical Risk Assessment Partnership. So in all of these, you will find certainly aspects and attention to One Health. EFSA is not doing legislation. We're providing scientific advice. We're doing risk assessment for the policymakers. And we communicate on these risks. So I put on this slide, but it shouldn't be confused with EFSA. But again, it's important to understand the framework that we operate in. And the fact that we haven't seen One Health so much in legislation yet is not surprising at all. Because if you're familiar with the European Union, actually the competences vary very much. So it was first defined in the Maastricht Treaty, and then the Amsterdam Treaty, which gave room for public health, then Article 152, which actually is also referred to in the founding regulation of the European Food Safety Authority and many other agencies. And that was enlarged also with the Lisbon Treaty to include also public health on some aspects which are defined there in Article 168. And actually, if you look at the details of that article, you will see that in the area of health, actually the competences of Europe are limited. It speaks about encourage cooperation between the member states. And only in cases of explicit consent and in certain areas, like the veterinary and phytosanitary fields, there is legislative power for Europe as well. But certainly not, and we've seen that with COVID, not in the human health, in the public health arena. That's the competence of the member states. And obviously, that means a lot to how we operate One Health in Europe, because you can't sit at the European desk, draw board, and say, okay, now this is how we will implement One Health in Europe. It requires legislation and actors across very many different actors. A very recent piece of legislation which came out in December last year was the cross-border health threat, the serious threats to cross-border, which in fact is a follow-up of the COVID. It is in follow-up of the COVID, and it actually very explicitly includes One Health in this legislation, which is hopeful for us today for the future. And here, if you look at that, at the details of that legislation there, you will see that member states are asked to set up this response plan, preparedness and response plan, which should be done from a One Health approach, following a One Health approach. And also in another article they mention that there shall be One Health training provided. And there again the agencies also have a role to play to support that. Interesting, in the same legislation you will see that there's also public health risk assessment that can be required by the Commission to its agencies. but also here they're mentioned for the first time all together, so it could be done also in a more holistic, in a more One Health approach. So I hope I've argued for you that EFSA is not only a great place to work, but actually it's also a One Health organization. And after 20 years, on our 20th anniversary, we've organized for that occasion also what we call the One Conference, the One Health, One Society Conference. And the outcome, not surprisingly, is again that EFSA, together with its the other agencies, we call them the sister agencies, with whom we organize the One Conference, they have a role to play, we believe, in One Health, together with the member states, together with the Commission and very many other actors. Because obviously it's the place where the data is being exchanged, where we do the analysis, we provide the scientific advice that is the basis then for the policymakers, both in Brussels and in the member states, to take action upon. So the outcome, in very short, is here that EFSA and its actors shall increase the operationalization of One Health in their activities. And there we do that together with the other agencies. So at the conference, we agreed with the agencies that we would establish a task force on One Health. And we've done so. In fact, we met earlier this week on Monday. We met with the 5 agencies, the EEA, the ECDC, EFSA, the Medicines Agency, and the Chemicals Agency in Helsinki. We do meet now every quarter, and we identified already a number of work priorities, 4 work priorities on which we will develop and push for the One Health agenda, obviously in consort with the European Commission. So the first priority there would be strategic coordination, where we try to be clear that obviously we cannot suddenly implement the One Health approach on everything, because we're bound by legislation to do certain things. So we can't now reinvent the wheel. But coming together, probably it's worthwhile to identify a number of priority topics, again, together with the risk managers, say, okay, for this appropriate, for this task, for example, we would benefit from a One Health approach. An example from the plastics that we heard about earlier. Many years ago, it's in our legislation that EFSA shall perform risk assessment of food packaging materials, including plastics. At the time, we did not realize that the plastics that we use in our food packaging is not immediately exposed to the consumer by food, but also goes into the environment, goes into the sea, goes into the fish, and comes back on our plate through microplastics and nanoplastic materials. So would we have had a One Health approach at the time? Probably we would have worked together with many other actors to come with a more comprehensive answer. So we should learn from the past, but again, we will need to make choices, because obviously doing such a risk assessment is much more resource and will require also more time. The other aspect where we think we can do a lot together as agencies is to inform the research agenda setters, certainly RTD, but also in the member states, to say, okay, these are research needs and investments that we need to push for the One Health agenda. And that we do have experience as agencies to inform about knowledge gaps and research needs. But coming together, we think we can formulate a better informed One Health research agenda. Stakeholder engagement, obviously it would be wise not to have 5 doorbells to ring on, 5 different agencies, but if there's a One Health issue, that there's one port of entry, and I'll give an example on that. And finally, we think it's good to work together also, for example, on building capacity, so for example, training. And certainly also soon the Commission will come out with sustainability legislation, where we think that also scientific advice will be needed from multiple actors. So the example I would bring here very shortly is the azole fungicide resistance. Again, we heard earlier today about the important issue of antimicrobial resistance. This is actually, I believe, for the first time that all 5 agencies, the sister agencies which I mentioned, received a common mandate. And this is important because this means that at the time of the problem formulation, actually it's put in a One Health perspective. So it's not that the scientists at the end think of actually what could be the wider impact, but it's from the risk managers to consider all the different aspects. And their azole fungicide resistance is really important because we know it leads to resistance to aspergillus, which is a very nasty infection. Actually, it seems that there's a significant contribution of environmental exposure to azoles. So luckily, it can be screened through different mutations. But again, we do need the expertise from different agencies together with their networks and the member states to bring together the complete picture and come with a complete scientific advice. So that's ongoing. Thanks again, Dr. Osman Dar, for a very interesting presentation, especially the work done on the quadripartite. I think it's really remarkable that the global entities actually first come together formally. And I think it's worth looking at what they've done and try to follow that path. So do we actually. For example, we've in EFSA started looking very carefully at the One Health theory of change, not only the definition obviously, but also the theory of change. And especially we did a survey amongst our colleagues in EFSA on what they experience as main barriers, which again is a large part of the theory of change. First, understand the barriers before you come with feasible solutions. And not surprisingly, they're very much aligned with the theory of change barriers described. In addition to what are the high-level barriers, we also asked our colleagues to be a bit more concrete. And like I already mentioned, I think probably the biggest issue, if you look at the proportion indeed, is the boundaries of the regulatory frameworks. Even if we want to have a full comprehensive approach, we cannot always afford it. One, by resources, but also by the regulatory framework that we operate in. An example, for certain food additives, we do the assessment, and for the same additive that goes into feed, we are also required to do the environmental risk assessment. So by the same chemical, actually, it's not the same process which is regulated through vertical legislation. So there we have an issue which we cannot solve on our own. It's also not easy for the legislator because of the other competences, differences in competences that I explained. But it's something to be addressed. Linked also to the data protection limits, obviously, we're also not always free to share the data that we are collecting as we would want to with our counterparts. Again, that is something not easy to solve because, of course, we will respect the legislation. But I think it is important to find solutions also in that area. On this one, I'd like to mention again one of the barriers described already in Theory of Change is the limited education in One Health. And also there we found resonance with our colleagues. EFSA is working through scientific panels. We have 10 scientific panels on many different areas, and we have about 100 working groups active each year. So we work with something like 1,500 experts on a daily basis. Obviously, we select those experts because of their expertise, so it's the in-depth knowledge in their scientific discipline. What we see more and more is also the need to integrate, which is actually one of the fun things to work in EFSA, because that's the place, that's the table where this knowledge comes together, where people sitting in the same panel, the same working group, have different backgrounds and complement each other in their knowledge. Still, we would need, for example, better attention also for social science, for statisticians, etc. So it's important that our disciplines, our access to the scientific disciplines is not only deepened, but also broadened. And especially the knowledge integration is a more and more important area. I like this paper that I want to bring to your attention, which I think fits very well with what I've seen today from the master of the IDO, namely that it's not enough to do the training. I loved your description of the internship because that's where you go into practice. So you need a mindset, you need the knowledge, you need the skills. So there, I think, I hope actually it's the beginning of also a relationship through Mariana with EFSA, who has been to EFSA for what we call the EFSA traineeship. which is something that we open every year. So hopefully also in the future, people may find their way. And also maybe through the fellowship program, which I'll mention later. Another very brief point I wanted to make is in the One Health Joint Plan of Action, which we heard also about earlier, there's quite some attention also for Action 6.4 to create an interoperable One Health academic and in-service training programs. There's a number of concrete suggestions on what shall be done. And also there, I think you can play a role together with many others, obviously, to make sure that the lifelong learning is empowered, but also the other educational aspects which are mentioned in this joint plan of action. One I mentioned because I was involved here is the competence framework for field epidemiology training, who will soon, hopefully in a couple of weeks now, will come out with a framework, a guideline on how these national or regional competencies can be developed for field epidemiology training, which brought me back to today because it was wonderful before the break to hear about the alumni, because I've sat in this training 25 years ago, and I confirm that it creates lifelong bonds, which are really very important also for the public good. So I think you're on the right track there. So with that one, I finish. Also in EFSA, we have established what we call the EOFORA training, so a fellowship program for people to be trained in a different country for a year long, with training in the field especially, but also some modules, theory models, which is very much mirroring the EPIET training, which is a longer standing program run by the ECDC. Well, also this program is open yearly, so should you not be interested in the EFSA traineeship, you might be interested in mid-career fellowship program. So that's my contribution for today. I hope to see you in Parma. Thank you.
Thank you, Steph. Does anyone have any questions for Steph, Dr. Ronswire? No? Anyone? Okay. I mean, I'm just going to add here because, oh, okay, perfect. Okay.
Thank you very much. It was very inspiring. I have maybe a naive question, but given now we're talking about integrating more and more disciplines, more and more people, where does artificial intelligence could sit in trying to enhance even the capacity to make the right models, just to highlight where the right direction should be, and in a neutral way as well, so that the communication might be easier as well between the different communities?
I don't have the answer to that. I do know that it has been mentioned in the action plan already, artificial intelligence, by the One Health Action Plan. And actually also in our survey, it came out from my colleagues that there is a need for, because one issue obviously which for One Health is particularly challenging is the jargon used of the different scientific disciplines. So ideally, probably we will need to train also the language schemes for artificial intelligence to make sure that they don't mess it up and that they do help us indeed. Personally, I'm a believer in artificial intelligence. It will bring challenges, but also a lot of opportunities, I believe.
Okay, any other questions? No? Okay, well, I mean, as Dr. Steph was mentioning, I mean, I was a trainee at EFSA, so for all the students, past students that are here, it is also like a great opportunity, like both EOFORA and both the traineeship. So, I mean, EFSA is actually a really good place to work.
She wasn't paid for this.
Yeah, no. Okay, so we're up with our next speaker. It's Professor Mark Stevens. He is the chair of microbial pathogenesis at the Roslin Institute in Royal Dick School of Veterinary Studies at the University of Edinburgh. His laboratory studies Salmonella, E. coli, and Campylobacter infections in farmed animals, with an emphasis on the host and bacterial factors influencing persistence, pathogenesis, and protection. He uses his knowledge from these studies to develop and test strategies to control animal and zoonotic infections, and his team has received international prizes for research that replaces, reduces, and refines the use of animals in the development of veterinary medicines. He has served as the Director of Research at Roslin since 2015 and has played a key role in securing strategic investment inside the Institute. So let's give his talk is titled, sorry, Role of Bacterial Vaccines in Control of Antimicrobial Resistance. So please welcome Professor Mark Stevens.
Okay, so thank you so much to the organisers for the kind invitation to speak at the meeting, and many congratulations to the students that have been recruited to the IDO programme and to those that will graduate soon. From what I've seen, it's really impressive, and your achievements are remarkable. I'm going to speak about the role that bacterial vaccines could play in control of foodborne diseases and also antimicrobial resistance. And I'm particularly going to talk about this in the context of vaccinating farmed animals that are a reservoir of many of these bacteria. But first, just for a little context, the global scale of animal production is vast. According to the Food and Agriculture Organization in 2021, just considering poultry, some 74 billion broiler chickens were reared for meat, and laying hens produced some 1.6 trillion eggs. And there are similarly vast numbers of other food-producing animals produced each year. And this trend has been growing for decades inexorably, and by all accounts will continue to do so at least to 2050 owing to population growth. Now, obviously, we recognize that there are impacts of this agriculture, and these are on the environment, climate, land use, and biodiversity. But farmed animals still play a critical role in mitigating hunger, malnutrition, and poverty, where an inexpensive protein source in low and middle income countries can have a huge societal impact. Now, it's a similar picture in aquaculture, and remarkably today, we now produce more seafood in aquaculture systems than we actually catch in the wild. And this looks set to continue. Aquatic species have a relatively light carbon footprint, and they've only recently been domesticated, and so there's much scope for genetic gain through selective breeding. Now, these are broadly the regions where these animals and fish are produced in the world. You can see that Brazil, China, India, and the United States, not by order there, are major producers. And it's therefore perhaps not surprising that when we look at where antibiotics are consumed in terrestrial farmed animals, that we find that these same regions are responsible for a substantial amount of animal use. You've seen this slide from Professor Ploy earlier, but for me the most remarkable statistic in this analysis is that in 2020 it was estimated that nearly 100,000 tons of antibiotics were used in terrestrial farmed animals. And you should just reflect on that for a moment. If you think of a kilogram jar of antibiotics on the table in front of you, it's 100 million of those used in farmed animals every year. Now, the picture in aquaculture is somewhat below that, but even here, just across the 6 key species, some 10,000 tons or more of antimicrobials were used in aquaculture, and these are often just tipped into the water in which those fish are being reared. So there are obviously concerns about environmental residues of these antibiotics and the impact that might have. So why do we do it? Well, of course, farmed animals suffer from infectious diseases just like we do, and they're often used in control of enteric, steric, and respiratory diseases, also in the context of dairy production, mastitis in ruminants. We can use them to prevent infectious diseases, but also to prevent the spread of those once a population is exposed, so-called metaphylaxis. But remarkably in the world today, much of the antibiotics that are used in farmed animals are still used for the promotion of growth. And this is done at subtherapeutic levels, which is of concern because the microbes are not killed by the antibiotic at those concentrations and can evolve resistance under selection. Now, this is a study that I and some collaborators at the University of Cambridge did, just looking at the consequences of using a lot of antibiotics in pig production or little. And here we looked at 50 pigs on farms with high or low antibiotic use, and then we sequenced all of the DNA in their gut contents. And this metagenomic approach showed a very clear correlation, whether between antimicrobial usage by quantity or the number of different antibiotics used on a premises, with the number of different antimicrobial resistance genes that could be detected. So the more we use and the greater diversity of antibiotics we use, the more different antimicrobial resistance genes we see. That's alarming, but it's also promising, because if we withdraw it, we should see the trend hopefully go in the other direction. So what types of antimicrobials are we actually using in farmed animals? Well, there are actually 27 different antimicrobial classes that are used in animals, and most of these will have a human counterpart. There are actually only 9 classes that are exclusively used in animals. And the top 3 classes by sales for animal use worldwide were of the same 3 types that WHO considered to be critically important in human medicine. This fattening drug actually had a high concentration of tetracycline in it. So, you know, there's genuine concern about the quantities of these clinically relevant antibiotics we're feeding to farmed animals. And of great concern, this isn't strictly regulated in all countries across the world in the same way. Here in the European Union, we have a ban on the use of antibiotics as growth promoters. But many of the countries that are responsible for the greatest proportion of antimicrobial use don't have any ban on their use as growth promoters. And as we've heard from others, this is a highly interconnected system, such that resistances that evolve in one country can rapidly spread via trade and travel to other countries through the food system. And we've seen this with the emergence of colistin resistance, first in pigs in China, and with NDM1 beta-lactamase in the Indian subcontinent. These are now routinely found in diagnostic surveillance in Europe. So we can't be isolated from the use of antimicrobials elsewhere. Now, we know that this transfer of microbes and resistances from farmed animals to humans occurs because of foodborne zoonoses. And my lab in particular has studied these 3 organisms, Campylobacter, Salmonella, and virotoxin-producing E. coli. And they're responsible for a substantial number of cases of acute gastroenteritis in people. And depending on the nature of the pathotype or serovar, they can also cause severe disease and death, particularly in vulnerable groups like infants and the elderly. Now, we know unequivocally that that poultry are a major reservoir of human campylobacteriosis, that eating contaminated beef is a major risk factor for human VTEC infections, and Salmonella is often found in poultry, pigs, and cattle, and again transmits through the food system to cause disease in people. These organisms, when we study them in national surveillance, very often highly antibiotic resistant. These are tetracycline-resistant Campylobacter jejuni, and you can see here some 60% of them are now routinely found to be resistant. This is ciprofloxacin-resistant, maybe slightly lower, but still very high prevalence of these. And these organisms are on the list of WHO priorities for R&D to combat antimicrobial resistance. So for some of these, like Campylobacter and Salmonella, they're a high priority, and for some, like E. coli, it's now considered critical that we have new antibiotics to combat them. So what role, if any, can vaccines play in the control of these foodborne pathogens, including in their animal reservoirs? Well, I think history tells us that they could play a significant role because of the impact they've had in controlling salmonella that derives from chicken meat and eggs. These are human laboratory-confirmed cases of salmonellosis in the UK over the last few years and decades. And you can see during the 1980s and 90s that we had a significant pandemic associated in particular with Salmonella enteritidis phage type 4. And it was at this point that it became mandatory under a national control program to vaccinate laying hens and broiler breeders. And that's credited with having substantially reduced the number of cases, albeit this national control program included other measures, including related to feed and biosecurity. But nevertheless, it's thought that vaccines have played an important role in protecting public health. But you'll notice it hasn't reduced to zero. In fact, we still have an estimated 50,000 cases of non-typhoidal salmonella in the UK each year. Now, that might partly be because the vaccines are serotype specific. So a Salmonella typhimurium vaccine would protect against that, but not necessarily Serovar enteritidis. And it's also the case that Salmonella can reach us through the food system via imports, where these vaccines might not be being used in other countries. And it can also reach us from pigs and cattle, where we don't currently have effective vaccines. The situation is even worse for Campylobacter and VTEC. We don't have licensed vaccines of proven high efficacy for these yet for farmed animals, and there's a pressing need for that. So how do we go about designing those vaccines? Well, we have no shortage of genetic blueprints for these organisms, literally hundreds of thousands of draft and complete genome sequences now for these three organisms. But staring at these circles of DNA won't tell us which of the encoded genes play a role in persistence in the animal and the induction of pathology. It won't necessarily tell us which of the encoded proteins elicit protective immunity or how they do that. We can look at whether key antigens or epitopes are conserved among the genomes of circulating strains. But again, it's very difficult to work out how we're going to elicit durable cross-protection in diverse animal populations with different genetic backgrounds. And of course, farmed animal research is very expensive. We use sentient animals. So how are we going to do it with minimal animal use? Now, for this, my lab has adopted a very powerful technique called transposon-directed insertion site sequencing. Sometimes this is called TN-seq. I won't go into all of the detail of how it works, but we use a transposon to randomly mutate the genes in the chromosome. Think of this as a kind of jumping gene. It inserts almost at random into the chromosome, and when it does, it typically inactivates that gene. And we then use a clever form of massively parallel sequencing to copy the flanking regions either side of those transposon insertions. Now, we do this with a pool of mutants, sometimes several hundred of them. And when we apply the sequencing methodology, we can see to the nucleotide where the insertions are, and the number of sequence reads that we obtain for those mutants gives us a measure of their abundance in the pool. And if we do this both before and after infecting an animal, we can then understand the role that those genes play in infection. And in this hypothetical example here, you can see that in gene B, there are 3 insertions at these positions, and that the sequence reads are present both before and after infection in this hypothetical animal experiment. So this tells us that gene B is mutated, but it doesn't play a role in vivo because there's no selection on the number of reads before and after infection. Whereas here with gene A, you can see, again, 3 mutations with sequence reads present in the inoculum, but these are absent or underrepresented in the output from those animals. And consequently, this gene must be important for infection because the mutant was present in the inoculum, but it's missing after infection. It's been negatively selected. So to cut a very long story short, this has been remarkably powerful for us to find salmonella genes that are involved in colonizing cows, pigs, and chickens. We've made a very comprehensive library of some 8,500 mutants. These red lines are where all of those insertions are located in the genome or across its plasmids. And we've been able to screen the same library by oral inoculation of calves, pigs, and chickens. Here, in calves and pigs, we could screen almost 500 of them at once. So instead of testing one mutant, one animal, we can put nearly 500 into those animals and find out what happens to them simultaneously. And this methodology unambiguously found the identity and fitness of about 90% of the mutants that we screened. So from these studies, we got roles for nearly 3,000 salmonella genes in their key reservoir hosts. And what things really struck us after this are that there's a conserved subset of genes that Salmonella uses to colonize all 3 hosts, but equally you find factors that appear to act in a host-specific way. Genes required to colonize a cow, not required in the other hosts. Of course, this is important information for vaccine design because something designed to be effective in a cow, if it relies on one of these factors, might not necessarily be protective in another species. Now, not only have we been able to understand how the gut gets colonized, we've also been able to follow the role that Salmonella genes play as infection spreads within the host. This is a slightly different technique. Again, I won't go into the detail, but each of these black spots here is the signal that we return for a different bacterial mutant. And we can follow those in surgical models from the inoculum into the gut mucosa, spreading to the lymphatic system and escaping via efferent lymph and arriving at the visceral organs. To cut this story short, there are niche-specific virulence factors, not just host-specific ones. Some Salmonella genes are important in the gut, but not in the circulation or in the other visceral organs. And equally, there are some that are required when Salmonella are in the liver, but not in the gut. So again, this is key information if we want to understand how to design a vaccine. Now, another thing that's really important is, I've spoken about Salmonella as if it's just one organism, but actually there are thousands of antigenically distinct serovars, and they don't all behave the same. This is an adaptation of the TN-sec methodology, where I've taken a pool here of 11 different Salmonella serovars, and we've inoculated one calf with all 11 in equal proportions. And you can see that after infection, they don't all behave the same. Salmonella typhimurium here rapidly outcompetes the others in colonizing the gut. Others are able to cause a greater degree of systemic colonization. All of them were able to get into the lymphatic system. So there are not only host-specific virulence factors, niche-specific virulence factors, but also serovar-specific ones. And we'll have to need vaccines that can cope with this natural diversity in the serovar. But where to start? You know, we've got hundreds of candidate genes with which we could make live attenuated mutants, or we could express subunit vaccines, but it's really hard to predict at the outset what balance of persistence, protection, and safety we will achieve by mutating a specific factor. There are various ways in which we're trying to do that. But one thing's for sure, it will need to be inexpensive if it's to be applied in farmed animals. The margins are so tiny. Just coming to an end shortly. We've also done this very same sort of set of screening methods here with Shiga toxin-producing E. coli 157, that we did in calves at containment level 3. And here we find, again, major region of the chromosome, critically important for colonization. This encodes this remarkable molecular syringe which the bacteria use to inject their own receptor into cells lining the gut, to which they then bind. And if we take components of this system, the needle, the receptor, and the adesin for that receptor, and vaccinate cows with them, we can protect them. And this is work done in collaboration with David Galley and colleagues at the Roslin Institute. And they have modeled that if you applied this in cows, you would see a public health benefit. So we have an effective vaccine that could have public health benefit, but currently it's not licensed. And one of the reasons is who pays? E. coli 157 is absolutely deadly in people, but in cows, it's asymptomatic. So the farmer doesn't get a direct benefit from it. So who should pay for the vaccination of cows for E. coli 157 when the benefit isn't to the farmer, it's to the consumer? And that's where we might need mandatory national control programs and pressure through the food system. Just very briefly, there's many challenges in the design of veterinary vaccines. Because the margins are so tiny, they have to be inexpensive and easy to administer. For chickens, it's getting really tough because they live for such a short time. Some broilers are in the food system 5 weeks after hatch now as football-sized supermarket chickens. And obtaining protection in that short duration is challenging. And also, chickens aren't feathered mice. you know, they have significant differences in the repertoire and function of their immune system. And that makes it difficult often for us to study immune responses and how they protect. And remarkably, for reasons I don't understand, a national survey of immunologists found that less than 1 in 20 would consider working in veterinary vaccinology. So we've got a real challenge to train people to work at this critical interface if we're to tackle zoonoses. So just a few marks in conclusion. Antimicrobial use in farmed animals is substantially greater than humans. This chart is astonishing. The grey bar here is what we use in humans, and everything above it is what we use in farmed animals. We must have international action to try to regulate antimicrobial use, particularly as growth promoters. But I do think that vaccines have an important role to play in control of these diseases. I'll thank those people that were involved, and I'll take any questions you might have.
Does anyone have any questions for Professor Stevens? No? Okay. No, it's because we're running a little late on time. But he's around, so you can also ask him. Okay? So we have reached our last speaker, which will be joining us online. We will stay with the same topic, which is AMR. So we're going to, the speaker now is going to be Dr. Jungxie Song. She is the Senior Animal Health Officer in the Food and Agriculture Organization, AMR Coordinator, Unit Head, Lead Technical Officer for the AMR Quadripartite Collaboration, and she is also the coordinator of the endemic zoonosis diseases, which includes rabies, brucellosis, and zoonotic tuberculosis. She will be presenting One Health and AMR, youth engagement at FAO. So you can take over whenever you want. Dr. Jungxie, thank you.
Thank you very much, Chair, for your introduction. So good afternoon. I'm really delighted to be here to join this infectious disease and One Health event remotely. So let me put on my slides. Just a moment. Can you see my slides? Okay, so I would like to take this opportunity to provide an overview of promoting One Health approach, addressing antimicrobial resistance in agri-food system. And also I would introduce some youth engagement activities within FAO. So those are the two main segments of my presentation today. So this is the One Health specific definition developed by the OLAP, One Health High-Level Expert Panel, supported by Quadripartite, namely FAO, UNAP, WHO, and WOHA. This definition is really a big shift for One Health, covering a broader scope, not only zoonosis disease, AMR, but also much beyond than that. So here, this is the FAO strategic framework, focusing on supporting transformation to more efficient, inclusive, resilient, and sustainable agri-food systems to achieve four betters. We say better production, better nutrition, a better environment, and a better life, leaving no one behind. So under this strategic framework, 20 prioritized program areas were identified. So including this One Health prioritized program area, we call it One Health PPA. So under One Health PPA, there are 5 components, including improving early warning system, better biosecurity for pest and disease management, and more effective emergency preparedness and response, and heightened AMR risk management, and enhance One Health systems integrating the environment. So basically, this is the overarching One Health framework in agri-food system, which is also very much aligned with the global One Health joint plan of action, which is developed by the 4 organizations. So AMR is one of the key components of this One Health PPA FAO, and also the SO is a one extract of the One Health joint plan of action. So I think the previous speaker already elaborated very well why addressing AMR is so important for food-producing animals. And it's around 73% of antimicrobials sold globally are used in food-producing animals, namely livestock animals and aquaculture. And 76% of antimicrobials used in food animals are also very important for human medicine. So to support FAO members to mitigate AMR emergence and spread, FAO published the AMR Action Plan from 2021 to 2025. It sets out 5 objectives, including increased awareness and stakeholder engagement, and surveillance and research, enabling best practice to prevent infection, promoting responsible use, strengthening governance. So up to now, more than 60 countries have received technical support from FAO through implementing like projects or applying FAO tools, interventions, or products. So here I would like to highlight 3 key flagship activities for addressing AMR in aquaculture system. This is the first one, FAO International Antimicrobial Resistance Monitoring Data Platform. The acronym is INFAM. So to support the evidence-based policies through data generation and sharing, FAO established this platform to collect AMR data in aquaculture system and also EMU data in crops. Here, and in global level, we really have a very good aligned effort with WHO and with WOHA. WHO work on the data to collect all the data from human side, including AMR and AMU data. WOHA will collect AMU data, focusing AMU data for animals. So FAO collect the data, AMR data, but also covering AMU data in crops. So it's really very good synergies between the global organizations. So then here is the visual identity of INFAM. But where we are now, we already finalized the pilot phase. And we already, in the pilot phase, we tried just make some fake data. But now we start to receive real data from the countries. The global rollout will happen late this year or early next year. So this is the second initiative. FAO is preparing to launch a 10-year initiative to reduce the need for antimicrobials. So we know that overuse and misuse are the main reason why antimicrobials is being a big problem in our food systems. By effectively reducing the demand for antimicrobials, we can achieve cascading benefits, including, for example, decreasing residues in meat, milk, and eggs, lowering the release of resistant pathogens into soil and water, and also reducing the contamination to the environment. So in 2021, AMR Global Leaders Group, this is a quadripartite government mechanism, called for a significant reduction in the use of antimicrobials in food systems. And similar, FAO members also request FAO to take actions to reduce the need in agri-food system in governing bodies meeting. So to align with this GLG call and also with FAO members' request, we are now prepared to launch this global initiative, reduce the need for antimicrobials in agri-food system. The acronym is RENOFAM. So I think the previous presentation focusing on vaccination. So it is vaccination, through vaccination to reduce the need is really a key action track in this RENOFAM initiative. So the idea is to support the farmers and the producers, reducing their need for antimicrobials. But if it is really necessary for the farmers, we will support them to use these antimicrobials responsibly. So just a bit more background. Last year, 3 AMR targets by 2030 were endorsed in the Amman ministerial level meeting. So two of these targets are really relevant with the antimicrobial use in livestock in agri-food system. The first one is zero use medically important antimicrobials for human medicines in humans for non-veterinary medical purpose, or in crop production for non-phytosanitary purpose. It means no preventive use, no growth promoter will be allowed. So the second one is reducing the total amount of antimicrobials used in agri-food system by at least 30 to 50 from the current level by 2030. So the FAO Renal Farm initiative, we will take these two targets as indicator to really monitor the progress of reduced need, because reduced need is really complicated to monitor. So we will take these two targets as indicator. So the third one, antimicrobial AMR multi-stakeholder partnership platform. This is a quadripartite initiative established. This is a inclusive international and platform aiming to bring together all the relevant stakeholders across the human, animal, plant, environment interface to really address AMR and bring in a One Health approach through a One Health approach. So the platform was launched last year during the Awareness Week. So now we will prepare the first plenary session. So we already received more than 200 applicants. Those are all the champions from the 5 clusters, including the government, the civil society, private sector, academia, and also resource partners. So those are the quadripartite collaboration, one of the quadripartite collaboration efforts. So maybe you are aware, the quadripartite comes based on the tripartite. Tripartite used to be WHO, WOHA, and FAO. Now with the UNEP joint effort officially in 2022. So we already have the first in-person meeting on March, and also come up with the global call for action focusing on One Health. So now I will move to the second part, the youth engagement. FAO will also already put out so much effort to engage youth. We are following the definition, what the age of the youth. We are following the definition of the UN definition, which defines the youth as persons between age 15 to 24. So there are around 1.2 million young people, and falling within this age range is about 16% of total global population. So engaging youth is definitely crucial. When we invest the next generation, we are really essentially investing in our own future. Those young minds have an incredible ability to introduce innovation and diverse solutions that we might never even think of. So they are very skilled at taking complex technical concepts and transforming them into enjoyable, interesting language, which is really impressive. So we have organized various initiatives aimed at engaging youth people campaigns to place their demands and suggested solutions at the forefront of One Health advocacy. The events like, for example, One Health Youth Dialogue and One Health Youth Art Contest. We have teamed up with some remarkable and creative artists. What they are doing is really amazing. They are effectively helping us bridge the gap between those complex concepts, for example, antimicrobial resistance, and how they play out in our day-to-day lives. Pictures here, artists from around the world, they are getting involved. So there is a spoken word artist from Belgium, a singer, songwriter from Philippines, graffiti artist from Kenya, and a TV show host from Ghana. So they are not just artists. I think they are really like magical translators, breaking down those significant ideas and making them very easy to understand to all of us. So in 2022, I feel we are partnered with the REACT to engage youth people in discussion about antimicrobial resistance. With FAO support, REACT Africa hosted the Food Without Harm, Reducing the Need for Antimicrobials competition in African Union university students. And in the meantime, in Asia, the similar competition was organized. After that, and the reducing the need for antimicrobials, we organized a very successful regional dialogue on the youth engagement. So, and now I have just a couple of slides showing the youth engagement activities for this year. So there is a launch a special prize, Global One Health, Transformative Research Challenges, which is a collaboration with Wageningen University. This challenge aiming to spotlight the necessary for a global approach to effectively preventing emerging infectious disease and managing crisis responsibly. So currently we are in the final stages. We have selected 10 proposals. They are now prepare their presentation. We will invite them to showcase their work in the World Food Forum flagship event on October 17th. It will happen in FAO headquarters. And so the Global Youth Dialogue on Sustainable Life Cycle Transformation is set during the conference. This will happen from 27 September. We are going to sponsor 30 participants from low and middle income countries and aims to bring together 200 young people. This is Youth Dialogue created by youth and for youth. So building on our past and present audience, we intend to launch a One Health youth community of practice. This platform will enable youth individuals to connect and networking, sharing perspectives, inspiring sustainable changes for the future. So our effort is really aligned with the quadripartite, we say the 4 organizations. And the quadripartite is establishing the working group on youth engagement for AMR. This is really a dynamic coalition of organizations focusing on youth. This group aims to kind of imply young people's voice and experiences, harness their expertise, energies, and ideas. So the working groups also draws from existing youth-focused work, like what FAO is doing, and there are similar activities from other organizations, from UNEP, from WHO, and WOHA. So going forward, our future plans will involve expanding our youth engagement to include a more broader audience. We have initially focused on more multidisciplinary university students, including from public health, animal health, environment health. We are aiming to broaden to our scope. So build on the experiences and the successful stories, we developed the youth engagement strategy. The acronym, I really like the acronym, OYES, aiming to encourage and inspire young individuals to consider the future, the design, and how they can their present and future actions. So under this new strategy, we will strengthen our partnership, including the 4 layers and the cross-divisional and regional country, and also with the offices, the quadripartite, and external partners. So for the youth engagement, for short summary, FAO aims to take a really inclusive approach when really facing future challenges in One Health. This framework is built around the theory of change, which recognize that urgent actions is required globally, regionally, and nationally to achieve this sustainable development for youth and vulnerable communities. This proposed strategy aims to promote and inspire young people to think about the future they want and how they can how they can take actions when they facing the One Health issue, like an ecosystem, animal health, human health threats, and even social economic damages. So this is my last slide. I just want to share this news with all the participants. FAO DG, Mr. Dr. Qu Dongyu, established FAO Youth and Women Office in International Day just a few days ago. Over the next years, this office will aim to strengthen FAO's capacity to serve these members, particularly by advocating the interests of young people and women. So this will mark really a significant milestone for youth engagement in AMR and One Health. I will really appreciate my colleagues to helping me to putting together and the slides. Thank you very much for your attention.
We have time for questions due to we're short on the program and there's a very important event coming up for cohort 5. But thank you so much, Dr. Yongxia, for this really important insight on AMR and what FAO is doing.
Thank you very much. If you want to have any further information, yes, please feel free to contact me. Thank you.
Thanks a lot. Okay, so we have reached the finishing point of the day, right? But we were constantly telling you to vote on Menti for both the posters and for the flash talk presentations. So this is a very important moment as well, because we will be announcing the winners. So also if I call your name and you won, first of all, congratulations, and then you can come forward because we have a tiny gift for you. And so the winner of the flash talk is Paulina Morales Ruiz. And the winner of the poster is Emily Watts.
Thank you. Thank you very much.
Well done. Very well. Okay, so after seeing our winners, the day has come to an end. I know most of you are tired, but I hope you learned a lot and that you could really notice the importance of One Health and the importance of, like, for example, what the IDO program is doing. Well, first, this is the end, but not the end of the day, because we still have the graduation of the 5th cohort. So if you want to stay for that very important event, you can stay here in the room. If not, I mean, you can leave, but it's a really nice moment, so I would recommend you to stay. As well, I mean, we would just like to thank everyone that is helping us today. First of all, our coordinators, the participating universities, Morgan, the technical team down there, because they made everything run so smoothly. Our student speakers, the poster presenters, as well as our amazing speakers today, because they came, they spoke with everyone, they answered our questions. Also, for example, the new intake, new students, past students. So thank you so much for being here today. Without you, this event would not be possible. And also thank you for being a part of this, of the IDO family. So, I mean, now they will show a really nice video for the graduation of the 5th cohort. And well, I mean, the 2nd IDO day has come to an end. So congrats to everyone.
Okay, so perhaps before starting the video, yeah, if all the graduate students could be here and get dressed, even that's a pity because some of them has a very great local dress, so but perhaps you could see them after that. And also, when I will call you the newcomer, please come here on the stage, and then you will go back on the room with the stairs, okay? So ready for the video, so you will see that they worked a lot, but I think they had fun too. Okay, so you see that they had great time too. Even if they said that they work a lot, I should say yes, they work a lot. Okay, so for starting this welcoming and graduation ceremony, I will first call on stage the other coordinators. So from MRR, so the Hannover Medical School, Jens Bohne. I don't know where he's there. And Jürgen Merching from the University of Tours, Denis Brown. So they will help me giving the diploma. I think that you know that all of you succeeded in achieving this master degree. So congrats in advance. I would like to thank all the organizers for the second edition of the IDO Day. I know that was very, very heavy work, so thank you very much for that. Thank you for all the staff too. And also I would like to thank our colleagues from the University of Edinburgh who came for the defenses and for the second edition of the IDO Day, and I really appreciate our collaboration and friendship. Okay. So first of all, we will start with a welcoming ceremony. So perhaps few words first on the new intake. So that's the seventh one, and for the moment, the last one benefiting from the support of the European Commission. So they will have to apply again. Since I will stop managing the program in 2025. So I still have work to do. So for these cohorts, there were at the beginning 22 students, and finally there are only 21 because one student decided finally to quit. That was not corresponding to what she was expecting. So 22 students, 17 nationalities. No, sorry, I mixed the fifth and the seventh one. Yeah, that's the problem when you are a lot of in different cohorts. So for the seventh one, so the new one, so 22 students, all of them are supposed to arrive, 17 nationalities, only 7 men. I don't know why. 6 vets, 1 medical doctor, 1 PharmD, and 14 different, biologists with different backgrounds. So you will see the diversity. So I will start calling them. So that's not in the alphabetical order of the country. So please get ready. Okay, so first of all, from Bangladesh, Tanjimul, I know he's here. So please take the floor. Tanjimul, just come on the floor. You will be on stage, yeah. Okay, yeah, and you can go and take the stairs. So Lucia will arrive next week from Spain. From Pakistan, so 2 Pakistanis, Zoa and Jahan Zaib. Sorry if you are not pronouncing correctly. Nice to meet you. Okay, so 2 Pakistanis this year. Oops. Mena from Egypt, he will arrive next Monday. Claudia Lorena from Mexico. She already has fans. Ashley from United Kingdom, sorry. Ricardo from Brazil. Marta from Georgia. Olufumbi from Nigeria, she will arrive next week. So 2 Belgium girls, so Sarah and Jeanne. Yes, Sarah. Did I made a mistake on the nationality? No, that's fine. So Sarah and then Jeanne. You're French. Okay, so sorry. I'm so sad that we don't have any French students, and we have one, and I missed it. Incredible. Sabrina from United States. Josephine from Germany. Three people from Nepal, so Bima, Rabina, and Pratik. Pratik already wants to be with the teachers. So from Romania, that's the first time that we welcome students from this country, so Teodora and Irina. So one is on the left, and the second one arrives on the right. So I don't know who is Teodora? Okay. Tanaka from Zimbabwe. Fernando from Costa Rica, and once again, that's the first time we have this country. You've seen he already had a talk this morning. And to finish, Hema from Netherlands and Italy.
Thank you.
Not enough room on the floor for the picture? So usually we say the tall behind and the short in front. But yeah, that's not bad. Is it fine? Okay guys, so you are in French, so you say cheese for the picture. Thank you very much. Okay, so you can go back to the room with the stairs. So about the fifth, this time I'm correct. So about the fifth cohort, so the cohort 2001-2030. So as I said, there were 22, and finally there are only 21 at the end. That was the only cohort with a perfect gender balance, 50-50. So that's impressive. We had 7 vets, 5 medical doctors, and 10 biologists. So I will start. So coming from Netherlands, Sarah, during an internship, she went far on the north of Germany in Reims at the Friedrich Loeffler Institute when she worked on the evaluation of surveillance strategies for African swine fever in wild boars. Also coming from Netherlands, Jolene. She spent 6 months at the Pasteur Institute in Paris working on structural biology and epitope mapping. So for this cohort, we had a big batch of Nigerians. So let's start with a woman, so Shidi. Shidi went to the US working on the effect of natural products on apicomplexa such as Toxoplasma gondii and Cryptosporidium parvum. Then Tariq, that we call Tariq Q, because we had two Tariq in the same cohort, so Tariq Q and Tariq K. So Tariq Q was not able to come today, so we will miss him. And he was also in Reims at the Frederick Lefort Institute, working on measles virus and new treatments. So this guy is not Tariq, okay? This guy is Sujan from Bangladesh, but he's in charge of collecting all the diploma for his classmates.
And selling them.
I hope he will not sell them, yeah, I don't know. Okay, so now Abraham also went to Reims in the very north of Germany. I mean, you've seen picture with a lot of snow. Reims is also known as Virus Island, and fortunately for us, he let him come today. Paul was also in Germany and in different research center, and he worked on efficient probiotics against liver cancers. And the last Nigerian, but not the least, Thomas. He was with Paul in the same research center, and I'm not sure I will pronounce correctly, so that's the Helmholtz Center for Infection Research, that's correct, and worked on vaccine against COVID-19. So then we have the Tariq K. So Tariq Alam from Pakistan, so it's still Sujan. And Tariq Alam was not able to come today too, and he worked on epidemiology. I hope you have big luggages. From Argentina, but I should say also from Italy, Denise. Denise spent 3 months of her internship alone with foxes, and finally she came back to the real life. That was at ANSES Nancy. So from Bangladesh, so Sujan will come again 3 times. So the first time for him, so he stayed in Hanover, and he worked on adenoviruses, but I will not tell you more since that's confidential. Then go back for Nazneen. Nazneen spent 6 months discovering the zebrafish model at INRAE, and come back for Kabir. Kabir identified early warning signal during infection at the University of Edinburgh, and he has just started a position as clinical fellow in the UK. So now Juliette from Austria and France. And in line with her double bachelor degree in biology and political sciences, she examines the ethical question of massive drug administration for neglected tropical diseases at the MRA. Shivangi from India enjoyed her life in Barcelona and decided to go back there, working at IRTA Cresa on the detection of cigarette toxin in water and fishes. So I think I've made a mistake because I've considered that Jackson was American, but finally he's from Taiwan. So I thought they were both double nationalities. So Renee from United States and Canada. So Renee spent 6 months in Ireland working on bovine tuberculosis and wildlife. And Jackson, who is finally Taiwanese, went to Austria at the University of Veterinary Medicine in Vienna, and he was partially under the supervision of the former and an alumni of IDO, Gabriela, and he worked on pig trade movement and infectious disease epidemiology. So Jackson, sorry for the mistake. Rob from Ireland. So Rob spent 6 months at bioMérieux in France, a pharmaceutical company, and I could not give you any additional details. Annalie from Philippines. She worked at the TOS, the Hanover Veterinary School, and she worked on newly identified viruses. Leo from Germany. Since Leo is from Europe and I spent the 3 semesters in Europe, he said that was better to go and to explore the world outside Europe. So he went to Australia at the University of Melbourne and worked on dendritic cells and vaccines. Yukari from Japan. So perhaps you've seen that she has a very great Japanese dress. And she worked on habits, belief, and local knowledge impacting infectious disease. And finally, Richard from Zambia. So he was also in bioMérieux and he was working on diagnostic methods. So congratulations to all of you. And I think that for picture it will be, oh yeah, perhaps that's, yeah. Perhaps that's better to be on stage.
So before the emotions explode here, I would like to thank the organizers from Tour, Stephanie and Frederic, and all the others for this nice organization of these days and Defense Day and so forth. So please cheer up for them.
Okay, so the tool behind, the small in front. Okay, small.
Where's Nazneen when you need it?
Okay, so for your hat, you will throw them away at 3. So 1, 2, 3, and then you will throw it away. Okay, I count. So Annalie, you are losing your. Okay. 1, 2, 3, go. To celebrate this event, I invite you downstairs, for a drink. Yes, and fortunately for them, all the caps are identical, so they can take anyone.